Hello and good evening, friends. Is my voice clear to all of you out there? Abir, Dalia, Rahma, Dr.
Yes, yes,
Thank you very
clear.
much. Thank you very much for joining in. Welcome, Harshiba Nadra, Dipti, Dr. Sujata Charles. Thank you very much for joining in. I hope you all are doing good, and let's have a wonderful discussion, another wonderful discussion on early pregnancy care today. Thank you very much. So I hope all the participants are here. Yes, we are going to start with Dr. Sabia today, and then we'll have Harshiba. Hi, Dipti. How are you doing? This
I'm
week,
fine.
this week,
How are
thank you.
you?
I'm good. Thank you very much, Dipti. So this week had been a better week than that of the last one. And as I was talking just to one of the students here, I always feel this is not only with you guys, I always feel that whenever the students who have their active participation, they are very active in the mini groups and they are calling every student to be together and practice with them. So this happens. I would just like to make a suggestion at the very start that feel that every week you're presenting. The idea of distributing stations is just because at times you people are busy and there are commitments as well, so that you be available in your live participation. But it does not mean that you get easy in that week. Your preparation of that module should be that when one person is presenting, you at least note down and make your notes and you write down the points. What would I have been at her place? What would I have been doing? And what are the points which I missed and she presented? What are the points that student has done, which I would not have done to be better in this scenario? This is your assessment, and this is going to help you. Okay, so please take these words as an important instruction in your preparation. Don't feel that this module you can manage later. I can understand lots of commitments going on, and in this 1 week, loads of rumors and the telegram was spreading by, and you people were a little shaky. Nevertheless, college has not come to any decision till now. So please keep going. Okay, keep going and keep preparing yourself. Hopefully, when the update would be there, we'll accordingly adjust the schedule as well. We'll accordingly adjust the practice pace as well. All right? Okay, so let's begin with the early pregnancy care today. A quick reminder for all my students today, be a quick reader. A fast reading is very important. Every word, please pick it up. Take your 45 seconds at least to make an outline to enter into the cubicle in a confident manner. So these are the presenters today: Dr. Sabia, Harshiba, Dua, Ramya, Dr. Bindu, Rahma, and Fozia in the end. So 7 stations we are going to do, and then we'll have 4 WhatsApp tasks as well. All right. So the module early pregnancy care. I always tell my students when I used to start my preparation, even if it was my first go, I began with early pregnancy care. Then, when I started my second revision, I began with early pregnancy care. And when it was like the final thing before exam, again, I used to do early pregnancy care at the top. Why? Because generally, I think that early pregnancy care is a relatively easier module as compared to others. Why? Because very common topics are there. The topics which are there are generally easy and are absorbed better. Why? Because we do that in our clinical practice very commonly. Number two, it also happens that these topics, they are less in number, so you get over with this module quickly. So that gives you some sort of satisfaction or some sort of confidence. Okay, so we are done with early pregnancy care. Do you feel the same? Do you people feel the same, that early pregnancy care is easier as compared to others, or was it my feeling always? It's comparatively easier, no? Yeah? Dipti, do you think it's an easier module? Of course, it's very easy as compared to the sexual module. Yeah? So,
Yes,
yes, Dr. Savia.
yes, it's easier actually because
Yeah.
the scenario clinically, whoever is working, we are dealing every other day of our life.
Exactly. So that gives us confidence, and we know the management plans are not very complex in this, as compared to some sort of disease. I mean, you talk about Marfan disease or you talk about pulmonary hypertension. Things here are relatively simpler. But again, there can be a little twist and up and down in the stations, which we are going to discuss today. And we'll see that how far we can deal with the easier stations in a better manner. This module should be your at least 90% and above module for the exam. It does compensate for those topics which are difficult. So when there's an easier module, your preparation should be perfect so that in that module, at least you cover up the other little difficult stations which come in exam, where chances are that you go a little less than pass or borderline in that station, so that these stations, they can compensate for them in your complete result. Okay, all right, so the topics are less in number: molar pregnancy, ectopic pregnancy, the threatened miscarriage, the missed miscarriage, the recurrent miscarriage, the failure of the treatment of miscarriage as well, the pregnancy of unknown location, hyperemesis gravidarum, determination of pregnancy, unwanted pregnancy with intrauterine Cooper device. That's one of the station in the Oxford. I took it from there. So these are the complete topics from this early pregnancy. That's it. So early pregnancy is done. We do know that there are RCOT patient information leaflets, and we've got NHS patient information leaflets for the ones for which we do not have the Royal College information leaflets. We did discuss about the early pregnancy based template last time, and you know that if the complaints of bleeding would be there, what questions you need to ask. If it's a pain as a complaint, what questions you need to ask. Try and avoid going through if the patient is uncomfortable. Please make her comfortable. If she requires some painkiller, do ask her that if she requires that, and rule out the allergy as well. And are you okay to continue? So seek her permission and then begin with a consultation. Generally, if it's a complication, avoid congratulations. Otherwise, yes, we do that in our daily antenatal care routine with the patient. I'll guide you in the template in the end. But when it's a complication, of course, you need not congratulate, because you are coming to the management in terms of ending up of that pregnancy. So always remember this point and keep in your mind. If it's vomiting, again, you all know what questions you need to ask. Some general questions regarding the well-being of the patient. You need to ask about the folic acid booking test, if at all it's been done. You come to the obstetric history, the gynecological history, the medical history, the family, surgical, drugs, allergies, personal, social, mental health. If you think it's a breaking bad news, go with that. And if you think it's something which she knows earlier or she's aware of the diagnosis, just make her comfortable and move with the management plan according to the cause. Do ask if she has some other concerns which you need to address, and the closure is going to be according to the admission and arranging the follow-up if she's a stable patient. So this is how we move with the early pregnancy care. And now we have to begin with station number 1. And can we have Dr. Sabia here? Hello, Dr. Sabia. Good evening.
Good evening.
How are you?
Fine, Alhamdulillah.
That's very good to know. Okay, so we are going to start with Dr. Sabia first, and then we'll have Harshiba in the row. Okay, so let's see, what do we have for Dr. Sabia? And the 2 minutes for Dr. Sabia, they start now. So 4, 3, 2, and 1. Please take your time.
Okay. Okay, next. Okay, I can start.
Yes, please.
Hello, I'm Dr. Sabia, one of the doctor in the clinic today. May I confirm your name and age, please?
So, hi, doctor. Doctor, I'm Ellie Wilson. I'm 26 years.
Okay, is it okay if I call you Ellie?
Yeah, okay.
Okay. Ellie, I can gather from your notes that you are pregnant and you are here to discuss your scan reports and the blood test what already done. Is that right?
Yes, doctor, but before that, I've been waiting for 30 minutes outside. I mean, this is normally what's happening with the patients here.
I'm really sorry for the delay because clinic is running very busy. So for that reason, it's quite little late. But I apologize for the delay, Ellie.
I understand, doctor, but if the clinic is late, you should ask for more help. I mean, more doctors, every patient. I saw a patient outside who was waiting for like more than 1 hour.
Yeah, sure, Ellie. I will raise your concern to the managing department. What can we do in the future so that there will be no delay for the patients.
Thank you, doctor.
So, Ali, sure, I will discuss with your reports and I will formulate the management plan. But before that, would you like to ask you questions? Is that okay?
Okay.
So, can you tell me about your pregnancy?
Yeah, I'm not happy with that, doctor. We were practicing condoms. I don't know, they didn't work. And I just came to know that I'm pregnant. It's around 6 weeks I am. And I'm very unhappy. I want just ending up of this pregnancy. I just underwent a scan. I was having a little discomfort in my tummy. And I just want
Mm-hmm.
that this pregnancy ends up. I mean, give me some medicines or something so that I end up with this pregnancy, doctor.
I can understand your concern, Ellie. Sure, I will address your concern. But I would like to ask you a question before talking about your concern.
Okay.
So, is that okay?
Yeah, that's fine.
Can you tell me more about your pain or is there any bleeding?
The pain, it's not exactly pain, it's a little discomfort as we feel as in periods, a crampy feeling in the lower tummy. And no bleeding at all at the moment.
Mhm. Do you feel any dizziness or fainting attacks at home?
No, no,
Any shoulder tip pain?
no,
Any bleeding? No spotting or brown
not,
discharge?
nothing, doctor.
Mhm. Have you been pregnant before, Ellie?
No, this is first time.
Mhm. And are you using any contraceptives?
That said, we were using condoms, I told you, but I don't know what happened.
Mhm. Okay. And what about your periods? Are they regular?
Yeah, the periods are fine. I mean, 6 weeks back I had that.
Ellie, do you are you otherwise healthy?
Yeah, I don't have any problem, doctor.
Are you on any medication?
No, I'm not taking any.
Any surgery done on your tummy and down below?
No, doctor.
Are you allergic to any medication?
Yeah, I'm allergic to penicillin.
Okay, I will note it and I will in your file as well. Okay,
Thank
Ellie.
you. Mm.
Do you know your blood group, Ellie?
Yeah, that's O positive.
Mhm. What about your smear? Is it done?
Smear, yeah, one smear done last year.
Is there any history of blood clots in your lungs, legs and lungs?
No, no, nothing like that.
Okay, Ellie, please don't mind me asking some few personal questions.
Mm-hmm.
Is there any history of treatment for the sexually shared infection?
No, doctor.
Mhm. And Is there any family history of family concern in your family?
No.
Mhm. What do you do for living?
Yeah, I work as a teacher.
Mhm. And is your partner supportive?
He is, yeah.
So you are living with your partner.
I am, yeah.
Mhm. Do you smoke, Ellie?
Very occasional, but I guess I do smoke.
Mhm. Okay. And what about alcohol and
No,
recreational drugs?
no, doctor.
Ellie, in the last few days, have you ever been bothered by feeling low, depressed, and hopeless?
No, doctor. I'm otherwise happy. It's just that we are not ready for the baby at the moment.
Yeah, I will address your concern surely. I want to examine you in the presence of chaperone with your consent, and then I will discuss with your reports.
Okay.
Is that okay?
Yeah, that's fine.
Yeah. Let's discuss with your reports, Ellie. I have your reports
Mm-hmm.
of your blood pregnancy hormone and your scan. I confirm. Let me confirm your name, Ellie Wilson, 26 years old, and NHS number 7434381. And according to the report results, your hemoglobin is 13 gram per deciliter, it's normal, and your pregnancy hormone is 1020. And regarding your ultrasound report, uh, Ali, you are alone today.
Yeah, I just came here with the driver.
Do you need any support?
No, it's okay.
Or
Please go ahead. I just don't want this pregnancy. It's fine. Yeah.
okay, Ali, sure. I will discuss your concern. Sally, according to ultrasound report, no, there is no your pregnancy in your womb, and there is a very small cyst in your right ovary, and that's it.
So the pregnancy is where?
Ellie, let me explain to you.
Mm-hmm.
I will draw it for you. See,
Mm-hmm.
this is a womb,
Mm-hmm.
and these are the tube, and these are the tubes. Okay,
Okay. Yeah.
what happened? Usually, pregnancy form in the tube, this
Yeah.
area of the tube. Yeah, like a sperm, your husband sperm and your egg combine here in is this area, and
Hmm.
then after make starting of the baby, they travel towards the womb, and they get attached to the womb, and the baby grow inside the womb, and then we have a baby.
Right.
Are you getting me, Ali?
Yeah, I am. So that's what my understanding is. It should be inside the womb, right?
Okay, yes, but it takes little time from making hair and to going towards the womb and attaching and starting to grow. It takes little time because
Uh,
pregnancy is a dynamic process. So, in your situation, it seems like that we call it pregnancy of unknown location. Are you getting me, Ali?
I get that. So it's like it is inside the womb at the moment, but we cannot see that. Am I right in getting
Yeah,
that?
yeah, you are right. There are three possibilities in this situation.
Mm-hmm.
Either it's a very early pregnancy that is
Okay.
very small, it
Mm-hmm.
cannot be visualized,
Mm-hmm.
but with time it will grow and we can see it. Number
Okay.
one possibility.
Okay.
And number two, second possibility is either it's a failing pregnancy,
All
okay,
right.
and
Yeah.
with the time, if we see it, it will there will be nothing because it's a
Mm-hmm.
failing pregnancy. The
Mm-hmm.
third possibility is somehow very important for you to know that it can be a ectopic pregnancy. Do you
Mm-hmm.
know about ectopic pregnancy?
No, I don't know that, doctor.
Okay, let me explain to you. What happens where the pregnancy is formed in the tube? Sometimes, for some abnormality or some situation, it cannot travel towards the womb, and it gets implanted there in the tube. And the tube is not that much big. With the growth of the pregnancy, it become big, and then it can ruptures with a life-threatening bleeding.
Uh-huh. So you think that it's in the tube?
It can be a possibility, Ellie. I cannot be sure because I'm sorry I'm giving you this
No, I get that, doctor. So
uncertain.
how would we be sure? I mean, what to do now?
Yeah, we have to repeat your pregnancy hormone after 48 hours.
Mm-hmm.
Okay. And if it is significantly increased, then it's quite reassuring that your pregnancy will be normal, ongoing pregnancy. And we will see it when the pregnancy hormone will be more than 1,500, then we will be able to see the pregnancy inside the womb.
Mm-hmm.
And if it is significantly decreased, then it's again reassuring that it's the ending pregnancy, failing pregnancy.
Okay.
And in between, if it is not significantly increase or decrease or stays the same, then there is a possibility that it can be ectopic pregnancy.
I get that right.
Mm.
So I would just want to end up the pregnancy. So can you help me now? I mean, give some medicines wherever it is. It would be just finished. No.
Uh, Ali, as there is a possibility of ectopic pregnancy,
Mm-hmm.
I can give, if I give you tablet and it's a ectopic pregnancy, it will not add with the medication.
Oh, okay.
And an ectopic pregnancy, as I told you, this is a something very serious because the tube pregnancy will grow and tube can rupture with a life-threatening bleeding.
Okay.
So I'm giving you appointment after 2 days to repeat your pregnancy hormone,
Okay.
and we will see how the pregnancy hormone increase. And I will be giving you appointment with the consultant also, that after 2 days you can discuss with your further management. And if the and in between you have to check if you have severe abdominal pain, any shoulder tip pain, any dizziness or any fainting, please contact immediately. I'm giving you contact details.
I get that, doctor. Okay. So I'll see you after
Okay,
2 days,
Ali?
right? Yeah, yeah, I understand. I'll see you after 2 days with the pregnancy hormone fresh report, right?
Yes, yes, Ali.
Ah, okay. Okay, I get that, doctor. Thank you very
Thank
much.
you, Ali. Thank
Yeah.
you, Ali.
Thank you.
See
Thank
you, inshallah.
you.
Okay.
Okay. Give me patient information leaflet.
Yeah, yeah, I'm giving you patient information leaflet.
Yeah. Give
You
me
can read that and you
so that
can,
I can take that point. Okay. Thank you very much. How was it, Dr. Sab?
I don't know I don't know what I did.
No, you just need to know the good points as well. Hello, Group A. Where are you guys? How did Dr. Sabia do? Hello, Rehma. Yes. Dr. Sabia, tell me the good points you did. The first thing ever to appear in this exam is having confidence, right? So be
Yeah.
confident on the things which you did right. So I want to know that what good things you did. Come on.
Okay.
Yes.
Okay. Okay.
Yeah.
As
Let's
you know, as my colleagues who practice with me, they know that I'm not at that level of confidence. I'm trying to get that level of
very good.
confidence.
You'll be very perfectly all right. I have started with
Inshallah.
people who were very low in the confidence and in the language than you. So I won't grade you at 100% of course, but I won't grade you less than 50 even. So you are in the mid and you'll definitely reach the upper. So the traveling
Yeah,
percentage
inshallah.
is from 50 to 100. That's it. So you're already
Yeah,
at your mid, my dear. Okay. So tell
yeah,
me the good
inshallah.
point. Yes,
Inshallah,
yes.
I will
Tell
try
me
my
the good
best.
points. Yeah. Yes. What did you do good in the station? How was the introduction? How was the information
Actually, I
gathering?
think
Yeah.
I was not that much confident in the history.
Okay.
Still, I have to make a very confident and very
Yes.
fast
Yes, I'll tell you.
history
Yes, I've
taking.
noted this point. We'll definitely guide you, and you'll send me the records on that. Maybe one record of 3 minutes, maybe alternate day of information gathering, so that it becomes a little quicker. That was the
Yeah,
reason
little
you knew.
quicker. Yes.
Yes, yes, we'll work on that. That's not a problem. So
Yeah, inshallah.
it comes with practice, one after the other, speedily question, because you were taking pauses in between. That was you were thinking about the next question. I
Yeah, yeah,
want
yeah.
that. Yes, yes.
That's my problem.
I respect that.
I will try. I'm trying to recover. I'm trying to overcome that.
Yes, and definitely
Inshallah, I will do it.
I'll tell you that how we are going to do that, okay?
Yeah,
The only
inshallah.
thing is that one after the other, the question should come into your mind and you be a little quick. That was the reason you knew the management plan but it was like after the bell rings. So, we were 1.5 minutes over time. So we'll
Yeah,
cut
yeah, yeah,
that 1.5 minutes from our
yeah. Hmm.
information gathering. Okay,
Yes, yes, yes,
right?
yes.
Okay. So, yes, history took a little time, Rahma, you're right, but explanation was very good. Tell me what points you think, other than the history, you noted that you were having a little difficulty at?
Sorry.
Other than history, any other point where you were having a little difficulty at?
No, no, only I know my weakness, history.
Okay.
I'm working on it.
Yeah, so we'll be speeding up that. Okay. Now, yes, Vernadra, she had a very clear explanation. You were very clear about pregnancy of unknown location, what it is. And it was like, you know, any senior person teaching to like junior colleagues, because I know that you're a very senior consultant and practicing for many years. So I'm not worried about your applied clinical knowledge at all, Dr. Sabia. I know that it's perfect. But the only way is we should be having that beautiful communication as well, that what we know, we are able to communicate that as beautifully as we know that. So we just
Yes,
have to
yes.
transform into that thing that yes, we know the things and we are going to communicate that in the same level so that the scorecard goes rise up. Okay.
Yeah, yeah, inshallah.
Yes, very good. Okay. So let's begin with the feedback. Whenever you read the station, please, and whenever you people have this any sort of a delay in the clinic, or any sort of consultant away from the consultation could not be done by the consultant, always remember to begin with the apology. Don't give an opportunity to the role player to come up with the anger, because if you ignore that, that means you're taking for granted. I mean, they should understand that it's happening, so it should not happen. So bring up your apology first and then come to the agenda. Okay, this
Yeah,
is first
yeah.
point.
I
Okay.
should do that actually.
Yes, yeah. So always remember, everybody has to do that. It's not only for Dr. Sabia. Please, all of you remember that whenever there's something in one station, they'll put something like that. Either the consultant is not there. So begin with an apology for the consultant. If the clinic is delayed, so I'll tell you that how you have to speak rather than saying that we are having a busy clinic. It is not patient's fault. Okay. So before that,
Yes,
let's
yes.
see what good points Dr. Sabia did. Your introduction was good. Your agenda making was good as well. A little fumbling is there, which with passage of time you'll feel would be perfect. Till
Yeah,
fourth and
inshallah.
fifth session, you'll see a change in yourself. Okay.
Inshallah, inshallah.
Then information gathering, it started with the open question. That was very good. I gave you a star on that. You asked about the pain, feeling dizzy, that is ruling out all the ectopic signs, which was very important to patient safety in pregnancy of unknown location. Then you did ask about the obstetric history, the contraception, medical history, the medications he's taking. You noted down the allergy. That was very good. Last time you people missed this point. This time you did document the allergy. I gave you a star on that. Then you asked my blood group. That was very important patient safety. You did that for an early pregnancy care. You did a sign posting. Again, I gave you a star on that on STI history. Family history, smoking, alcohol, the medical history. You did examine me in the presence of a chaperone. Again, it was a very good point. I did give you a star on that. Investigation. Investigation, you told me that hemoglobin and the pregnancy hormone test, they are the results. I'll give you a little better way of doing that, but however, it was a good way that you did tell about the findings of the investigation. Then about the explanation, you did a little sign posting. That was good to prepare the patient, and I'll tell you that we can omit the sign posting in an unwelcomed pregnancy as well, but giving sign posting always makes you safe in exam. So that was good that you did a little signposting to try to patient to understand that thing. Then your explanation of the pregnancy of unknown location was fine. And I had to ask like where it is, and you were explaining the things that you know neither inside the womb nor outside the womb, and the three possibilities. That was beautiful. The best thing which you did in explanation was that you did not name the percentages, that it's going to be more than 63%, or it doubles up, then it's going to be a normal pregnancy. If Dr. Sabia would have done that, friends, I would have corrected that, because it makes patients confused that, you know, it's falling down more than 13%, or it's rising more
No,
than
no,
60%.
we already
Very good.
discussed, Dr. Sidra.
Very
Patients don't understand how much it will fall
very
down.
good. Well done. So this is a very good point, please. Few of the students, when they do this station with me, day before yesterday, one of the Malaysian student was doing this station with me, and she was telling me that if after 48 hours, more than 13% would be the fall, we'll do this, less than 13%, and I was confused as a patient. So patients don't require this. Remember, patients just want that what is going to be the interpretation. So you say, if it's doubling up, the pregnancy hormone is doubling up, or it is significantly rising, that means it's going to be an ongoing healthy pregnancy. If it goes
Yes,
as a plateau, or it doesn't rise significantly, neither falls, we assume that it might be a pregnancy outside the womb. Or if
yes,
it's falling significantly, it would be a pregnancy failure. So this is how you explain that, and your job is done. You need not go into all pregnancy of unknown location TOG article table. Okay, you need not go into, but yes, if it's a structured discussion, then it is very important to tell the exact percentage, because as a doctor, you should be knowing the interpretation. But patient just requires to know that how the things would be. So significantly rise, not rising or staying at a plateau, or significantly falling down. So these three terminologies are enough for patients to understand. So this was a very good point. Then before ending up, though it was after the bell rings, but at least you gave me red flag signs that I should be knowing that what are those things for which I have to come back to you immediately. So that again was very good. So if I enumerate that, I've got around 10, 15, 20 good points, Dr. Sabia. So nothing to have lack of confidence at all, my dear. Okay, these all points were very good. Now we are going to see that what are those things together which we all are going to improve. Okay, the first thing which I expected in the start was that you'll enter into the cubicle and you will say that hi, I'm Dr. Sabia. I'm one of the doctors in the early pregnancy assessment clinic today. So may I confirm your name and age? Ellie Wilson, 26 years. Is it okay I call you Ellie? Ellie, at the very outset, I would like to apologize that the clinic is running late today. Some unavoidable reasons. We are looking into the matter and we'll ensure that it does not happen with the patients in future. Accept my apologies. Sorry for the inconvenience today. Okay.
Yes.
Okay,
So my one number gone already.
No,
huh?
no, sweetheart. You covered it up when I came with the anger. Beautifully when you said that sure, we'll raise your concern and we'll see that it doesn't happen again. I wanted to listen to this thing.
Dr. Sidra, can you repeat that again?
Oh,
Dr.
yeah,
Sidra,
sure.
repeat that again.
Yeah,
Yes.
it was actually spontaneous. Maybe I'll come up with some other thing now, but if it's a change of word, you can listen to the recording. Okay?
Yes,
Whatever you find
yes,
best.
yes,
So
yes,
how I'll go is that
yes.
Ellie, at the very outset, I would like to apologize that due to some unavoidable circumstances, the clinic is running late today. We are looking into the matter so that it doesn't happen again. Sorry for inconvenience today. Okay, so my point of view is don't give her an opportunity to be angry. Another important thing is, Dr. Sabia, the right way to have an apology is not that clinic is busy or your consultant or your doctors are on leave. See, this is not patient's mistake. It is the hospital department who has to give working hands. Am I right? So that's why I said that you should call help from more doctors if it's busy. So don't give this opportunity or give excuse to the patient, right? What you have to say is, so what is the ideal way? My way of doing an apology is that due to unavoidable circumstances. So what are those? Neither, if it's like less doctors, if it's like consultants not there, or we have given some, unfortunately, some more appointments which we cannot handle today, anything like that. But don't give the reason, because any reason you're going to give, it's not important for the patient. We should handle our reasons ourselves. So just cut the point there, okay? So ideal way of saying is that due to some unavoidable circumstances, it is a delay today and we are looking into the matter. Remember, friends, doing an apology does not settle the patient only. Yeah, saying that we are looking into the matter so that it doesn't happen again, yes, that is the right way of settling an anger in the future. At times, role player from the very start says, no, it's not fine. I want to launch a complaint. Always say, I agree. You have the right to do so. I will connect you to the pals and you can escalate the matter. I will help you in that, Ellie. I'm just telling you if at all role player has been instructed to do so. Okay? Pallavi, have you written, my dear? Pallavi, sorry, I just saw your message, sweetheart. Is it written?
Even I want to write, but I will write when I will listen the recording.
Just after 3-4 hours for the conversion, I'll update the recording, and tomorrow you people have a complete day to upgrade your templates. Okay, yes. Thank you very much, Pallavi. So all these things, and this doesn't go for this station, any station where some, you know, I'll
Dr.
give you
Sidra, you said they'll connect you to the PAS, right? The patient
advice liaison service. Yeah, Divya. Okay.
Translation. All right. All right.
So another important thing is that in exam, I mean, in my, I was in Nottingham and there was a station that which said that the patient is very angry that it's been 2 hours she had been searching for the parking lot and she couldn't get the parking, and it was outside the cubicle. So I knew that this is something like she's going to be a little angry on. So I started with the apology in the same things, like this is the way. I said the same lines and said that I can understand. I've been informed that it took you time to search for the parking, and we are looking into the matter. Administration has been informed so that we can ease and provide you the comfortable parking in time. So anything like that, but do it in the start. Otherwise, this anger would keep on going, Divya, in the entire station, which we cannot afford because we want a good repo building. Okay, so this is something which you all have to remember. Any sort of uncomfortable starting would ruin your station. I asked myself for the apology, but Dr. Sabia managed that well, so I was happy on that. But I expect you guys to start from yourself rather than me telling, or a role player telling you that please apologize, something wrong has happened. Okay, when done. Okay, second improvement which we have to make is in information gathering. That it took around 6.5 minutes. I'm sure with practice, one after the other, the question they come. So the pauses in between the question we have to decrease, Dr. Sabia.
I will do, inshallah.
Very good.
I will practice.
So we are going to decrease that and bring it to 4 minutes time so that we have an ample time for the management. Okay. The third thing which I've written is that during the history taking, what made you ask about the blood clots?
Yeah.
I mean, did you have anything linked in that, or were you thinking that maybe I'm not getting that? That's why I'm asking, because I could not see any relation of asking about, or are you asking about because of the thrombophilia, something like miscarriage, or it just went out spontaneously, or it went out spontaneously at that time?
Yeah. So yeah, that's actually Dr. Sidra. That's we are discussing, and in my mind also,
yes,
we have a template, which question need to be asked. But in some stations like this early pregnancy module, we should not ask actually. I'm thinking this family history is not that much relevant.
Okay, I'll tell you. Family history, you say, may I know any family history of concern you would like to inform about? About the blood clots, specifically if you want to ask, that would be a valid question, Dr. Sabia, in a recurrent pregnancy loss. Okay, in any patient who is having some sort of abruption previously or thrombophilia, you want to rule out.
Yes.
Right?
And antenatally, an antenatal module.
Antenatal, not in all cases, but yes, when there are risk factors or bad obstetrical history, yes, then you need to ask. Okay? So these questions specifically, otherwise you'll just formulate an open question. Any family history of concern you would like to inform me about?
We are waiting for your class today to know that which should be asked and which should not be asked.
I'm grateful.
And see, you are explaining the same thing.
Yeah, I understand. Dr. Sabia, I always listen to each word. See, I had been given a task by the organization to give an open, 3 open stations for 1 week in the guide group. And, I had to be so superficial. Of course, when you don't take your responsibility and you can't guide any person because it feels bad that, you are pointing out each and every point. But here I am responsible. Why? Because I have to train you guys. It is like that a systematic improvement should be there. One odd person who will be given like a feedback by me or in a free telegram by somebody else, or then a third person, they get scattered because everybody has his or her own way. So what I want you to know is that this is going to decrease or shrink up your time, because we want that we have a good time management in the applied clinical knowledge as well. Okay, so just avoid this question, my dear, and just put this question only in the cases where we suspect thrombophilia. Okay, when we suspect thrombophilia. Okay. Now, another point which I had to, otherwise the history went okay, examination part was okay. Now coming to this point, please. I want all of you to concentrate here. Patient doesn't need to know what 13 is or what 1020 is, right? You just have to tell that I've confirmed your name and NHS number, Ellie. I would just like to tell you that your hemoglobin is normal and the pregnancy hormone report is done as well. However, the ultrasound, 1020, even if you miss telling the figures to the patient, it's okay.
She don't understand. Even I was thinking the same, Dr. Sidra.
Exactly.
So I should tell or not?
Exactly. So skip the numbers telling to the patient, please, because numbers, they don't matter. But yes, hemoglobin is normal. That matters a lot. right?
Yes, yes.
So ultrasound
Okay.
impression.
So no need to repeat the name, like this is the name, this is the age, this is the NHS number.
No,
Only
Dr. Athiya, don't repeat. Just say, confirm, I have confirmed your name and NHS number.
Okay.
Okay.
That's
That's
it.
that's
Because
right.
it takes your time, Dr. Athiya. It takes your
Yeah,
time,
yeah.
right? So just avoid that. Your patient safety is that, yes, the patient you're talking to, the same report is in front of you. That's it. So even don't repeat the NHS number, my dear. Just say that I've
Okay.
confirmed your NHS number and that's your report and it says, and then go to the report. Okay. Now,
Okay.
avoid telling the numerical figures to the patient, like a husband semen analysis. If it says like 2,000 something sperms or something, don't say it's 2,000. Say where it lies. Is it normal? Is it subnormal? You know, tell the interpretation to the patient in investigations. Don't quote the figures, because quoting figures makes her confused. Or she would say, what does it mean, doctor? Is it normal? Okay, it's normal. So that's sufficient for her. Okay, so avoid using the numbers. It doesn't go for this station only. It goes for all the stations in which I would be providing you the investigations. So tell the interpretation. Always remember, don't quote or tell the figures to the patient, because it puts her into confusion. Okay. Now about this, my overall suggestion was the management plan was very good. Explanation, I'll just speak again just for your ease, that how I would go. However, I was happy with that. Yeah, one more point. When you explained to me the pregnancy of unknown location, that was all right by drawing diagram. But again, when I came to the ectopic pregnancy, you said, do you know about that? So that is a separate agenda. You again started drawing and telling me that, you know, if it starts growing in the womb. So you can decrease your time spending on that part. You can simply say that, yes, it is a pregnancy which is not inside the womb and it starts growing outside the womb. Go to the recording, Dr. Sabia, you'll feel that around 45 seconds were taken to explain the ectopic pregnancy as well. So it is not the agenda today. Yes, it's a
Okay.
possibility. That's it. So drawing diagram once, why do we do that, Dr. Sabia? We do that because we have to get marks. Now, drawing it twice in a station will make our time management a little trouble. So,
No,
you know,
actually,
what
Dr.
are you doing?
Sidra,
I'll tell
I'm
you.
thinking that
Yeah.
I'm thinking that I'm giving her a diagnosis of pregnancy of unknown location, and it can end in ectopic also.
Yes.
So I already draw the picture. So I'm just telling that, see, this is what I already
So
drawn.
I'll tell you. So don't start again, starting from the tube and the sperm. So again, you were starting from zero. You say that if it doesn't go back inside the womb and get attached there, it starts growing inside the tube. We call it as an ectopic pregnancy. So just take story from there. So at least your little time is saved. Okay. So because second time you again started from the conception and, you know, the whole thing again. So I wanted a little, because I was looking at the clock at that time. So I wanted a little squeezing of time at that part.
And doctor, what should be the order of explanation? Like first we should explain the ectopic and then go for the normal one and then for the miscarriage. And
no. What I would say is that see, I've confirmed your name and NHS number, Ellie, and your blood reports show that your hemoglobin is normal. However, the ultrasound reveals that we cannot find out the pregnancy either inside the womb or outside. Ellie, when the pregnancy test is positive, but the pregnancy cannot be seen on an internal scan, we call it as the pregnancy of unknown location. Am I clear? Ellie, I would just like to tell you that there can be possible reasons, like the pregnancy in the womb, it is way too early to be seen on scan, or it is a failing pregnancy, it is already a miscarriage, or the pregnancy is outside the womb, but is again too small and too early to be picked up on a scan. So these three ways would be my possibilities telling about the pregnancy of unknown location. You can add on that what we are going to do, because, you know, then Dr. Sabia took a pause and I was waiting for the management because I was looking at the time. If you allow, I can tell you about the management plan. So how we deal with these pregnancies, Ellie. So lead the role player, because you've got less time. You have to finish up your applied clinical knowledge, right?
And what about this right of variances?
Yeah, that's fine.
So how we will?
So very small actually.
You just have
I did
to say,
not bother.
Yeah, you don't have to bother. Why? Because at the time of this, it is just like a luteal cyst. You can simply say that there's a light fluid-filled cyst in the ovarian, but it is
But need to mention or not?
Dr. Atia, if you mention, it's fine. If you don't mention in the management plan, it won't make any difference. So it's okay, even if you skip that. Okay. Now, I would just like to tell you, Ellie, that how do we move forward from this point of time? The pregnancy hormone and the progesterone hormone can guide us in this regard. If you're well enough, you can be sent home. But if you think that you're having increased pain or bleeding, we suggest women to get admitted. Now, what you have to come back with a fresh pregnancy hormone that is 48 hours from this pregnancy hormone test. And this is going to tell us that how the pregnancy is moving forward. So now you can tell about these significantly rise, having a plateau, or significantly decrease. So this is the only plan. Now I told Dr. Sabiha that I want it to end up. So please give me something. So here you just have to say, Dr. Sabiha, you immediately said that I told you about the ectopic pregnancy. So it can be dangerous and we have to go for the surgical method. If I come up with a concern, you have to say, I respect your concern, Ellie. Okay, so the first thing you have to say is, I respect your concern, and then come to the concern. Remember, make it a habit, all of you, please. Make it a habit. If I say, doctor, please give me the medicines, immediately you people start answering like, no, it cannot be done. The other way is, I respect your concern, Ellie. However, I would like to tell you is that we require to know the location of the pregnancy, because the ending up of pregnancy inside the womb is different outside the womb. So first step is to locate the pregnancy, and definitely you would be respected in your wish and your desire. Would that be okay?
Yes, you are right. Yeah.
Got that? How you're going to deal with the concern? Yeah? All of you, Bindu, Pallavi, Leah, Divya, everybody got that? That how you address the concern. This is the right way of addressing a concern. First, respect that. However, then come to the point. Okay, very well done. Great. Go. Okay. So this is how then you have to tell about the red flags, that it is very important that you remain well, Ellie. If you think that the tummy pain is getting worse despite the painkillers, if you think the bleeding is heavy, or if you have pain in the shoulder, feeling lightheaded or dizzy or fainting, please see us without any delay. So this is 24/7 hospital contact number, and this is some information leaflet to give you the information for what we all discussed about today. So now your station would be ending. Beautifully done station, Dr. Sabiha. Only we'll work upon the time management, and we'll work upon squeezing our information gathering so the management doesn't go beyond 10 minutes. Okay, so you were very clear about that. Let's see what I'm here with you guys about the key of the examiner. The communication with the patients and the relatives. Yeah, apology in the beginning. Remember, you have to do that. If empathy has to be there. So if she requires painkiller, that's fine. But today I was saying that it's just a discomfort, so it's okay. And match the tone to the role player. Always remember, this is a tip from my side. Role player is down or sad, don't be very cheerful or loud, okay? If the role player is very happy and cheerful, don't be very serious. So in either of the ways, just match your tone to the role player. So the questions were fine, obstetric history and the general history, the pain, discomfort, that was all right, but a little time we took, so next time we'll just work on that. The patient safety, mild signposting was done. I didn't require to ask for the PALS, but if it was there, you should do that. Red flag signs, they were told about Dr. Sabiha, that was very, very important, patient safety. When we come to the applied clinical knowledge of pregnancy of unknown location, you just need to tell about the possibility of ectopic pregnancy. No need to mention the percentage, but it's just for your knowledge. It can be a failing pregnancy. It can be an ongoing live pregnancy inside the womb, but it's an early pregnancy, therefore is not picked up in the scan. If she decides again and again that it's an unwelcome pregnancy, please speak one line as I did. So your decision of ending up of pregnancy will be respected, Ellie, after the location is diagnosed, and we will treat it accordingly. Would that be okay? So this is her concern. And your concern is that first we find out the location, and accordingly we are going to end this pregnancy up. Okay? So this is one line which you can speak to satisfy her, that it is going to be respected, that ending up of pregnancy if she wants. Now, in exam, in 2019 November, basically the question came when the patient was stable, right? If the patient is stable, this was the part which we had in exam. Hemodynamically stable patient with a pain-free station. So yes, expectant management and repeating the pregnancy hormone at 48 hours is your management. But I brought this table from the talk article. If the patient is stable but with pain, you can do the pregnancy hormone according to the condition, but you may consider keyhole surgery as well. At the same time, friends, if hemodynamically unstable patient is there and having pain as well, then you have to consider surgery. Remember this part because it's a possible ectopic and a ruptured pregnancy, okay? Now, because it can be a structured discussion as well, because when I was solving the station for all of you, there's a disparity, and even my part 2 students, they have a little confusion in solving the EMQs. This is from the Pregnancy of Unknown Location talk article, that changing in the pregnancy hormone, if it's more than 13%, it says that you do in 2 weeks the pregnancy test, and it's less than 13% decrease, you just repeat the HCG on day 7. More than 66% increase is going to be normal intrauterine pregnancy, and you repeat the internal scan after 7 days. And if it's less than 66% increase, it's a probable ectopic pregnancy. Again, you repeat the internal scan. But there's a disparity between the talk article and the NICE guideline. So here, if a structured discussion comes, it's not for an SPT, but I have to tell you, if a structured discussion comes on pregnancy of unknown location, you have to follow the NICE guideline. Why? There was a college course for the EMQs, and many of my students, they attended that course. In that, there were EMQs following the NICE guideline because it's year 2019, it's a recent guideline. The talk article was not followed in that values. So you just need to remember that the NICE guideline says that for a woman with an increase in pregnancy hormone levels greater than 63% after 48 hours. I'm saying again for a structured discussion, please. So that you're going to tell her that it's generally, possibility is that it's going to be an intrauterine pregnancy, okay? And you repeat the internal scan in 7 to 14 days later. Again, the NICE guideline says, friends, that if there's a decrease in the serum HCG levels greater than 50% after 48 hours, the chances is that it's unlikely to continue. So it's a failing pregnancy. And it says that a woman with a decrease in serum HCG levels less than 50% or an increase less than 63%. So now this is the pregnancy for which we are having concern. So she has to be reviewed within 24 hours in early pregnancy assessment service. Okay, thinking about the topic. So why did I bring the screenshots from NICE guideline and the pregnancy of unknown location? So that in exam, you know that from where are we talking about. The memory is always better when you say that from where are they bringing up the questions in the college. Okay, so in exam, there's a disparity between an old talk article and the recent NICE. So follow the recent NICE in terms of the percentages, if at all, it's a structured discussion. Am I clear, friends? Am I clear, friends?
Yes,
right?
doctor.
Okay,
Yeah,
thank
yeah,
you very
very
much. Thank
clear.
you.
Hello, Dr.
Yes,
Sidra.
right. Yes, please.
I have one concern in my mind. If the patient is adamant to end the pregnancy despite of the fact that we cannot find pregnancy anywhere, so this is also mentioned in NICE abortion
Yes.
care guideline that we can give her the option of
Can
termination and
consider.
with signposting of this thing.
Yes,
That
yes.
if it is ectopic, and then she will have trouble with that.
Yes, very, very nicely said, Sarvat. There's a line in the NICE guideline which says that if the patient is adamant with pregnancy of unknown location, saying that I want termination at any cost, so you can consider doing that a medical termination, right? And telling her, if at all there is no expulsion of the pregnancy products, then we might consider, or you have heavy pain or bleeding, then it might turn out to be a pregnancy outside the womb, then we will deal accordingly. So if you think in a station this level comes and she's not ready to go back and repeat the 48-hour thing, you can consider that this is the last option, Sarvat. Absolutely right, my dear. Okay.
Okay.
Pregnancy of unknown location, how I'm going to distribute myself into my 10 minutes would be starting with the introduction, settling the complaints if the patient is having, make an agenda. Of course, before that, if there is some sort of apology required, I'll do that. Make an agenda, a quick focused information gathering. I'll do signposting if required. If she's already unhappy, it's okay. You can skip that as well, but it always makes you safe. Management I'll do, and then respecting her wish for termination, speak one line which makes her satisfied that whatsoever would be the result, me and my team of doctors are going to support you in your decision for the ending up of pregnancy, Ellie. Okay, so this is going to settle her that it's not that we are gaining time, that it goes, the healthy pregnancy keeps on moving forward. We are gaining time to find the location and deal accordingly. Before sending her back home, don't forget the red flag signs or else you fail your patient safety. So wonderfully done by Dr. Sabia, the red flag signs, and follow her up after 48 hours of the pregnancy hormone and see what is the pattern of the pregnancy hormone. This is how you distribute your 10 minutes time and you do it a wonderful station. Thank you very much for a very good start, Dr. Sabia. And I'm sure next time we would be better than this. So graph if it's rising. So we are going perfect, remember. If
Inshallah.
every other station is better than the previous one, again, I would say, you know, many of my students who are doing the activities, right? If I sometimes will make you share their first station with me, so you'll have so much of confidence, Dr. Sabia. Okay, so I'm not bad. So whenever Sarwat, Dr. Atiya, Rahma, and Sarwat, my other Sarwat from UAE, whenever Dr. Sabia and the mini group says that I have lack of confidence, please tell me. I'll tell her that the students who are doing mentorship in different groups, so their first station with me, how they were. So see the pattern, see how they had improved. So everybody has the chance of improving. Nobody is perfect at the start. Everybody started from 0. Maybe somebody is starting from 5 by 10, but that doesn't mean that everybody is on 10 by 10. If somebody is on 10 by 10, they won't require coaching. Right, Dr. Sabia? Okay, so the coaching makes you better in the right direction, and I'm sure we all would be fine. So nothing to have lack of confidence. Always feel that we all have weaknesses, just we need to know and understand those weaknesses and work upon that. That's it. Okay, wonderfully done,
Yes,
station. Thank you very much, my dear. Great going.
Thank you. Thank you.
Okay, so let's move to station number 2. I had Harshipa here. So Salma Al-Sabai, she has some domestic issues for that. She has postponed her exam. So we've got...
Sorry to say, doctor, last question, that in this case, if the patient has come to us as in this session that I have mild abdominal pain, so we'll take that mild abdominal pain with a suspicion of ectopic, and we will send the patient home.
Significant abdominal pain, please admit her. Always remember, whenever it's an you ask her, can you score that pain from 0 to 10 to me?
Mm-hmm.
Okay, so if it's like 1, 2, 3, so it's fine. Give her the painkiller, it's okay. And again, don't forcefully send her back home. How do you feel? Do you feel to get admitted? I can offer you admission as well. So be safe in exam. So if she says, no, doctor, it's not much, I'm fine, I think I'll take the painkiller. So you are safe in exam, Dr. Atiya. Okay?
Okay. And in this station ending, this one which you have presented, what the ending would be, yes, you can go home with this all red flag sign with patient information leaflet and contact details.
And coming back in 48 hours.
48 hours. Okay, right.
Okay.
Thank you.
Thank you very much. Okay.
Dr. Sidra, just one point I would like to say.
Sure, Jyoti, please.
Yeah. So we don't use the M4 model anymore. It's the M6 model, which is closer to the NICE guideline. But anyways, we are using the NICE guideline, so that's fine.
Yeah. So basically we are following the NICE guideline, and that too, I'm not talking about only the clinical practice. Why did I emphasize on sharing this screenshots, Jyoti? Because in the EMQs, they changed this pattern. So they use that. So I have this view that college is using the NICE guideline for the question making. So it was just like 4 months back I'm talking about. So this is what you have to remember, because there's a disparity. So you should be knowing that what you're talking about and from where are we communicating in a structured discussion, my dear.
Yeah, so that's exactly why the model was changed, because it was closer to the NICE guideline, the M6 model.
Yes, yes. Thank you very much, my dear. Thank you. Okay, so we have Harshiba here. So I was telling you guys that, Dr. Salma would be taking the next batch with me. So we have a replacement of that. Actually, I had to regret many of the students as an active participants because I was blocked with this batch. So Abir joined yesterday, friends. Please welcome Abir from Iraq. She is, and she has joined as an active participant in replacement with Dr. Salma. So I'll be giving all Dr. Salma stations to Abir. And lots of listeners, they've also joined in this week. So we are going to have a healthy discussion, inshallah. Thank you very much. Okay, so Harshiba is going to do her own station today. Again, I'm thankful to her that yesterday night I was clear about Salma's the problem, and we just decided that she should be taking the next batch. So I told her at night, and she was like, okay, ma'am, I will do. And I appreciate that so much, that even the last week, that means that in the entire week, she's practicing. That means that in the entire week, she is like, okay, I will do the station. Because I know many of the students, when they don't know that they have their presentation, they become very easy. So I have all the appreciation for you, Harshiba, that you're always ready. That means that you take every week very seriously, my dear. So hats off to you. So you're one good student.
Ma'am, all of us are doing in Group D. All of us are taking part in.
That's very good.
We have
That's very good, Harshiba. I'm really glad about the Group D going perfectly, and I'm really glad that you people are encouraging each other and working on those points. I'm sure you people would be doing great in passage of time. Everybody would learn from each other. All right. So,
Dr. Sidra,
yes.
my group also doing every day, and all of us are doing stations.
You have got 10 by 10 this week, Dr. Sabir.
Thank you.
Okay, right. So, Harshiba, please check your mic for everyone if we can hear you properly. Yeah.
Yes, ma'am.
Say hello, hello.
Hi, ma'am. I can hear you.
Yeah. Okay. So everybody can hear Harshiba. Okay. Yeah, Dr. Sabia, I was actually gave that, but this week, actually, Dr. Atia was a little less in the participation. I did note that, but I think that she was a little committed with her shifting and all. So I respect that. But at the same time, everybody should be available, right? Okay. So yes, Sarvat is happy. So let's start with Harshiba, please. We are going to start the 2 minutes time, and then we'll start with the 10 minutes time. So Harshiba, your station starts now, my dear. Go ahead.
Okay, ma'am. Next slide, please. Hi, I'm Dr. Harshiba. I'm one of the doctors in the early pregnancy assessment unit today. May I confirm your name and age, please?
Hi, Doctor. I'm Mrs. Lena John. I'm 19 years.
May I call you Lena?
That's okay.
Lena, from your case notes, I gather that you are 8 weeks into your pregnancy and that you're experiencing some bleeding. Am I right?
Yeah, exactly, Doctor. I'm having bleeding since morning.
Okay. Surely in the next few minutes, Leena, I will address all your concerns and we'll come to a safe and a mutually agreed management plan for you. Before I proceed, is it okay if I ask you a few questions to know more about you?
Yeah, that's absolutely fine, doctor. I just wanted to tell you that I just want to end up this pregnancy because I'm really scared. I didn't know I have irregular periods, so I didn't know about this pregnancy. And just around maybe 3 weeks back, according to the calculation, it would be like 5 or maybe 5+ weeks of pregnancy. I had an ankle sprain, so I underwent an X-ray. So I'm really scared. I don't want an abnormal baby at all. I'm too young to handle such sort of a pregnancy. I want ending up of pregnancy, please.
Yes, I appreciate your concerns and I'll surely address that, Leena. Can you please answer a few questions for me before that?
Yeah, that's okay.
Okay. Can you tell me more about your bleeding, Leena?
Yeah, the bleeding I'm having is maybe I just had to keep my panty liner, so that's not much. But yes, it's there. It's bright red, doctor. And along with that, I don't have any other problem.
Okay. So there's no pain or vomiting associated with it?
No, doctor.
Okay. Leena, have you gotten yourself booked in this pregnancy?
Actually, I just came to know last week that I'm pregnant, doctor, because generally my periods used to be irregular. So I was not expecting a pregnancy. So yeah, at the moment, I've not booked it the pregnancy yet.
Okay. Are you taking any folic acid? Have you gotten any ultrasound done?
I've not started yet.
Okay. And no ultrasounds done as yet?
Ultrasound is done today, and they said that the baby heartbeat is there, but I'm really scared.
That's a good thing, Leena. Congratulations, firstly. We'll talk about all your concerns. Have you ever had any previous pregnancies?
No, that's the first ever pregnancy.
Okay. Besides your irregular periods, any other problems with your periods, Leena?
No.
Have you been on any contraception?
Yeah, we used to practice condoms, but this time we were planning to have a baby.
Okay. So this pregnancy was a planned pregnancy, right?
Sort of, yes.
Okay. Any illnesses running in your family, Leena?
No.
Okay. Any drugs that you're taking or following up with your GP for something?
No.
Okay. Any surgeries you've had on your tummy or down below?
No, no surgeries, doctor.
Any medications, any allergies that you're aware of?
No.
Okay. Leena, do you smoke, drink, or use any recreational drugs?
Yeah, I am smoking.
May I ask how much?
Maybe 3 to 4.
Okay. So, Leena, have you ever considered trying to quit smoking? You know, because it is a health hazard in general, and now that you are pregnant.
I'll think about that, doctor.
Okay. So, with your consent, I would like to refer you to our NHS Stop Smoking Services. I'll arrange an appointment for you with them.
That's fine. Thank you, doctor.
Okay. So, Leena, my questions might sound a little intrusive to you, but how has your relationship been with your partner? Any sexually shared infections you've had in the past, or your partner?
No.
Okay. How are things at home, Leena?
They're okay.
Okay. What do you do for a living?
I'm a teacher.
Oh, that's good. How have you been feeling in the past 6 months? Any episodes of being sad or tearfulness?
No.
Okay, that's good. May I know your blood group, Leena? Are you aware of it?
Yeah, that is A positive.
Okay. And what about your weight to height ratio?
That's normal, 22.
Okay. Thank you for all the information, Leena. Is there anything else that you would like to add?
Yeah, that's it. Just tell me about the X-ray. I mean, I don't want an abnormal baby.
Okay. Leena, one last question before we proceed. Is there anything that you have been forced to do against your wishes or anything of that sort at home? Any domestic issues?
No, doctor, nothing like that.
Okay. So, Leena, I would like to examine you in the presence of a chaperone now with your consent to see your bleeding and how your pregnancy is doing. Is that okay?
Yeah.
Okay. So I've examined you, Leena, and I have your ultrasound report here with me. It's the baby is going well inside your womb, and the heartbeat is there. So that's a good news, Leena. And I would like to tell you that the bleeding that you're experiencing is a very common problem that women generally experience early in their pregnancy in the first 3 months. It might be associated with some pain on and off, but it does not mean that something is wrong with your pregnancy, first of all. And also that you've gotten your ultrasound done, everything seems fine. Now, the concern that you have about your x-ray, because I'm sorry, what happened? How are you feeling? How's your ankle?
No, that was just a sprain. Actually, I thought it's a fracture, but it turned out to be a little sprain. I just used some simple painkillers, creams, and it was okay. Yeah.
Okay. So the only your ankle was exposed to the X-ray, am I right? No other
It was
part of the body?
yeah, my right ankle X-ray.
Okay. Yeah. So I would like to tell you, Leena, that X-rays are generally associated with very, very low dose of radiation, and they generally do not cause much harm to a growing baby. Especially because it has been done away from your tummy where your womb is. There is no reason to be worried about this pregnancy. Even if it would have been done in the region of your tummy, it would have been with very low risk to your baby.
Doctor,
Okay.
I just made a Google on the and on the topic, and it says that there are chances that the baby can have cancer. I'm really scared.
Yes, Leena, the risk of cancer in a baby, when especially it is exposed to, when the X-ray is exposed to your abdomen or your tummy, are there, but they are very, very minimal. And in your case, the X-ray has not been done anywhere near your tummy. It has been done in your ankle, so it is far away from the baby. So hence, I have strong reason to believe that it will not affect your baby's growth or lead to any sort of problems with the baby.
So what can be the reason for the bleeding then? I mean,
okay. Leena, as I said, bleeding is very commonly associated with the first 3 months of your pregnancy. It can be because the baby is forming inside and your afterbirth is forming inside. So sometimes your womb is stretching. That may lead to some sort of bleeding. But in your case, it is very slight. And I have reason to believe that there is nothing to worry about this.
So what do you suggest me now?
Yes, Selena, I would like you to start taking folic acid, which comes with a dose of 400 micrograms. And I would also advise you to take rest at home. If you like, I can arrange a meeting with the child specialist doctor, just to allay all your fears and concerns. I can do that for you. And from now onwards, we will have a regular antenatal pregnancy care plan for you. We will be calling you at regular intervals, doing your blood tests, and at 18 to 20 weeks, you will do an ultrasound to check development and growth of your baby. Does that sound okay?
Yeah, I get that. That's okay. So now I'm a little better, but I'm again having these waves of what if the baby would be abnormal, and I get all these bad thoughts all the time.
Okay. I see that you're very distressed about this, Leena. I will arrange a meeting with you and a counselor. You can bring your husband also to this meeting, and all the stress and worry that you are having, you can discuss with the counselor. And rest assured, if there is any increased bleeding or pain that comes in future, you come to us immediately. We'll look into the matter. But as of now, please don't worry, and if you need any help or support, we are here to help you.
Okay. Thank you, doctor.
Okay. Thank you, Leena. I hope I solved your queries.
Yeah. Thank you, doctor. Thank you. Give me some leaflet, Harshaba.
Yes. Sorry. These are some information leaflets. You can go back home.
Like Dr. Sabia, you people are forgetting leaflets today, huh? So today is the leaflet day. Okay, no problem. No problem. Okay, wonderfully done, station Harshaba. How did it go? Yes.
I was not sure about my agenda because there was nothing given about X-rays over here.
Exactly. So
So
I came in my concerns. Like she has her concerns and doubts about the pregnancy. Yeah?
yeah.
Okay,
Yes.
right. What were the good things you did, and what were those difficulties you were facing in the explanation, please? Yeah.
Yes, ma'am. So the good thing was that you told me about your concern in the beginning, so I knew where to go from there.
Yeah. Yeah.
And I think in the management plan, I was not very structured,
Mm-hmm.
and I could have improved upon. I could have spoken about the counseling, and I could have tried to. I don't think the patient was very satisfied.
No, I was satisfied, but because I'm 19 years, so the understanding of 19 years is like, they are more scared. So I wanted you to put up this counseling thing and the anxiety thing earlier.
In
But
the
I was
beginning.
yes, in the beginning. So I'm going to fix with the connect you to the counselor so that you can talk to them and feel better. There were many good
Yeah, and I think I mentioned husband also. I should have said partner. I
yeah,
said
yeah.
husband.
It's always better to say partner, but it's
Yeah.
fine because she was like Mrs. Lena. So
Hmm.
she's in a married relationship as per the station. So that is what I can just take it easy by your saying husband as well. So lots and lots of good points in the station. Introduction was good, a very smooth introduction and entering into the cubicle. Agenda making was good as well, and asking about the concerns, knowing about the X-ray, then acknowledging that yes, I'm going to settle your concerns. You did ask about the vaginal bleed, the pain, vomiting, or whether she's been booked or not, about the having the heartbeat. You did congratulate, that was all right. You asked about is it a planned pregnancy? That was very good about the family, the medical, the drug, the social history, about smoking. You did connect me to the cessation program. Very sensitively, you asked about the partner history, about the sexually shared infection. Beautifully ruled out the anxiety, depression by being sad or tearfulness, because this is 1, 2, 3 things which we would keep in mind. And then you did ask about the BMI, and forced pregnancy was also ruled out. So these were the best points which you did not mention. See, I remember my student, when they came out of the cubicle, they told me that, ma'am, this was such a difficult station, as in the X-ray was done, and she is like again and again saying, I want ending up of this pregnancy. So we were thinking that it's some sort of a domestic violence station, and asking again and again the hidden agenda. Neither it was depression, no, it was domestic violence. Because why is she adamant to go for the termination of pregnancy and just on an X-ray? Because she says that I don't want an abnormal baby. So we kept on asking about the violence, but it was nothing like that. But we had this sort of hidden agenda in mind, that at 19 years, being pregnant at 8 weeks and saying that because I don't want an abnormal baby, I want a termination, right? Now, coming to the point of examination, you did a good examination. X-ray explanation was smooth, but a little clear. I would just make it. I will give you lines on that. You did give folic acid in the end, asked me to rest. You did connect me to the counselor and gave me the red flag signs. Don't forget the patient information leaflet, okay? Now, coming to the points which can be improved. Yes, Fawzia, because she insists on termination, my dear, because she wants termination for the reason that the X-ray might cause the abnormality in the baby. Now, as X-ray is causing the abnormality in the baby, so if you settle that concern, so she's happy with the pregnancy as it's a planned pregnancy, so it was acceptable. But if you think that there's some sort of abnormality, then avoid that. Okay. All right. So the points to improve which I have to give you is that the history taking was all right and it went on time. In fact, the entire station got completed in 10 minutes, Harshaba. That's very good. That shows your practice. The explanation part in that would be a little smooth explanation I'll give you about the X-ray. And my starting of the concern would be with this, yes, very good timing, Divya. My concern would be to make her settle about her choice of termination. If she wants that, that would be all right. Rather than the child specialist, you say, I'm going to connect you to the baby doctor who is going to tell you about this, the results, or you can have a word with him to for your concerns to be addressed. And moreover, one anomaly scan in the antenatal care you can mention that we are going to deal with that, and a mid-pregnancy scan we would see just to rule out if at all there are any chances of having an abnormality in the baby. So it's picked up early and we can talk to you at that point in time. When I'll start the station, remember, in communication with the patient, you went 2 by 2, no medical jargons, explained the situation well. You spoke in a very calm manner in a very appropriate volume. So your greeting, your introduction, creating rapport with the patient. I'm happy with that, Hirshaba. Just keep on practicing like this. In information gathering, okay, before that, when I'll start my station, I'll start with the agenda of yes, bleeding in pregnancy. And when she comes up with this, you did acknowledge that and you said that after asking few questions, I'll come to your concern. I will address that concern by saying only that, what was her name? She was Lena. Okay, so I would say, Lena, I reassure at the very outset that everyone has the right to take a decision for continuing or ending up of pregnancy. Me and my team would support you in this. So this would be my starting, that it's not that termination, we are against that. So it is your right to continue the pregnancy or ending up of the pregnancy. Okay, starting of the pregnancy, ending up of the pregnancy. Yes, Liana, where did she use that? Where did she use that? Let me come up with this, then I'll take your questions, okay? So to begin with, just speak that sentence so that she's comfortable talking to you and she knows that, you know, whatever I'm going to decide would be given respect to and would be taken as a decision final. So then information gathering went fine. You did ask about the bleeding, general questions. Now, these yellow highlighted questions would be my questions for this, specifically this case. So my few questions, Lena, might sound intrusive. How do you and your partner feel about the pregnancy? Is he supportive? Do you consider yourself a happy couple? Is he a regular partner? Any history of sexually shared infection? And in mental health, like Hirshaba did, do you feel that in the last few days you were being sorrowful or tearfulness or getting depressed? Because I am keeping 3 or 4 things from the start when she asks for the termination. Number 1, domestic violence. Number 2, forced pregnancy. Number 3, history of anxiety or underlying depressive disorder. And number 4, the depression itself. Okay, so anxiety, depression, forced pregnancy, and domestic violence. All these 4 things in the history, we have to come up with one after the other. Yes, Liana, what you have to use is the first half, second, or the third half of the pregnancy, if you have to speak up anything in between. Okay, and Dr. Atia, connect to the radiologist for more explanation or not. Radiologists, no, because they don't have, they don't know that, you know, what would be the basically implication. But yes, the child doctor or the baby doctor is fine because they have more to deal with these scenarios. So do connect to the child doctor or the baby doctor, you can say. Okay.
Ma'am, should I have mentioned NT scan like 11-13 weeks?
No, that is an antenatal care. You will just say that at this point, from this point, we are going to follow you with a regular scan and your reports and a mid-pregnancy scan telling us if at all there is some problem with the baby, and we'll discuss with you at that point. So,
because we don't suspect anything to happen.
Yeah, so say that we are going to follow you with the regular scans from this point onwards to monitor the pregnancy. Okay, right. So then in the patient safety, remember that in this case, the underlying thing was that you did tell about the X-ray thing, but the threatened miscarriage word I wanted to hear from your side. This is a diagnosis at the moment, no? Yeah? So yes, what is the diagnosis at the moment, sweetheart? I wanted you to elaborate that what threatened miscarriages and the management options which we have. This second part of the station of the applied clinical knowledge went a little lower in the information points. So for only that reason, I wanted you to speak a little more on the management of threatened miscarriage. The only thing which I got in the management was rest. So other than rest, I didn't get anything. So threatened miscarriage has its applied clinical knowledge. So it was a combination of addressing the X-ray part and a combination of managing a threatened miscarriage. and excluding the domestic violence of forced pregnancy, anxiety disorder. You wonderfully did that. And you did respect, in fact, telling again, in the end that yes, we are going to continue pregnancy. Again, you have to speak one line that it is going to be your wish. You can discuss with your partner, and I can get you connected to the child doctor as well. And then you can discuss whatever you're going to decide. Again, it would be respected. All right. Okay. Sorry. 6 months off what, Sarvat? 6 months off? Six months of what, my dear? 6 months for get to. You can ask about, yeah, what you can say is, Dr. Sarvat, what you can say is that in the last few weeks, generally 6 months history we take because it's a short-term point. You can say last few weeks as well. It's up to you, right? Yes, depression history, I get that. You can say last few weeks, or you can say in the last 6 months. So basically it gives you an idea how had the mood been. All right, thank you very much, Sarvat. Okay, so now I'm here with the screenshot from the TOG article, the imaging and the results and its effects on the pregnancy, to tell you that it was a recent TOG article. And my previous groups in the batches, now I've given them the schedule, and daily they do 2 to 3 TOG articles, and I make structured discussion from them for it, because they've done with all these cases earlier. It's been 3 months that now they're free. So why am I emphasizing to them? Because 1 or 2 stations, they come from the recent TOG article, and they're newer stations like this. That year, this TOG article came for the X-ray and the imaging effects, and they gave in this station. So I am always in favor of doing the last 2 years, or specifically the last 1 year TOG articles, because some sort of station, they make that from there. Students had difficulty when they were doing this because it was something new and they were not sure about the applied clinical knowledge. Now we are doing as a repeat station, so we know that. Both the X-rays and the gamma rays, they are short wavelength electromagnetic waves that can ionize tissues and alter the normal cellular structure in 2 ways. The TOG article says it can be a stochastic and deterministic effects. When it is a stochastic effect, the example is development of carcinogenesis, which I was talking to Harshiba about. It is said that some cellular damage can be done in the germline mutation. However, no known threshold value at which these effects will not occur or occur, we don't know that. However, it is said that increased risk of childhood malignancy, including the leukemia and the lymphoma, is there. If we say that effects of deterministic, they occur, it is the loss of tissue function because of cell death and the results from radiation doses above a threshold value. Now, these are predictable, some sort of chromosomal anomalies or structural anomalies like skeletal, ophthalmic, genital tract anomalies, fetal growth restriction, and neurological effects like microcephaly or some developmental disability can occur. So these are the 2 effects, like stochastic and the deterministic effects as per the TOG article. But this part is fine if you're going with the structured discussion. But the problem which we face is that how to explain. Harshiba was very clear in her concept, but I want crisp lines, because see, we are fighting against time as well. So if I would be there, I would be starting my applied clinical knowledge by Lena. So I have 2 things, 2 aspects to talk to you about today. First is the X-ray you underwent for the ankle, and then bleeding in the early pregnancy. So coming to the first point, I want to reassure that having X-ray during the pregnancy does not increase the risk of miscarriage or causing birth defects, and neither it affects the mental development in any way, Lena. However, the literature and the animal studies, they do suggest that small risk that the baby might develop cancer in the childhood. But the exposure of the dose of the X-ray is very small in your case to cause the harm to the baby. And that too, the X-ray was taken distant from the tummy, that even lowers down the risk in future, Lena. Am I clear about this? So now by applying...
So we have to mention the word cancer. I mean, is it necessary?
Yeah, why? Because it's an applied clinical knowledge that yes, the risk is there. So what if it happens? But at the same time, I would emphasize, Harshiba, that it's an animal study, not seen in humans. And in your case, there are 2 points for which we can reassure you. Number 1, it was the lowest radiation. Number 2, it was distant from the tummy. Right? So then your applied clinical knowledge would be fine in telling her that this thing In your case, it lowers down the risk. Okay, so just go in this flow and telling her that this is the first concern. From where did they take this, friends? It was a very low dose examination in which less than 0.1 milligray is the radiation. And that too, they have taken the station from radiography of extremities. That is even less than 0.001 as per the TOG article. Okay, radiography of extremities is even lower. So if we look at from where did they make the station, do this table. Why? Because then they can make from 0 to 2, 3 to 4, 11 to 17, anywhere. They had 5 to 10 weeks of gestation, and the effect is none as per the TOG article. Why? Because less than 50 milligray, they say that no effect is there. And in our case, it's less than 0.001. So that's almost minimal, friends. Why am I sharing this? So that you understand that from where basically the applied clinical knowledge is coming, and you would be very confident in exam. Okay? So according to the TOG article, if we talk about very low dose examination, extremities, and the conclusion is that the available literature demonstrates that the effects of the diagnostic imaging studies on the fetus involving less than 50 milligray radiation at any gestation are likely to be negligible. So you're confident in exam. You're confident in exam that they are talking about this thing. Less than 50 milligray radiation at any gestation is likely to be negligible. And in Lina's case, it was less than 0.001. Bringing this applied clinical knowledge so that when you see with your eyes, I could have made the slides as well, but when you see with your eyes that this is documented in the article, the memory is better. So you're confident in exam that we know, because students, when they were appearing in exam, they were having shaky applied clinical knowledge. They were not sure how to counsel because it was a new station. So how to handle this patient, right? So now you'll be in a perfect position to handle this station. Now, this part was good, this part was satisfactory, but the problem which was not dealt with was the second aspect. So now I'll be discussing the second aspect, Lina. And see, the management plan, the X-ray part is done. And for the threatened miscarriage, I will tell her, basically the vaginal bleeding in early pregnancy, it's common, Lina, and it does not always mean that there's a problem, but it can be a warning sign of a miscarriage as well. We call it as the threatened miscarriage. So my applied clinical knowledge would be fine when I'll speak up this diagnosis, Harshaba. Did you get that, my dear?
Yes, ma'am.
Yeah. So you'll just speak it up, my dear, and your part would be done. Now, it is not always possible, Lina, to give an explanation as to why you have a bleed. However, there can be multiple reasons, because at times the afterbirth that tries to burrow into the lining of the womb, and at times the neck of the womb becomes rich in the blood supply and becomes softer, and a slight trauma like that of an intercourse that can cause a bleed as well. And rare cases, it can be an infection as well that can lead to bleeding. Now, the important part is to know whether the heartbeat is there. And it is reassuring, around 90 out of 100 women, Lina, they have a successful pregnancy when the heartbeat is visualized on the scan. Am I clear so far? I would just like to tell you that how we move with this pregnancy. We generally advise that you take rest, avoiding the sexual intercourse safely in pregnancy until and unless the bleeding is stopped. And I can also write to your GP to provide with a sick certificate if we require. So, right, Harshaba? She was the teacher.
Okay.
Okay. So this is the general management of the threatened miscarriage you have to tell. Now, even...
Ma'am, do I also have to say avoid any strenuous activity?
Yes, I'm coming to that. Yeah. So along with that, I will also mention that avoid using tampons and use the sanitary towels or the panty liners according to the bleed, and refrain from exercise or swimming or any strenuous activity for the time being, Lina. Would that be okay? If at any point in time you feel that some heavy red bleeding is there, or it's a fresh bleeding, or the pain is also associated with that, please see us without any detail. So now, without any delay, if she comes to you, now it's going to be the end of your management plan. So I was happy with this part. This rest was there, but just in 15 seconds, do mention the others as well. Okay, so this is a combination of two things. And please tell about the threatened miscarriage as a diagnosis, because it would be like your applied clinical knowledge that you understand. Your explanation was perfect, but telling about the red flags in the end, you did tell about that. That was very good. And in the end, you can also connect her to the counselor for anxiety and patient information leaflet. And again, you can say, so whatsoever you decide, your decision would be respected. So your job is done.
Okay.
Okay, well done, my dear. Great. So introduction, agenda, a very good information gathering. Rule out hidden agenda in your history, please. And counseling regarding the X-ray in early pregnancy, then management of threatened pregnancy, miscarriage. So these two things you have to do: patient information leaflet, follow up, and respect her decision even in the end. So there's a very beautiful closure to your station. All right. Okay, wonderfully done, station, Harshipa. I will give you.
Actually, there was no talk. There was no resource on threatened miscarriage I could find. So
there's a very beautiful. Yes. Okay, just remind me after the class. There's a very good NHS patient information leaflet on threatened miscarriage by NHS. Yes. Okay.
And ma'am, the scan that we have to do is the next scan is only the 18-20 week scan, right?
Not directly, my dear. You'll follow the pregnancy if she continues like any other pregnancy. So one would be the down screening as well.
The screening.
It is generally done as a routine for everyone. So knuckle translucency would also be there. Okay. So I'll write down, what do I have to post for threatened miscarriage PIL you want, huh?
Yes, ma'am.
I'll do that, my dear. You can have a look on that. And remember, always when the patient is bleeding, she might require a sick certificate. So you can just add it into your management.
Dr. Sidra,
yes,
so something like this where the patient has come to us in her early pregnancy, do we always have to ask if she's had a booking visit?
Why? Because if she has had a booking visit, so at least your plan would be starting from this point onwards, because the booking test would be done. So you'll be knowing that, okay, this thing is done. If it's not done, then you have to do in your management. So that gives you this information. Your starting point is basically in the management is actually it helps you in that.
Okay.
Okay, that's the reason. Otherwise, if she tells you herself that, okay, I had booked with a midwife, that means her folic acid would be started. You confirm that the scan would be done or some booking blood test has been sent. So your management plan would be starting from that point, which has been done. So moving forward from there. Okay. All right.
If she's come to us at 6 weeks, we ask them that.
Yeah, when she comes as an early visit. Even if she comes as a 12 weeks, at times they're not booked. So you ask, like, was your booking done with your midwife and how did the tests go? Are you aware of the results?
All right.
So you
Ma'am, I'm sorry, I'm not clear about this, but do we call her before the screening scan for another ultrasound, or we call her directly? I mean, it will depend upon her symptoms. If she resolves with the bleeding,
that's fine.
Then we will call her at the screening time.
Yes, at the screening time. And then after, like, according to her risk factors, you can call her in the antenatal clinic, like 2 to 4 weeks. Accordingly, monthly, you can call her. Okay, if the things they get settled. Now, if of course you'll tell her the red flag signs that she has any concerns, she can come earlier as well. Okay.
And ma'am, what are the questions, like somebody asked in the chat about the mental state, the GAD2 questions? The
what you said were absolutely fine. So may I know, how had you been feeling in the last few weeks or the last 6 months? Any feeling of depression, tearfulness, anxiety? So that's it. Your job is done. Basically, yes. If she says, no, otherwise I'm very happy about my life and everything is going fine. So that means that it's okay. So your job is done. You're ruling out some underlying anxiety or depression, underlying disorder. Okay.
So Dr. Sidra, we must mention 6 months as we are usually asking in the last few weeks. Is that okay, or we should mention 6 months?
Okay, if you want to fix that, last few weeks can also be like, coming up to that. You can say in last few weeks to finalize that. Okay, so if you want to make one final, so do it last few weeks. Okay, so that you understand that what had been the recent well-being of the mental well-being of the patient.
Okay.
All right. Okay. So any questions from this? I hope now you people are clear, because this was a new station and it was a little difficult, of course, because we are preparing that now as a repeat one. But now I hope that you people are clear that from where did they bring the station and how it was made and how we are going to solve the station. Claire Bindu? Yes. Yes,
Dr.
Dr.
Sudha, I
Savitri.
have one question.
Please, Dr. Sabir.
I don't want to forget because this about talk article. With the new talk article, can you please tell us that which topics we must go through, or the whole talk article we have to do?
Just complete these important stations first, and with the books, I'll give you the list. I've made one drive with everything, all the curriculum to prepare for part 3. I always give to my students. That's my Google Drive with everything inside. So I'll give you that, or till year 2020 talk articles are there. The last 1 to 2 years, I will tell you that you have to do. Okay? And I'll make sure that we do that together. All right?
Okay. Ma'am, when we're explaining about the X-rays, do we, sorry, yeah. When we're explaining about the X-rays, do we, should we say that it has been seen in animal studies that in some cases that it has been seen that it is associated with cancer, very low risk. Should we also mention about the other risk, the risk of anomalies?
No. Actually, it says only the cancer. The others are said if the radiation is more. For her, the radiation is way too less. So it's fine only saying that there's a slight risk only for this childhood cancer, and that too coming to this point because your risk of and your exposure to the radiation and the X-ray was very less, and at the same time it was distant from that of the tummy, which even lowers down the risk. Okay.
So we say that in our case the possibility is very low. It's minimal.
Very low.
That's what to say.
Yeah. So coming to the second aspect. So divide your parts into the first aspect addressing and the second aspect addressing. Okay. As I made the algorithm for all of you.
Yeah, I read the talk, ma'am, but I don't know how to like put it in
I'm glad that now you'll be in a better position doing. That's why I've come with a screenshot of the talk that this is the written information, but how we have to put into the words, just write down from the recording into your, put a stick on your template and things would be fine in exam. It would be a very good flow. Okay?
Yeah.
Okay. Thank you very much, Harshaba. All right. So that was a 1 in 1,000 for Bindu. 1 in 10,000 for Bindu. The exposure?
Yeah, childhood.
0.001. Yes. Way too less. Yes, Dr. Bindu. Way too less. So you don't give the figures. What happens is no matter how many figures you remember in exam, all gets mixed up. So always say it's very lower in very rare cases. So anything like that which gives a very less intensity impression to the patient. Okay. All right. So thank you very much, Harshaba, for a wonderful station, my dear. Just applied clinical knowledge, I will give you like 1.2 or 1.3 out of 2 because of missing up a few things on the threatened, but I'm sure in exam it would be a perfect station. So the things, rest all the domains for passing, sweetheart. So the things which we make mistake today, of course, under the guidance, that is the best thing. Rather than few students, they learn the harder way and they learn in the exam. So it's always better that we learn the things in this part and we do have a smile in the exam that everything went well and we enjoy the result and we enjoy the success. Okay, so thumbs up to all of you. So let's start with the third station, which is with Dua. Hello, Dua. How are you?
Hello, doctor.
How are you? I hope you're not on duty today.
No, I am not on duty. I cancel my duty for you.
Oh, thank you very much. My pleasure, sweetheart. My pleasure.
Thank you.
So, Dua, how's everything going in the mini group?
It's okay.
Okay, very good. Well done. So a little change in the mini groups. I'm sure for this week, things would be okay. I've talked to Nadra as well and Dalia as well. So you people would be sharing the templates as well, and you would be sharing the discussions as well, so that with every group we have to improve together, okay? All right. So let's begin with Dua station, and I'll start with your 2 minutes time. Okay, all the best from the mini group, and start now.
Okay, next. Okay, Dr. Sada.
Start, my dear. Yes, please.
Hello, I am Dr. Bai, and I am ready for discussion.
All right. So how are you doing today, Dua?
Fine.
Okay. So can you please tell me that what initial assessment you would perform for your patient?
For the patient now, she is coming maybe 3 weeks after her medical management for miscarriage, and she came with a positive pregnancy test. She is a known case of idiopathic Berber, and she had a low platelet before, and she received the transfusion. So the initial management for this patient, I have to ask her initially if she has any symptoms, like if she has any bleeding, and how's the severity of the bleeding, if she has any pain, excessive vomiting, any other abnormal symptoms like difficulty in breathing or chest pain, or she has any fainting attack of home or any symptoms of hyperthyroidism. Then I want to ask her about, after completing the history from here and doing the examination, to check her vital signs and to check if she is stable or not, and to check examination from down to check the amount of the bleeding. I want to do for her beta HCG quantitative to check the hormone level, and I want also to do complete blood count to know the level of the platelets, and I want to do scan to see what is the condition and why the pregnancy test is positive. This is my initial management.
All right. So what do you think are the risks in your patient?
The risk in this patient, at the beginning, she is a known case of idiopathic Berber, so she has a risk of bleeding. And also she has a positive pregnancy test after the medical evacuation. So I have to know why this patient has a positive pregnancy test. It was a misdiagnosis from the beginning. The patient has any other reason, like molar pregnancy, or there was incomplete evacuation, or this patient has already she didn't receive a proper contraception and she had an intercourse and she became pregnant without her knowledge after. So this patient has all this I have to put in my mind in the management of this patient and considered as a risk factor. And the main concern would be as regard her bleeding tendency should be put in mind also.
Okay. So what is your differential diagnosis in your patient, and what are you going to do to reach to a final diagnosis, please?
For the differential diagnosis, here, this patient, maybe she has, as I said, maybe the medical evacuation and the pregnancy not terminated, the medical evacuation done, and the patient, maybe the termination not come completely. So still she has remnant or product of conception. Or maybe this patient has any source of gestational trophoblastic disease or molar pregnancy. Maybe she has after the miscarriage itself, she will retain her fertility. Maybe she had an intercourse after that and she became pregnant again. So this is a cause of the positive pregnancy test. And what we have to do the beta HCG. We have to do an official scan, ultrasound to check the remnant, or to check what is the situation right now, and also to do the complete blood count. But the final diagnosis can be reached without a histopathology. What we are doing now is just for the initial diagnosis for the patient. The final diagnosis will be by histopathology of the tissues after evacuation.
All right. So beta HCG has come out to be 56,000 and the platelets are 150,000. Ultrasound has also been done, which shows the cystic lesions. What do you think is the diagnosis now? And now take your time to please explain me the further management for your patient.
Okay, for the diagnosis, most probably from this high beta HCG level and for the ultrasound, this is most probably a case of a molar pregnancy. So what we will do further management at the beginning, we have to admit the patient. These patients should be managed by a multidisciplinary team. My consultant will be involved, and also we have to involve the hematology. Although the platelet count is a little bit within the normal level here, but we have to involve the hematology in the management of these patients in case if she has any risk of bleeding. And also we have to do cross-matching for the patient and to know the blood group for her, and after that we have to counsel the patient and inform her what is happening and to take her consent that we are going to do, to explain to her what we are going to do, that we have to go for further evacuation for the remnant of this retained product. And this is usually will be done under general anesthesia. And during the evacuation, the patient should be, the senior should be, he is the one, senior obstetrician, he is the one who will do the evacuation in the presence of the consultant, because this patient has a risk of bleeding. Maybe we can give this patient also some medication to just to soften the cervix, like misoprostol, just 2 hours or 3 hours before the evacuation. The evacuation usually will be surgical evacuation. Oxytocin shouldn't be used in this case due to the risk, maybe there is a risk of embolization, but only we can use oxytocin in the condition of risk versus benefit if the patient has heavy bleeding to arrest the bleeding. This is the initial management for her for the surgical evacuation, and these patients should be registered to the trophoblastic screening center, and also the tissue will be sent for the histopathology. And we have to check the blood group for this patient. If the patient blood group is negative, she should receive anti-D. Also, if the patient for the molar pregnancy, whatever the complete molar pregnancy, maybe anti-D is not needed because of fetal tissue, but because of the histopathology will take about 10 days. In this case, we have to give anti-D before waiting for the result of histopathology. And after registration, we have to go through, according to the result of histopathology, if it confirmed molar pregnancy, we have to go for the follow-up for this patient. The follow-up should be, we follow up the result of beta HCG weekly. If the result become normal, less than 56 days, so the patient will be continued for follow-up for 6 months from the date of evacuation. But if the result become normal more than 56 days, so we will continue for 6 months from the date of normalization of beta HCG. And we have to counsel the patient to use the proper contraception. Usually it will be a barrier method, because hormonal contraception not preferred in this condition because it increases the risk of gestational trophoblastic neoplasia. Also, the IUCD is not preferred because there is a risk of perforation. So she has to go on barrier method till she will complete the follow-up.
Okay. You've got 1 minute. Anything you would like to add in any of your question, please? Yes.
So the platelet. I think, and we have to ask to counsel the patient also about the risk of recurrence in the next pregnancy, about 1 in 80. And also there is a risk, maybe if she's a molar pregnancy, there is a risk she has gestational trophoblastic neoplasia and maybe she will need a chemotherapy. It's 15% in complete molar pregnancy and about 0.5% in partial molar pregnancy. And the chemotherapy will depend according to the FIGO classification and if less than or equal to 6 or if more than or equal to 7, it will have to need either single agent or multiple agent chemotherapy.
Okay, about contraception?
Contraception, I said the contraception, it will be barrier method till she will complete the follow-up.
Okay. So the bell rings, yeah? What do you say?
I was talking about the contraception. She has to use only barrier method.
So when the bell rings, what do you say to wind up the station?
Thank you.
Thank you for your time.
Thank you.
Okay, well done, Dua. Wonderfully done, station. Beautifully described the things, and very good job. Very good job. So credit goes to Nadra, Midhat, all of you out there. Very beautifully done, station. A structured discussion. Beautifully done, Dua. Very well done. I'm really happy. Other than the question number one, I have to guide you for question number one. That how do you speak that, my dear? You were very good in your explanation. Beautifully told about the differential, the way you took the molar pregnancy and telling about the management, telling about the hematologist, telling about the consultant doing the surgery. Lots of stars here. You started beautifully. Yesterday I was doing this station with group B of mine, and Devya, I was with Devya knows a few of the girls. Sam and Rukaya were there, right? So I gave one of the station to one of them, and they were like starting with the management plan. So remember always that you start with the background, the way Dua started the station. You always begin with, okay, my patient. You take the name that Mary Jane's 28 years. She has had a miscarriage for which she went through the medical evacuation. And after 3 weeks, now she presented with a vaginal bleed, and her pregnancy test is positive, and she's a known case of idiopathic thrombocytopenic purpura. So my initial assessment is, and then you start with this part. So remember that whenever you're doing these cases, always remember to start with some background rather than saying, so my initial assessment would be. This is the beautiful way of doing like Dua did, that she brought the background in the structured discussion and then she started her structured discussion, right? But in structured discussion, please keep a note of this. Whenever some initial assessment comes, what do you incorporate in that? You incorporate history, incorporate examination, and investigations if required, right? And investigations if required. So these are the initial things which you have to speak. Now, Dua, you beautifully said that I'm going to ask this. I want you to clearly speak up to the examiner. So my first part in the initial assessment would be taking history of the patient. Rather than asking, you were taking history, but I want you to speak this word to get marks. I would be taking history of the patient, then would examine my patient in the presence of a chaperone and will run few important investigations as well. So in history, I would be doing this. Now, in history, my sweetheart, you just took the history of the bleeding, right? And you took history of the general complaints now she's having. Remember, in history, you don't ask the questions like you do in the SPT, but you go with the entire template. Like in my patient, I would like to know the history regarding the bleeding, the amount, the color, the vesicles, any associated pain, any medicines she's taking currently, any associated vomiting, or any recent ultrasound performed. Regarding the history of the idiopathic thrombocytopenic purpura, I would like to know since when she was diagnosed with that. Is she on currently any treatment like immunoglobulins or platelet transfusion? When was her last visit to the doctor, and how is the control of the condition to her, and is she symptomatic? Then I would like to know about her past obstetrical history, the medical history, the surgical history, the drug history, ensure that she is not Jehovah's Witness, her personal history, social history, and mental history. So what am I doing, Dua? I'm completing the template, only putting in the headings to tell the examiner, all this I would take from the patient in the initial assessment. You get that, my dear?
Yes.
Okay. So just in the, see, there's a difference, the same information gathering, sweetheart, the template, but the difference is there you ask the patient, and here you just mention the headings that this I would be doing, keeping the same template in your mind. So this part was missing. I would just like to add on this. Then I would examine my patient, taking the vitals, doing the abdominal examination to exclude the cording and the rigidity, doing the vaginal examination in the presence of a chaperone to assess the cervical state in my patient. Would send investigation the beta human chorionic gonadotrophin and urgent transvaginal scan to rule out the cause for the bleeding. Now my initial assessment gets over. Okay, so dividing into part. dividing beautifully into compartments, the history, the examination, and the investigation. Now, the risks in my patient are, yes, the failed medical management. I gave you a star on that, persistent vaginal bleed, bleeding due to idiopathic thrombocytopenic purpura, and she's high risk for hemorrhage. Otherwise, these are the risks in the patient. My differential diagnosis in this case, either it can be a new onset of pregnancy. Beautifully, you said that. I was very happy with your management, your differential, previous failed management, a threatened miscarriage, a molar pregnancy, an ectopic pregnancy, any local cause of cervical bleed, or bleeding owing to thrombocytopenia. To see and to reach to my final diagnosis, I would like to send a complete blood count to see the platelets, a serum beta HCG to rule out molar or ectopic pregnancy or a failing pregnancy, an urgent transvaginal scan to locate the pregnancy and to rule out molar pregnancy as well. So systematically we are going to answer. Okay, right?
Yes.
Okay, TBC, no, it's CBC, complete blood count. Bindu, complete blood count, right? I mean to see the platelets, Bindu, okay? Now, coming to the management, wonderfully done management, but one part in patient safety is missing. Anybody? One part in patient safety is missing, though I changed the slide, but I hope you people didn't see that.
Beta HCG after next pregnancy.
Okay, that's fine, Sarvat. Any other thing?
Screening.
Duty of
the
Candor.
registration in the screening program.
Dahlia, yeah, she did register. She did register to the
duty
for the
Dr. Sidra, we have to apologize. Duty of Candor, I think.
Very good. Duty of Candor and very good, Rita. Incident reporting.
Incidents reporting, yes.
This is one thing. This is one thing without mentioning which your patient safety would not be passing. Do you know, are you aware of that table of a clinical governance paper which says that whenever there's a misdiagnosis, you always have to initiate an incident report? This was a misdiagnosis. Very good, Midhat. Very good, Girija.
Okay, so but Dr. Sidra, there is something. Usually for the missed miscarriage, if the patient has medical evacuation and she has the evacuation at home and the result will not be sent for the histopathology at the beginning, she is supposed to do the beta HCG 3 weeks after. So maybe this is not something wrong because this is the habit. If the patient has medical evacuation at home and the result not sent for histopathology, she has to do beta HCG 3 weeks after to rule out the continuation of the pregnancy or the presence of other pathology like molar pregnancy.
Yeah.
So that's why I was confused about the incident report.
I understand, Dua. So this can be one situation. Generally, remember that medical evacuation, the misoprostol and all that has been given to home, but when they have pain and all, you ask them to come to you. Yes, if it is missed, sending the histopath. Ideally, histopathology should always be sent after a missed miscarriage to see that if it's not a molar. If it is missed, right? So you should always do an incident report. Number two thing is that important doing an ultrasound at that part when she was diagnosed with missed miscarriage. So maybe at that point, something was missed as well. So if you think that, Dua, you are in a confusion in a structured discussion, you will ensure that if it was a misdiagnosis, what would you speak in exam to get marks, Dua? That I will after history, I will confirm that whether it was a misdiagnosis. If the expulsion was in the hospital and it was not sent for the histopathology, I will ensure that incident report is initiated and I perform the duty of Candor as well. So you can put it in this line, that after confirming that it was a missed diagnosis. So you speak it in this manner. So you, in both the ways, you are safe, Dua, in exam. Okay?
Okay.
There is a table of the clinical governance incident report triggering. And if you've seen that, somebody can post that in the main group. So if somebody has not seen that, they can see that. Girija, do you have that table in which they say that the trigger of whenever there is a misdiagnosis, you do that?
I have Dr. Sidra. I will post it.
Yeah, post that in the main
group. I will post
group.
it in the main group.
Post it. No problem, Girija. Dr. Sabia would post that. Post that in the main group so that you never forget that it is a trigger to do the incident reporting, my dear. Okay?
Yeah, sure, inshallah.
Now, just highlight that part and just post that, my dear. So then you'll send the baseline beta HCG and the full blood count, the cross match, the liver, the kidney, the renal function test and the thyroid function test as a baseline. And the treatment of choice is suction evacuation. Now, Dua, I will divide my management by heading. See, a structured discussion means I've solved this for all of you that it should be structured. Beautifully, you did the operative care. You just speak this line. You did the pre-op thing, my dear. Just speak this line. In the pre-operative care, I will take the consent, arrangement of the blood products and the platelet concentrate, and anesthesia assessment of the patient. Prolonged cervical preparation would be avoided to reduce the risk of embolization as per the Green-Top guideline. Immediate cervical preparation can be performed in my patient. During the operative care, would suggest that we keep it as first on the list and the WHO checklist is followed by my patient. Consultant to perform the surgery and avoiding oxytocin except if significant hemorrhage is encountered. Ultrasound guided procedure, it has to be in sending histopathology with correct labeling. In the post-operative care, NTT would be required if she is Rh negative. The venous thromboembolism assessment would be required and registration in the gestation trophoblastic disease screening centers would be done. I would be suggesting my patient to do the barrier method as a contraception until the beta HCG comes back to normal. Then she can use the intrauterine copper devices and the combined oral contraceptive pills as well. Now, if she has a persistent vaginal bleed or dyspnea or some neurological signs, then the discussion of the chemotherapy would be done with her, would tell about the cancelling of the recurrence, that is 1 in 80 after 1 mole, 1 in 6 after 2, and 1 in 2 after 3 molar pregnancies. And after every subsequent molar pregnancy, it would be a test at 6 to 8 weeks to rule out that the beta HCG has come back to normal. Okay, so this would be the post-op. Now, the follow-up of the patient would be the beta HCG returns to the normal within 56 days. It would be 6 months follow-up from evacuation. If it does not return to the normal within 56 days, it would be 6 months from normalization of beta HCG. The hematologist review would be done in the post-operative time as well because of her condition, idiopathic thrombocytopenic purpura, will offer her counseling and support. So this brings your completion of the station. Very well done station. Just in question number 1, there were a little shortage, and in question number 4, divide that into headings. So in pre-operative care, so the examiner knows clearly, okay, so you're moving in a systematic manner in operative care, in post-operative care, and in the follow-up of my patient. When you speak these headings, Dua, examiner really likes the structured approach. Did you all get that? That what is the difference between any student and what is the difference between a structured student? The structured student is who goes like systematically in a structured discussion. This is the ideal way of getting marks. That's why I've solved it in this manner so that you people understand that how a flow should be. All these points, each one of you knows that. But the problem in exam is that you people jump from one point to the other and you people like go from here to there, because you forget that how we have to be structured. Okay, so being structured means that put your headings there, speak it up, right? That in the pre-operative care I would do this, operative care I would do this. So when you mentioned in the oxytocin point, just speak during the operation or during the operative care. So when you're telling about the cervical priming thing, you can say that in the pre-operative care. You get my point, Dua? Sweetheart, got that? Okay, so
yes,
yes, thank you very much, my dear. Okay.
Dr. Sidra. Yes,
Dr.
Sidra.
Yes,
yes.
Dali, please. Yes, my dear.
Dr. Sidra, I just want to know if this was not a structured discussion, if it's a role player task. How and when would we tell the patient about the incidence reporting?
Yes, Talia, if it is a simulated patient task, see how is the patient. At the beginning, is patient angry on the failed medical management? If she's angry at the very start, you say that if she knows the diagnosis, right, that the UPT is positive again. So at the very start, you have to say that at the very outset, I would like to apologize that a complication did occur, and we have already initiated the incident report to look at the causes as to where things went wrong. And the team of doctors will communicate back to you, and we'll be very open, honest, and transparent about the findings of the incident report. So you do apologize, duty of candor, and incident report at the start. Now, the second situation is, Dalia, that she doesn't know.
Yes.
She's only having vaginal bleed, and she doesn't know that it's a pregnancy positive, right? So then you take the station, take information gathering, and before coming to the management and telling about the scan, there you start with apology and then tell her the diagnosis. that it was a misdiagnosis, so I apologize. So then at least your information gathering would be secure, and you'll do that without any burden of an angry patient. So after diagnosis, she would getting angry, right? She would be getting angry. So there you can put the incident report. Always remember, if patient knows that and she's angry, do it at the top. When she doesn't know that, secure your information gathering domain and then do the information gathering. Okay? Yeah?
Okay, thank you.
Okay, thank you very much. Thank you. Right. Yes,
in this case, one of the differential diagnoses was said to be another new onset of pregnancy.
Yeah.
But it has been only 3 weeks since her medical evacuation.
Yeah. So actually, after 3 weeks, ovulation can be back. So this would be like lower down. So it can be a positive UPT, a new pregnancy as well. So this is said that after 21 days, pregnancy can occur. So the ovulation, that's why it is always said to start with the contraception earlier, that the patient has a risk in 3 weeks time.
Yeah, within 7 days.
Yeah,
so
yeah.
we are considering it to be a very, very early pregnancy.
Very
But
early
ma'am,
pregnancy.
a very early pregnancy, will it bleed that much?
No, that's why we are putting it down in the differential. I mean, it is one of the differential, right? Only differential. So yeah.
Okay, ma'am, and it was said that cervical preparation will be done with misoprostol. Is that correct? We can't use misoprostol before evacuation.
Yes, according to the GTG, it says that you can use that, but don't use a prolonged misoprostol. Immediate priming and softening up the cervix can be done, my dear.
But ma'am, that will be with dilators or misoprostol. Will it help? I mean,
yes.
Supposed to use.
Yes, generally we do that in the medical evacuation, right, to soften up the neck of the womb.
Yeah, but I mean, how prolonged? Usually we
immediately
do it like
they say like 4 hours earlier to the procedure. You put even 800 micrograms. It softens up. Yes, it softens.
So will we do that over here in this case?
No, we can give the option. Like, it is a structured discussion, right? So immediate priming can be done depending on the condition of the. It depends on the examination. Would it be required? So if it's not required, it's fine. But rather than causing a perforation, it's always better to soften up the cervix prior, as per the clinical practice.
Okay, so how long before can
that
we start, ma'am? What is prolonged then in this case?
No,
in case
you simply say,
molars?
like we do in the medical, like doing that. If she's bleeding heavily, you're going to do immediate. But if you're planning in a stable patient, you're planning a section evacuation maybe after 1 day or 2 days. You're not in a hurry, so you start putting the misoprostol like 2 days earlier. So it's not something which is not desired. That you keep on doing that and then you go for the suction evacuation.
Yeah. So just 3 to 4 hours earlier we can do it.
These hours I'm saying through the clinical practice. The GTG only uses the word immediate priming can be done. Long term should not be done. This is what the GTG says. Exactly. Okay. Right.
Okay. And ma'am, can we give
say around 3 to 4 hours earlier? I'll keep a little tablet down below to open your neck of the womb.
Yeah. For an SPT, you would say that after assessing your neck of the womb, we would see that if it requires to be softened up, we can use few hours earlier to the procedure, the tablet to soften it up. That's it. Okay.
And ma'am, according to the newer guideline now, it says that even hormonal contraception can be used in cases
Harshaba, this is a question which I always get from my part 2 students as well. Remember that whenever the idea of doing the priority in terms of the recommendations, we've always followed the Green Top guidelines as the top. The Green Top guideline is an older one, I agree, but it has not been updated. The FSRH, Faculty of Sexual and Reproductive Health, that says that COCPs can be used earlier. And I always show that screenshot in the session to the students as well, that it does say that you can use even the copper coil. But in SPT, don't say that because the GTG has not been updated. The moment GTG recommendation would agree to FSRH, we will change our recommendation in exam as well, my dear. Okay, so we have to follow GTG. We cannot give preference to FSRH on GTG, my dear, as per the college pattern.
Okay.
Thank you. Thank you, sweetheart. Thank you. Any other questions, please? Divya, you had unmuted somewhere in between. Yeah, you want to say something? No? Okay, Midhat, you raised your hand, please. Yeah, Midhat.
I'm good.
Okay, thank you, Divya. Midhat, you wanted to ask something? Okay, Shaheen, how is it going? Shaheen. First session for Shaheen, huh? Hello, Shaheen. Unmute yourself, Shaheen. Did you understand, my dear, the difference between the structure, discussion, and how it's going to be? Okay, fine. Thank you very much. Okay, no problem with it.
Ma'am, I want to ask something.
Sure, Liana, please.
Okay, if the question asks prior to these presentations, it means the first presentation patient came in with vaginal bleeding. She has underlying ITP with very, very low platelet. So the management is for the miscarriage, do we go for medical or surgical? Which one is better, ma'am?
What is the diagnosis?
The diagnosis at that time miscarriage with very low platelet because she's got underlying ITP. This is my real exam scenario last time.
Okay, whenever there are low platelet counts, you always see that are you able to go with the anesthesia? So regional anesthesia cutoff is to be more than 50,000, and if it's less than 50, you can go with the general anesthesia, Liana. You can go with the general anesthesia. If she's heavily bleeding, you have to go with the surgical evacuation. If she's stable, you can build up the platelets and you can give medical evacuation as well. So it depends upon the amount of the bleed. If it's an emergency, go with the surgical evacuation. If it's not an emergency, it's fine that you go with the medical evacuation as well. Keep your platelet concentrates ready. Keep them above 50 for the patient to be safe. All right.
Ma'am, in case of a simulated patient task, if the same patient is there and if she's stable and she's not bleeding, will we give her both the options of medical and surgical and ask her to choose?
Yes. Always give all the options. If she's not bleeding fine, even the expectant management is there. If it's a missed miscarriage, of course, if it's a suction evacuation, if it's a molar pregnancy, then of course it's evacuation. Okay. Okay. Right. We'll do one case on molar SPT today, right? It would be just coming next. So I'll discuss all the lines on there. All right.
Okay, Dr. Seda, just one question for this. If in this case, for the case of missed miscarriage, if she has a medical condition like any risk for bleeding, this medical evacuation should be in hospital, not at home as usual.
If she's bleeding, yes, it has to be.
No, if the patient has risk factor for bleeding, like idiopathic thrombocytopenia, hemophilia.
Yes, it has to be inpatient. Whenever patient low risk, only we send with misoprostol back home. If she is a high risk patient, or if the patient has a tendency to bleed for any reason, or the chances of going into surgical evacuation is more, you always give under your supervision the misoprostol.
Oh, okay.
Okay, thank you very much, Dua. So as per the grading, applied clinical knowledge is 2 by 2, my dear. Communication with the colleague. Yes, it was mentioned about the consultant and the hematologist. Those 2 points make you pass in that. And your patient safety was 2 by 2 as well. Very good pass station, Dua. Just a little polishing for your initial assessment, my dear. And I'm sure in exam you'll do great. Thank you very much for doing a wonderful station and a pass station. Next time, be ready for an SPT and a little difficult SPT. Okay, Dua? All right.
Thank you, Dr.
Thank you, sweetheart. Thank you. Fawzia, for contraception, as per the Green Top guideline, we have to say that it is going to be a barrier method for simulated patient task. Once your pregnancy hormone gets back to normal, it would be, you can use the copper coil or the combined pills as well. And for a structured discussion, you would say that I will suggest my patient to use the barrier method for the follow-up. And once the beta HCG gets back to normal, she can also take the combined hormonal contraceptive pills, and the intrauterine copper device can also be inserted. So this is as per the Green Top guideline recommendation, my dear. Okay, Fawzia? Clear, my dear? Okay, so Fawzia has a station today as well. Right, okay. So thank you very much. Now let's go to the 4th station of the day. Oops. And I've changed the station slide. Okay, so who's this? So we have Ramya.
Hello, Sidra.
Hello, how are you?
Thank you.
That's wonderful. So learning well? Yeah?
Yes.
How had the Skype meetings been going?
Yeah, it's going good.
Okay, very good. Well done. Okay. So let's start with the 2 minutes time and let's see what do we have for Ramya. Okay, so group C, let's see, how do you people do? Go ahead.
Okay, next slide. Can I have the previous slide? The previous one.
Start, please.
Hello, I'm Dr. Ramya, one of the doctors in the early pregnancy ward today. Can I check your name and age, please?
Yes, hi, doctor. I'm Mrs. Annie Thomas. I'm 27 years.
Okay. How may I address you?
Yeah, Annie is okay.
Okay, Annie, I have gathered from your case notes that you are that you're 6 weeks pregnant, and also you have come with the reports of the previous pregnancy. Is it right?
Yeah, exactly. It's my third pregnancy, doctor. And I didn't have some good events in the previous pregnancy. I'm really scared. I'm having nightmares that same's gonna happen. Please I'm desperately in need of a baby now.
I'm so sorry about what has happened in your past, and surely in the next few minutes we'll be discussing about your concerns, and together we'll formulate a safe and mutually agreed management plan. Is it okay if I ask you a few questions to know more about you?
That's fine, yeah.
Annie, can you tell more about your previous pregnancies?
The previous pregnancies, my first pregnancy was in second half. It was around 15 weeks. The heartbeat could not be seen, and I had to undergo, they gave me some tablets, and it was the pregnancy ended up. My second pregnancy, I had proteins in the urine, doctor, and but it went fine till 32 weeks. And then the baby heart again was not there. I was having headaches and flashing of lights, and they said that we need to deliver the baby, but baby was born without heart even that time. And now I'm pregnant again. It's been 3 months. I was planning a little contraception, but I just conceived spontaneously, doctor.
Okay. So have you booked your pregnancy, Annie, for this time?
Yeah, I booked to the midwife, and a few investigations for the last time was also sent. I'm not aware of that. And the midwife was saying that it's a high-risk pregnancy. I would be followed in the hospital.
Of course. And have you started on folic acid, Annie?
I did, yeah.
Okay. So have you started on any other drugs other than folic acid?
No.
Okay. Okay. We'll be discussing about that. And is there any other medical illness that you're following with GP?
No.
Okay. And any other family history of concern you would like to share with me?
No.
Okay. And any other surgeries done in your tummy or down below?
No.
Okay. Are you aware of any allergy to medicines?
No, doctor.
Okay. And do you smoke, drink alcohol?
I did smoke, but GP told me not to do that because of these events. So I have stopped smoking. It's been around 4 months, doctor.
Okay, I appreciate that, Annie. Pardon to ask, any recreational drugs?
No.
Okay. And how is your support at home, Annie?
Yeah, support is good. My partner is really loving, but it's again and again having these unfortunate loss of pregnancy that's causing me a little stressed up.
Yeah, yeah, I can really understand how distressing it will be, and we'll be here to support you, Annie, throughout. And how have you been feeling mentally in the last few weeks?
Otherwise I'm okay, but it's been just the moment I got to know that I'm pregnant again, I'm having nightmares. I'm having this feeling that again this pregnancy would be a loss as well. Again, I would be in that trouble. So this is giving me a headache.
Yeah, and we'll be really supporting you in in making this pregnancy an excellent one. Okay. And do you want to put up with any counselor today so that you feel better?
Thank you, doctor.
Okay. And are you aware of your weight to height ratio, Annie?
Yeah, that's okay. There's 23.
Okay. Is it okay with your permission? I would ask my nurse to check your blood pressure and record your pulse rate. Is that okay?
That's all right. Yeah.
Okay. Thank you. Thank you, Annie. And I'm having your reports now. Just confirming this is your report. And the postmortem report of your previous baby shows. So overall, the baby is normal by appearance, and it's all there is no abnormality detected with any of the internal organs also. but they observed a large blood clot that suggestive of abruption, which means your afterbirth is separated in advance before the birth of your baby. Am I making sense, Annie?
Oh, but why did it happen?
Yeah. Also, yeah, I come to that, Annie. We also have a blood report that shows something called as antibodies of special proteins, which is also positive, and that could be the reason I afraid this blood clot to happen, and because of and also the separation of afterbirth before the birth of the baby. Okay.
The proteins.
Yeah, I'll just explain to you, Annie, about that. Is it okay? Can I proceed?
Okay.
Okay. And you know, we have our own defense system that protects against all infection through producing a specialized proteins called antibodies. Okay. In some situations, these antibodies are produced against our own body cells. If these antibodies are produced against some fat cells, we call as an antiphospholipid antibodies medically. And in case if these antibodies are positive in any woman's in any persons, we call as a sticky blood syndrome. In such cases, you know what happens? The blood in the blood vessel, they tend to form a clots. Okay, am I clear?
All right. Okay. So do we have any treatment for that?
Yeah, definitely. So I could see this is positive. You remember whether these tests were done twice for you? This APLA antibody test.
That was what, doctor?
The blood report, the protein test, what you tested positive for you, right?
Yeah.
So it has been 3 months since your last pregnancy.
Yeah.
I would really like to confirm, are you aware that these tests have been done twice for you?
In pregnancy now?
Not in pregnancy, of course. I mean, so just before that, you remember how many times they have taken this test?
No, it was just once the blood tests were taken after I gave birth to the baby.
Okay, okay. That's okay. And so these antibodies, we call this as a sticky blood syndrome. Only we confirm the presence of these antibodies twice in the body, twice in the blood. Okay.
Okay, okay.
So these tests has to be done twice at an interval of 3 months to make sure you're having this a problem. You're having this condition. But in your case, you're having a history of previous high BP, and there is a premature separation of your afterbirth before the birth of the baby. All these events, right? Your pregnancy events more likely suggest there is a high likely chances that you are also having this condition of APS, the sticky blood syndrome.
Oh yeah, what is the treatment? I mean, I just want a healthy baby. Can
Yeah,
you help with that?
Yeah, of course. So this is going to be a high risk pregnancy, as your midwife rightly explained, and we will be giving a specialized tablet we call as an aspirin, and it will be right now prescribed by me to you, so that we have to start taking this baby dose aspirin from now daily once. And along with that, there is a special injection we call as a low molecular weight heparin, and we used to we will prescribe that to be taken once daily. So from now, so what these injection actually means, right? It tends to thin your blood. They are basically blood thinning agents that will prevent the blood clots being formed in your blood vessel. Okay.
When would you start that?
We'll start. We'll confirm we'll have a basal ultrasound scan done for you, and we'll confirm the pregnancy. And right away, I'll just put you across with my consultant advice as well, and we'll start as early as possible.
Okay. Okay. So would it be a cesarean section?
And yeah, it will not be a cesarean section, of course. So you will be continuously following under our consultant care in a hospital. You'll be having a frequent hospital visits to check for the baby's growth, and you'll be offered a frequent antenatal visits and frequent scans for the baby to check for the growth of the baby. And we'll be monitoring your blood pressure as well, because there is high chances that you may be having a high blood pressure in this pregnancy as well. Okay. At around 36 weeks, we'll be assessing you, and then we'll be discussing about the mode of delivery, not necessarily having this condition that you may need to really undergo a cesarean section. Okay.
Okay.
Most of the women who's having this special antibody positive, when started on this specialized drug, they tend to have an excellent pregnancy outcome and a healthy baby. Okay.
All right.
However, you have to be under a follow-up and have to be under frequent visits with us. Okay, and we'll be checking your blood tests, urinary function tests, liver functions as well, and we'll be following you up here under consultant care.
I get that, doctor. Okay. So today, need I take some medicine?
Hello.
Today, need I take some medicine?
So I'll be giving you prescription for the folic acid and an aspirin and the low molecular weight blood thinning agent, as I already discussed with you. Annie, is it okay? Am I clear?
Yeah, I get that. Okay.
Okay. And this is the information leaflet regarding this APS blood sticky blood syndrome, so that you'll be having a better idea. And in case any doubts, you can come up anytime here, and I'm here right now, happy to explain you all your doubts.
Thank you, doctor.
So, do I need to address any other concerns for you, Annie?
No, that's fine, doctor. I understood that. Okay. Yes, Ramya. How was the station?
I don't know. I was not organized.
Yeah, I understand. So, Girija, Jyoti, does she run like a bullet train in the mini group as well? Is this bullet train the same as she does with you, or is it only with Sidra ma'am?
No, this bullet train slows down sometimes, but inherently it is like that.
I have noted down the times, I think Dr. Sabia needs to do station with Ramya. So Ramya gets slowed down and Dr. Sabia goes faster. So I think I should make this combination of both, both extremes were there. At
yeah, somehow I need to reduce my speed. I understand that.
You have extremes. So you have to correct both of them.
At 5 minutes and 30 seconds, I've noted down the time, Ramya. You have to go through the recording. At your station, 5 minutes and 30 seconds. Then
I can't go through my recordings. I'm so sorry.
And
you know, Dr. Sidra, what is the best solution? Put both of them in one container and then mix it.
And at 7 minutes, you were beautifully telling about that I'm upset and you're going to tell me the support, and you said that we are going to provide you the support, and the support is going to be with you, and we will be there as a team of doctors. And I was like, you're providing support, but don't throw stones on me. I mean, it's fine. Take a pause somewhere in between. Ramya, see, beautifully done station. Just hold on, a little breath somewhere in between. A little ups and downs somewhere in between, sweetheart, rather than speeding up. Because see, if you're giving it information and the patient is not getting that information, at times you're talking the words or the concept is very nice, but it is such in a speedy manner that it loses its effect on the patient, right? So it loses the effect in the patient. Once when you sent me the introduction and agenda, I remember I told you to speed up. I didn't know that why are you taking, but today I understand. Today I understand that actually you were trying to cover this up. See, Ramya, I've got many good points, but in this tone, maybe the patient is not getting the effect of empathy,
Yeah.
This was a sad station. So if you're running through the station, the impact would not be like of that of empathy, right? All the points which you spoke were like star points, but the effect of those points would not be taken by the patient, because she would be like shaking her head that where to get the point and where to follow the right? So try and be a little slow. I won't say very slow because time management has to be there, but a slow, specifically when you're taking something about support, telling about something, we are here to listen to you and support you, Annie. Rather than we're here to listen to you and support you, Annie. So it doesn't give an impression. Right?
Of course, yeah.
So we'll just work on this thing to be a little slower, and the concept which you had, I mean, the things which you spoke were absolutely fine. Okay, I'm not telling about any of the applied clinical knowledge or the patient safety. They didn't have an issue. They didn't have a problem. But the problem was in understanding of the patient. If you'll be faster. Okay. Yes, Dr. Sabia, well done. Without only the speed needs to be a little in control. Okay.
Jyoti likes to say nervous, and that's why the speed is faster. She's not as fast usually. She is fast, but she's not as fast as today. So really? I think she was nervous.
I thought that Jyoti and Girija are used to of this bullet train, maybe, so they are not picking it up. So this was something unusual, huh?
No, we had
Dr.
earlier
Sidra's
told her a
tension.
lot of times about
Dr.
the speed,
Sidra's
but now she
tension.
had slowed down.
Okay.
No.
No.
Girija and Jyoti always they used to tell me to slow down, but somehow I enter into station, I forget about the speed, all those things. I just accelerate the speed.
I'm always slow and she's always fast.
Yeah, and I'm in between.
So the point is that, whatever you're saying should be understood by the patient. That's the point.
Of course, yeah.
And the ups and downs in your tone, the working in your pauses and taking breath somewhere in between, that's very important. So Ramya, is it your general habit, like otherwise as well, to be a little quick in speaking? I mean, generally,
I'm inherited like that only. I'll talk very speed.
Right.
Initially, my husband used to be get struggle now, to understand me. You speak a little bit slowly. I couldn't understand you.
Okay, so you have this habit of speaking quickly. The only thing in exam is that it is very good that your flow is good, but we have to slow down a little so that patient understands that. Only that thing. Okay? So I'll note it out the times where you'll go that, and I'm sure I'll work on that as well. So at the beginning, introduction was fine. Agenda making was fine as well. Go onto the mute mode, friends. There's a little distortion. Okay, let me set that. All right. So when we talked about the introduction and agenda, that was all right. And you did say, I'm sorry in the beginning about that. And you asked about the previous pregnancy to begin with. You can also ask about the previous pregnancies or the current pregnancy. Both are the presenting complaints, so that's all right. You did say, I'm sorry that you have been, when I told you about the previous pregnancies, go through the recording, Ramya, when you said that, I told you that first pregnancy, I had this problem. In the second pregnancy, I had this issue. You said that, okay, so for this coming to this pregnancy, so please do acknowledge that there. I'm sorry that you've been through a lot. We are here to support you, Annie. Okay. Then folic acid, you did mention about the drugs, Annie, taking medical history, family history, surgical history, allergy. You said, I appreciate when I told you about stopping smoking. That was very good. You did ask about the support. That was very good, but you did tell about the support at 5 minutes of 30 seconds of yours when you were coming to the management plan. You offered me counseling as well, but that was very quick. I mean, the effect of the support I could not get. I was like you are in a hurry, and it's just like for the sake of saying, you're saying, have some emotions in your words so that patient feels that, okay, it's support being given, okay? I'm not being scolded on that. It's support being given, okay? Very good. You asked about the BMI, my dear. And you did ask about the examination as well. That was very good. Now, you did confirm the investigation, the name and the age. Anything you would put as Leah here? Ramya, why is your name appearing as Leah?
Jyoti, my daughter's changed the Zoom name. I don't know how to change that.
Jyoti, so this is Ramya's daughter.
My daughter's name, yeah.
All right. So love to Leah from all of us side. Okay. So Ramya. So Leah is saying, don't change my name, huh? Don't you dare.
Yeah, that's what she's saying.
Okay, right. So anything before explanation of the diagnosis, you all would do that? Anything before diagnosis, you would do that? I would like to do a little bit breaking bad news, Ramya.
Okay.
It's a bad news for her that she's having some sort of a syndrome. So breaking bad news was expected.
Actually, Sidra, I got a confusion whether because she's having only one report with her, so I was confused whether to go ahead with
when we take yes, you're absolutely right that they should be 12 weeks apart. A second report.
And now she is also pregnant.
Exactly. Had she been not pregnant, you would have asked for a second report. But now she's pregnant with a characteristic history of APLA. Go with the treatment as you correctly did.
Okay.
Okay.
So I could not be
do a breaking bad news and tell her the diagnosis of a sticky syndrome, and then come to the management plan. So it was a high-risk pregnancy. You started aspirin. Now that was very good. Aspirin has to be started as soon as the urine pregnancy test is positive, remember. Then you started with the blood thinners as well. That was again good. You connected to the counselor. Today you started with my folic acid as well. That was all good. Now coming to the points to improve. In the family history, as remember that Dr. Sabia took the history of the clots in the legs and the lungs, and I told her that in pregnancy of unknown location, what made you ask me this, right? So this is the case. In family history, you can ask characteristically. So just to know any history of blood clots in the family, in the legs or the lungs, because now it is suitable to ask this question. She is a high risk case, okay? Yes. So this gives you a clue that some sort of thrombophilia is going on. Now, in the management plan, before coming to the explanation, I would do a breaking bad news signposting. And I can see that you're here alone today. Would you like somebody to accompany you during the consultation? I have some difficult news to talk to you today. So can I proceed? So one more thing, Ramya, when you say, can I proceed, take a breath there. When you say, can I proceed, and you start the next sentence. So that's, you know, asking the information, okay? You have to take a pause, my dear, there, because you're asking something. So you said that, can I proceed somewhere in between? And without my even saying, yes, doctor, or even if I'm in front of you without nodding my head, you immediately said your next sentence. So that means that your can I proceed is just for the sake of saying and not for seeking permission. So work on this, okay? When I say, can I proceed? Yes, sure. Just take a little breath there, just 1 or 2 seconds, and then move to the next sentence, okay? Right. So then your explanation to antiphospholipid was fine, but it was so speedy that I could not sense empathy in that. I could not get empathy in that explanation of the antiphospholipid syndrome, okay? And one more sentence which I had put a circle on, when I said the doctor is gonna be a cesarean section. Why I was going through that, because I know that I've guided you guys for the early pregnancy care template. But somewhere it was an overlapping of an antenatal care and the early pregnancy. Am I right? So Ramya, we know that in early in the maternal medicine or the antenatal care, we go through the antenatal, then intrapartum, postpartum, and we come back to today. Right? So yes, that's why I gave you a hint that please go forward with the antenatal care, then what you will do just in 5-10 seconds, then intrapartum, postpartum in 5 seconds, and come back to my 6 or 8 weeks of pregnancy, what I'm having now. So this was a little overlapping. Remember, early pregnancy, if it's like ectopic or miscarriage, it's fine. You deal it there and then, and that's over. But any pregnancy, if you're taking forward, please take the journey through the antenatal care, then intrapartum care, and then postpartum care. Okay, and then come back to today. Don't end up on breastfeeding or contraception. It gives a foggy ending to the station. You have to come back to the today's task and what she has to do that. And beautifully you did the aspirin and the low molecular weight heparin thing, right? When I said that, doctor, would it be a cesarean section? So the answer was, it will not be a cesarean section, of course. Yeah. So at this point in time, we can never say. So the right answer, remember, in a pregnancy patient at first trimester or even in second trimester, if the patient asks you, doctor, would that be a cesarean section? And you cannot say completely with the confidence that it won't be a cesarean section. The answer you have to give is, because we are not sure, there can be other reasons as well, right? So what you have to say, it's way too early to discuss about or to decide about the mode of delivery. However, only this condition of yours does not necessarily mean that it would be a cesarean section. If there would be some other indications, we will discuss about you around 36 weeks and we'll talk about the options available, Annie. Would that be okay? Okay. So remember that whenever you are in the first or the second trimester dealing with that part of gestation and the patient asks you about, would that be a cesarean section? Never say that, of course it would not be a cesarean section. You tell her that it's way too early to decide or to discuss about the mode of birth. However, only having this condition does not necessarily mean that you will undergo a cesarean section. If some other indications would be there, we will discuss with you about the options available at that time. Am I clear about how do you answer the patient? Am I clear, everyone?
Yeah, clear.
Yeah, yes, thank you very much, Ramya. Thank you. So these were the points which I've noted. Now I'll come up with these few things which I have to explain. Anybody would like to take a chance to explain antiphospholipid antibody? Or should I do that? And the management plan which was missing?
I'll do that, Dr. Sidra.
Divya, go ahead.
We were just discussing the other day.
Yeah.
All right, antibodies, this is how I would like to explain to my patient. Antibodies are cells that are produced by your body to fight against infection. However, sometimes these antibodies start working against your body's own tissues. So antiphospholipid syndrome occurs when antibodies start working against your body, and this will result in blood clots in your leg or in your blood system.
Okay, very good, well done. So I will tell about two things first. What is immune system and what is autoimmune system? So I would say that immune system, this is any, right? We have our immune system, which produces the antibodies, and this make us fight against the infection and the illness. But at times we have some autoimmune condition, which means that the immune system, which generally protects the body, it starts acting the healthy tissue by mistake. I'm sorry, this is the condition which we are having. We call it as antiphospholipid antibody syndrome, which makes the blood grow stickier, and this in which the unwanted blood clots are formed in the blood vessels. Now, definitely you would like to know, what does it mean to you, Annie? I'm here to tell you that these blood clots can be formed in the artery, which can cause the stroke. In the veins, can have the blood clots in your legs and lungs, and in the afterbirth, which can cause the loss of the pregnancy as well. Am I clear about this? So basically now you have to tell about the antiphospholipid syndrome, that where can be the clot formation and what does it mean to her. Now I'll come to the part. Remember, rule out other autoimmune diseases. No, Dipti, in this station I won't do that, she's pregnant, but otherwise you just have to go with this, right? Yeah, Girija. Okay. So now when I'll take this, remember, whenever there's an antenatal care patient or there's a diagnosis in which you are moving forward, always tell about what it means to her and what it means for the baby. So this part was also missing, which I wanted in the applied clinical knowledge. When I'll give you the template today, whatever is the situation in the maternal medicine, remember, take an introduction, give an introduction, make an agenda, start the information gathering, and if it's a diabetes, if it's a sickle cell disease, if it's any sort of syndrome, please tell what it means to the mother and what it means to the baby. Okay, so I'll tell you about how you have to proceed in the applied clinical knowledge, and we'll improve it together because there was a little overlapping. So we have to bring in and incorporate the antenatal care template in that as well. Communication with the patients and the relatives, friends, it went well. Greeting was fine, rapport building was fine. BBN was not done. I wanted to do that. And in communication, if it would be better, like a little slowed down, then even the other domains would be passing as well, so that the understanding is better. And definitely, Ramya, I'm going to work on that. And maybe once a week, do give me an opportunity to understand the pace somewhere. Like, okay, send me a voice note of any information gathering maybe, or send me a voice note anywhere, somewhere in between about some applied clinical knowledge, some bits and pieces, so that I can see that you're going in the right tone. Okay,
sure,
I would be rating for that. Okay. Now, information gathering, the general questions, how was the pregnancy diagnosed and the periods and all. This thrombophilia history, please do take in the family history, as Dr. Sapia did in the first station. So here you have to take that. It's going to be a team of doctors taking care of you. You did say it's a consultant-led care. You would be done. 2 reports you're going to ask. If it's pregnancy, it's fine. If she's in the non-pregnant state, in one of the case in exams as well, she's not pregnant, only with the reports she's here for. So you're going to say that we will be repeating the test now again. Now, regarding the applied clinical knowledge, how I would be moving from this station would be explanation of the I would do with the breaking bad news, as I've just done a few minutes ago. And then I would tell her about the effects on the pregnancy. So I would say that in terms of the condition having any effects on the mother, it can cause an early pregnancy loss. There can be the proteins in the urine, and the baby can be smaller in growth than the duration of the pregnancy. The baby can be dying in the womb as well. The possibility of having clots in the legs and the lungs. You can go into labor earlier than the due date. And along with that, in rare conditions, that can cause death of the women with this condition as well. For the baby, the early pregnancy loss is there, and due to the decreased blood flow to the afterbirth, having clots inside, it can also decrease the fluid around the baby. The babies are having low birth weight, and that can also lead to the pregnancy loss and death of the baby. Now, would tell you that how we are going to take care of this condition in the pregnancy journey. So to begin with, we will be starting with the team of doctors care. And it would be including my consultant and the blood doctor as well, and a specialized midwife to take care of you in this condition. We will be starting with the baby aspirin from today, and as soon as we confirm the baby heartbeat, we will be starting with the blood thinners. You will be guided about how to take that initially, and you can then take that on continue on your own as well. On each visit, we will ensure that we check your blood pressure and proteins in the urine, and you will have the ultrasound, your down screening, the mid-pregnancy scan to check that the baby is formed fine, and serial growth scans to have a look on the baby growth as well. Little general advice I would like to give you, Annie, that maintain the healthy weight and having a healthy diet and stopping smoking. That puts the improvement in the state of the patients as well. Now at 36 weeks, Annie, we will discuss about the care plan of the labor. It is going to be a consultant-led unit delivery as well. We'll keep you well hydrated to decrease the chances of having the formation of the clots. Are you with me? All right. So once the baby is born, we will encourage you to have an early mobilization. We'll give you the compression stockings. We'll encourage you to breastfeed. And as far as the contraception is concerned, we'll discuss with you the plan. However, the combined pills would be avoided. Now coming back to today, I'm going to prescribe you the baby aspirin. We'll fix an appointment with the blood doctor and my consultant, and we'll plan for the ultrasound to see the baby heartbeat so that we can start with the blood thinners as well. Any other questions for me, Annie? Ramya, how is the management plan? When systematic? Yeah, when systematic? Okay. So my point of view is that I know this was a change of early pregnancy, but it went like a sequence, right? She's already pregnant, Girija, so we cannot repeat, because in pregnancy, the antibodies, they get a deranged value is there. So according to the history and one report, we'll take her positive. All right, we'll take her positive. So this is how you move in the explanation. I want my each student to be as systematic as possible in the explanation. I should see a difference in those free groups and my students, that my students are better than others. Again, I would say it's a competitive exam. So we have to be at the top of the practice so that if one has to pass, it should be Ramya in exam. Yes, Ramya? Okay. So starting with that, my dear, go with this flow. And I'm sure you all would do perfect. Okay. This antenatal care, interpartum and postpartum, it is not an early pregnancy, but whenever you are continuing with a pregnancy, just give 10 seconds or 15 seconds for this. 5 seconds for this, only 2 points, right? But touching this is very important. Only 5 or 10 seconds for this so that you go in a sequence, you go in a systematic manner, and you prove yourself to be an organized candidate. All right, Dr. Sabia, yes. So you would be different in a different circuit, Dr. Sabia. That's why I didn't mention you. So in your circuit, you would be passing, right? So let's have a matchup. Dr. Sabia, do one station, message Ramya and do one station with Ramya, so that you do one station with Ramya and Ramya does one station with you. Okay, that's my suggestion.
Okay.
To both of you.
Okay, agreed.
All right. Okay. So wonderful.
Sidra, I have questions about this station. If you finish your, I can ask.
Yeah, yes. Just give me 1 minute for outline. So how do you divide the station? Introduction, agenda, a quick focused information gathering, do a breaking bad news, then tell about the effects on the mother and the baby, then manage the condition, offer support, give general healthy advice to her in just 2-3 seconds, and go through the journey of antenatal, intrapartum, postpartum, tell about the future plan and the information leaflet, and your job is done. Okay, as simple as that. And I'm sure it would be perfect once we'll do it again. And this station, if it comes, you'll be perfect in your management plan. Yes, I'm open for the questions, please. Yeah.
Dr. Sidra, as this is done only one antiphospholipid antibodies and one test, and you said because she's pregnant, so we start treatment because of clinical history and one antiphospholipid antibody test.
Because the benefit of doubt we'll give to the patient rather than having a pregnancy loss. You know.
So after the delivery, we will go ahead for the confirmation.
You can do that. Yes, you can do that after delivery. You can do a second second test as well. Yes, second test. Yeah. But don't mention it there because at the moment it's you have to concentrate on the management plan of the pregnancy.
Okay. Another thing is that the article what you said actually, I read that one day they mentioned before my understanding was that when the pregnancy is confirmed and there is heartbeat, It was maybe the old management that we start when there is a heartbeat. But the new, I read the new article. They said whenever the pregnancy test is positive, even before the scan, start giving the Clexane and aspirin. Aspirin maybe you can give even before the pregnancy. It's mentioned in the article actually.
Yes. Remember, the new applied clinical knowledge says that the moment patient is pregnant, you come to know that she's pregnant, start with the baby aspirin. Another important thing is when I was doing that with my my June batch yesterday, the student, she started aspirin at 12 weeks. So that was failing applied clinical knowledge and failing patient safety. See, 12 weeks is not for antiphospholipid antibody. That is for the hypertension preventing preeclampsia. Okay. So I just wanted to clarify to all of you that students, they do make this mistake under stress, because generally
APL, I'm sorry to interrupt you. APL, it's clearly mentioned that if APL is confirmed even before the pregnancy, you can start aspirin even before.
Very good. Yes.
And Clexane with the positive pregnancy test.
Yes. Why? Because we do know that basically the antiphospholipid antibody syndrome, the early miscarriage chance is there. Yes, but when we talk about the moderate or the high risk factors for the developing of preeclampsia, then we start at 12 weeks time according to the NICE guideline table of hypertension. Okay, that's a separate indication. Okay, any other question, please? Yeah.
So yes, we discussed a very similar situation. She had 3 miscarriages, and one anticardiolipin antibodies was more than 40.
Repeat after 12 weeks.
Had her second test.
Yes, always repeat after, according to the Sapporo's criteria, you always repeat after 12 weeks and 2 positive tests that advocate that you start with the aspirin in the pregnancy.
The thing is, in that station, do we counsel her for RPL or do we proceed with APLA?
You counsel her for recurrent pregnancy loss. If it's diagnosed with APLA, then you go with the management of APLA.
One test, and her first test has turned out to be ACL positive.
No, then take as APLA. Then take as APLA and say that we'll start the management and plan it further. However, after 3 months' time, you're going to repeat another test as well. But as compared to the history, it is unlikely that the result would be changed.
All right.
Okay, thank you.
And also, Dr. Sidra, in that patient, do we start her on aspirin immediately? Because she's planning for a next child.
In the preconceptional period, you can avoid that as well, like 3 months. As soon as she gets pregnant, tell her that immediately you have to start that.
All right. And do we ask her to wait for the confirmation test to start trying for a pregnancy? I'll try and forward that station in the group.
Yeah. So what you have to do is that as soon as the urine pregnancy test is positive, you can start that. Even if she has a little overdue, she can do that. That's not a problem.
Okay.
So ask her to see you without any delay as soon as she becomes the periods that become overdue. Okay. Any other questions, please? Yeah.
Yes, Dr. Sidra, the table that you put up, it's like the gift that you give for part 2. We need that for all cases you put.
Which table? This one?
Yeah, something like this for every case. We are going to print it out and make a book out of it.
There's these templates. Yeah, this algorithm, whenever I'm making, I have to practice like doing these animations, because at times I give 1 animation to this and 2 animation to this. Then I have to go back and say, no, arrowhead has to be 1, 2, and this is around, if you only take this slide of mine, this is around 32 animations in this one slide. So I have to give animations accordingly because it goes stepwise, But I'm happy that you people understand this way well. So I give input and, I give my effort on that. I'm glad that you people, memory would be better, Divya. After this, the memory and, the things would be better. So I would try my best to give maximum to you guys, my dear, because
actually,
I'm telling you, this is going to be the thing that we depend on before the exams. Because this is going to be that fast.
Actually, we like algorithm. They are, it can summarize in 1 page only.
I'm grateful, my dear.
To revise it is, to revise, to make revision.
Understand. See, I understand. I understand.
Hello, Dr. Sidra. I want to ask one thing.
Please,
is there any need that we have to speak in 1 line about how to inject the heparin, because there is not the tablet only?
We'll just tell for the future, because if she says that I don't know that, you said that we are here to guide you first, and then you can do that on your own as well. If she asks that, even if you say that this would not be, or at the moment you're not giving that, you can skip that point, but you can say that the blood thinners would also be given to you. So mentioning blood thinners is important. Yeah, how they would be given, you can mention, you can skip that as well. That's fine, Sarvit. Because today you're not giving. If she says that I don't know or something, like, you can say that don't worry about that. We would be guiding you from the start that how you have to take those or do those injections, and further on you can carry on your own.
Still, I'm confused about this. Is heparin should be started when pregnancy test is positive or when the fetal heart is seen?
Generally, the blood thinners should be with the heart. Why? Because the bleeding risk is with the blood thinners. Aspirin is started, but Dr. Sabia, have you seen the line of both starting with the UPT positive?
Yes, the article you sent, it's written there. Even my understanding,
I think me and Dr. Sabia, we read together that article. I think there was something. That's why I'm getting confused now.
Actually, Dr. Sidra, I will tell you my old, because my old understanding is that we will start this Clexane with the when there is heart is positive. Okay, but just with your article, we read that. Even I discussed with Sarvat also, that you see, Sarvat, before I was thinking that my old knowledge is that we will start it when the heart is positive.
It's my mind. That's why I'm confusing now. What it was.
Dr. Sabia, you have to post one table of that incident report, and second table you have to post that screenshot from that part so that we confirm. My patient safety is that aspirin would be started as soon as the pregnancy is diagnosed, without even knowing the heart. And on heart, blood thinners are started for the patient safety. Jyoti, you can help us in this as well. Jyoti, where are you? Jyoti works in that part in Jyoti.
I will do that.
Yeah, I'm here.
Yeah. So what do you say about this low molecular weight heparin starting on the fetal heart positive?
Yeah, we start low molecular weight heparin only after the fetal heart is confirmed.
This is what we do in lutein as well. Generally, what we do is that basically we wait. Aspirin can be started even overdue is there. Like 2 days overdue, she can start that. That's not a problem. UPT is positive, she can start that. But blood thinners are started on the confirmation of seeing the heart, because otherwise in the miscarriage or any other problem that can lead to her having risk as well. But still you can post, Dr. Sabia. This is what you can post in the group as well.
I will post.
So that we can just finalize that. My safe sentence would be still the same, Sarvat, that you can start with the baby aspirin now, and as soon as we see the baby heart, the blood thinners would be started. That too, after the consideration and consultation from the blood doctor and my consultant, so that you can just speak for your patient safety. Okay.
And also because when we don't have a heartbeat, we don't know how this pregnancy is going to progress.
Exactly, that's the problem. So blood thinners is a big decision. So for patient safety, we do that.
It is costly as well. So we don't prefer giving it before we confirm the heart.
Yeah, sweetheart, that's the reason. Okay, so this is how Dr. Sarvat right now fixed this. That's aspirin would be started just with UPT positive patient getting overdue, and the blood thinners on the when the ultrasound shows the baby heart. Clear? Okay, so this is your patient safety, and this is a passing patient safety. All right. So
Dr. Sidra, just one question here for the breaking bad news. For the breaking bad news.
Breaking bad news. Okay, yeah.
It will be the same severity as if we are breaking bad news for example, ectopic or for molar pregnancy, or just we will say, just I have a bad news for you. No need to have this whole sequence.
Dua, the breaking bad news in terms of the oncology goes like, I don't have a good news. I'm afraid I don't have a good news. For antiphospholipid antibody or ectopic, I would say like, I have a difficult news to discuss with you. So I'll just change the word of bad or not good or difficult. So you say I have a difficult news to discuss with you. Would you require somebody to be with you, or is it okay that I proceed? That's it. So use the word difficult news here, Dua. Okay?
Oh, okay.
Okay, thank you very much. Thank you. So thank you for the appreciation, and well done, Ramya. Next time, I want you to complete the station in 10 minutes, and that too without being a bullet train. Okay? So we'll do that a little slowly. We'll become, we'll try to become a vehicle on car, or we'll try to become on wheels rather than just speeding up. And I'm sure things will be fine. You know the things, I know you. But the only thing is that I should be getting the same feeling that you know the things as a patient as well. All right? Job well done. Job well done. Thank you, my dear. Okay, so let's move to the station number 5. And where is my notebook? So notebook says that it's going to be Bindu. Hello, Dr. Bindu.
Hello, Dr. Sidra.
How are you?
Doing good.
Thank you very much. So enjoying with Divya, Harshiba, Preet, Dipti, and Pallavi, yeah?
Yeah, I'm the eldest one among them.
I know you're the most respected one, and you know, Divya, I see the messages and say that Divya is a little Divya, scared of Dr. Bindu. I know she's very scared.
Yes.
I know she's one of a very renowned and senior obstetrician in India. So I know all the feedback. But for me, she's a student Bindu, and I'm really glad that, you know, when I actually give some point, and I'm really glad. I was having an MRCPI class, Dr. Bindu, and I've got one of my students, she's from UAE, right? And whenever she takes the session, and always whenever she unmutes, there's like baby crying, right? And always tells me, sorry, my grandson is making noise. I'm so sorry, Sidra. And she says, ma'am, Sidra is my grandson. And she always keeps them on the lap because her daughter, she is doing her medical school. So I was like, see that the age doesn't matter at all. It is actually that you keep on learning, and you already have a wonderful clinical experience, Dr. Bindu. So I'm sure once you just achieve
still learn from you.
I'm grateful. I'm grateful if I'm of some little help to you, and I'm grateful that this is a complete circle of your hospital which is with me, and that's a great responsibility. Believe me, that's a huge responsibility on me, and I'll try to give my 100% and make you guys satisfied. And with all this love and care in this practice, we are going to do great, inshallah. Thank you very much.
Yeah.
Okay, Divya, that's very good. Okay, so let's start with the station, and let's begin the 2 minutes time and start.
Okay. Yeah. Yes. Yeah. Hello.
Yes, please start.
Yeah. Hello, I'm Dr. Bindu, one of the exam candidates, and I'm ready for the discussion.
Okay, so how is the exam going, Dr. Bindu?
Yeah, so far good.
Okay, thank you. So can you please tell me that what further information you would like to know from your patient?
Okay, so regarding her history, I have noted the age of the patient. So she has had 3 second trimester miscarriages. So I would like to definitely know at what duration of pregnancy this happened. Her age of the partner, I would like to know. And like whether it was a painless, like whether the waters broke early and what period of gestation the miscarriage happened, and whether the waters broke early or whether she had any pain associated with miscarriage, and whether it was a planned or unplanned pregnancy, whether she has taken any fertility treatment, or whether she had consulted any other specialist before planning for the pregnancy. And I would like to know whether her cycles are regular or irregular, and also any history of like medical history. Also, I would like to ask her whether she has any diabetes, any thyroid disorders, any weight to height ratio. I will see any family history of recurrent miscarriages she has, and any surgeries done before, and any drugs or allergies, and her what does she smoke, drink, or have use any drugs, recreational drugs, her social stat, how is she, the family, and how is the support, and also the how is she doing after the miscarriages. That I will have to, any special investigations taken in between the pregnancies, that is also important, and whether any the pregnancy products has been sent for examination. Okay, so I would
yeah
so I would like to this is sort about the history I would like to see. Then on examination, I would like to examine her and check her what abdomen, and also the per speculum and the vagina, whether any septum or any other any other abnormalities are seen, and also I would check her ultrasound reports, whether it was a normal ultrasound or in a 3D ultrasound or MRI has been done, any like other hysterosalpingography or any other test, laparoscopy has been done for this patient. So how the diagnosis of bicornuate uterus was made, I would like to find out that also.
So can you classify the congenital uterine abnormalities for me, please?
Yeah, see, uterine abnormalities, the latest classification shows that there can be abnormalities in the uterus, cervix, or vaginal. So the Escher classification says that the U0 is a normal uterus, and U1 where it is an infantile type of uterus, and U2 is a septate uterus. And in this patient, it comes to a bicornuate uterus, which is a U3. And also then the U4 is a unicornuate uterus, and U5 is an aplastic or absent uterus, and U6 is an unclassified uterus. And on depending on the ultrasound, 3D ultrasound, we can say, according to the American Society, Reproductive Society of Medicine, the classification for normal and arcuate uteruses, we measure the depth from the indentation, and the angle of indentation is measured. If the apex of, if the indentation is less than 1 centimeter and the angle is more than 90 degrees, it is classified as a normal or an arcuate uterus. And if the depth from the interstitium to the indentation is more than 1.5 centimeter, or the angle is less than 90 degree, it can be a septate uterus. And in this bicornuate uterus, we find that the external indentation on the fundus is more than 1 centimeter. Usually the 3D ultrasound and MRI can classify this congenital uterine abnormalities, and we see this after in the second half of the cycle. So 3D ultrasound can be the gold standard, but if diagnosis is unclear, we can do a MRI. So in part that we also have to test for other abnormalities, like renal abnormalities we have to check. So your urinary tract ultrasound or an MRI or the IVP can also be done in such patients.
Okay. So do you think it's necessary to investigate for uterine abnormalities in all cases of recurrent pregnancy loss? And what do you think are the limitations for the two-dimensional ultrasonography and the hysterosalpingogram if we use it as a first line to diagnose these anomalies?
Okay, see, it depends upon, it is necessary if we know the period of gestation at which the pregnancy losses have happened, then we can have a clear understanding of whether it's due to uterine abnormalities and suppose this like septate uterus, the miscarriages happen in the first trimester, and in arcuate uterus it happens in the second trimester. Also, we can know whether whether if it is accompanied with no signs of pain, or it can be due to the uterine abnormalities, because these can have a weak cervix as well, or an incompetent cervix as well. And if waters have broken early, that is also important. So depending upon the gestational period, we can investigate for uterine abnormalities. And we obviously we have to, if it is the first trimester miscarriages, most of the time it is due to chromosomal abnormalities. So we'll have to shift our management plan according that. And antiphospholipid antibodies typically have a history, clinical history, and so we can investigate accordingly. And especially and the other factors like it is not, it causes only sporadic miscarriages, like smoking and radiation or obesity. But if we correct that factor, so typically the period of gestation at which the miscarriage happened, then accordingly we have to check for the uterine abnormalities. The limitation with 2D ultrasound and HSD, I have explained, because we will not be able to delineate the anomalies perfectly, and with 3D ultrasound we can have a clear length about the angle of indentation and whether any septum. So it's a 3D, it's a gold standard for diagnosis.
So what is the role of sonohysterography and magnetic resonance imaging in these cases of recurrent pregnancy loss, please?
Okay, MRI, usually most of the time we can know the diagnosis by doing a 3D ultrasound. MRI, we can see in unconfirmed diagnosis on 3D ultrasound, we do the MRI. Also, if we have to search for associated congenital anomalies like in the renal tract, so we can do an MRI. And also, the sonohysterography can only show the internal interior or the cavity of the uterus. So if we want to know about the external, so that we can correctly identify the abnormality, so we should have both external and internal aspect of the uterus has to be checked. So that are the limitations of these the sonohysterography. In septate uterus, maybe we'll be able to help.
Okay, so what are the evidences available for the treatment of the congenital and the acquired uterine abnormalities in the recurrent pregnancy loss? And which investigations will you offer to diagnose the acquired uterine abnormalities?
Okay, so evidence says that, especially in literature says that in a septate uterus, the correction of the correction or division of the septum definitely has a good prognosis for the future outcome of the pregnancies. In bicornuate uterus, previously the metroplasty or the unification of the horns used to be done, but recent literature shows that it doesn't help much in continuation of pregnancy. So all these people can have preterm labor, so we have to warn the women about that. And for acquired uterine abnormalities, we'll have to do this hysteroscopy and find out the patients.
Okay, so what are other interventions which could be done in the management of recurrent miscarriage other than the having the uterine abnormality?
As for the treatment is according to the diagnosis, like if it is a genetic abnormality, that is if some abnormality is found on the products of conception or on the father or the parents, you can refer to a genetic specialist and plan a pregnancy. A pre-genetic implantation diagnosis or an in vitro fertilization with a healthy embryo can be done in such cases. In antiphospholipid antibody syndrome, you can treat with low molecular weight heparin and aspirin, because it has got an 80 to 85% successful pregnancy outcome. And correction of diabetes, thyroid disorders, obesity, all those things has to be there. And yeah, so there's an entity called the unexplained miscarriage, where in spite of all investigations, we are not able to find out the cause. But here, assurance, tender, loving care and support is very much required. In spite of not giving any treatment and just assurance and psychosocial support, these women are able to continue the pregnancy forward, and they have a 70% or a good pregnancy outcome. Thank you. Thank you for the time.
Thank you very much. A wonderfully done station, Dr. Bindu. So this shows that you are a senior in the practicing gynecologist and obstetrician. So perfectly done. Very good. Very good classification of the congenital uterine abnormalities. Believe me, students, they were confused in the last, like, because why we generally do the green top guideline for the recurrent pregnancy loss, and we don't do the Escher. We don't do the European guideline, but this exam station was a very difficult exam station.
I know, ma'am, you saved this for me.
Why? Because you know, this entire station was formed through the recommendation of Escher. So
yeah,
all these, the green top guideline, green top guideline was not at all touched in this station in exam, and students were blank in exam that what is the questions, where are the questions coming from. And if you see the Escher guideline of the recurrent pregnancy loss, believe me, they've given the blocks of that recurrent pregnancy loss, which I've brought like a screenshots for you guys, that all of these questions. But I am so happy that even the classification of congenital uterine abnormalities.
You had sent that scientific impact paper, na? I love reading all new things. This was this classification I knew, but I never used to bother so much. But I made it a point to read that. I knew something was in store for me.
I'm so happy. I'm so happy.
Yes. I lost actually with that much information and knowledge.
Yeah. So
I lost all.
Dr. Sabia, she is like this. I'll give you an example. I've got a student, Shilpa, and she's very close to me. She's a very new sort of a trainee, and then, you know, then she was old student of mine for many years. I know her, and one day she just rang me that, ma'am, Sidra, please take care of my ma'am. She wants to join you. I said, Shilpa, why are you so scared? Ma'am, she's very senior, ma'am. Please take care of her, and ma'am, please don't mention anything about me to her because she's very senior, ma'am. And she was so scared of this. I said, okay, when she'll call me, Shilpa, don't worry. And you know, then whenever Dr. Bindu had some problem, I used to communicate to Shilpa that, okay, help her in some sort of the PayPal issue was there, right? Dr. Bindu, she was so scared of you. She said,
I'm 46 years young, huh?
Oh, no, Dr. Bindu, about your experience.
I have an 18-year-old son and a 14-year-old girl.
I really love you for that. And you know, Shilpa said, no, ma'am, I cannot help her. She's so senior, ma'am. Please don't put me in difficulty, ma'am.
Pallavi and Dr. Pallavi and Deepthi are my very good friends and buddies. They know that I'm never senior to them. I am as junior as them.
Yeah, I understand. This is your personality. So actually, I was telling you the respect Shilpa had for you, you know, and she was like, ma'am, no, she's very senior, please, and all these things. So I still from that day I remember that I'm sure that you're actually practicing for a lot of time, so I can understand all this. But this shows no.
It was my passion to get MRCOG right after MBBS, but it couldn't work out. So I'm desperate and doing that. Thank you very much.
Oh, thank you very much, sweetheart. And I'm really happy, Dr. Bindu, the way you took the station, because the information you had. Next time we'll do an SPT as well. But today, I did this station yesterday with the June batch, right? And nobody knew the congenital uterine abnormalities. And this came in the exam like 2 times, right? And the difficulty was that this entire station was taken from the Escher guideline recurrent pregnancy loss. And I'm here, Jyoti, I'm here with a screenshot that from where the things were taken. And I'm going to tell you each and everything. A wonderfully clear pass station, Dr. Bindu. So Group B, I'm very happy the way you people are putting in effort. You're not putting an effort to be pass only in exam. Believe me, you're putting an effort to be toppers in exam. The way Harshipa does, or Devya, you pull in everybody. Dr. Bindus have such a great enthusiasm, Pallavi, Dipti, all of you. So I'm very happy the way you people are going and the way you people correct each other. Whenever some information is required, I hurriedly Harshipa posts that, and she's awake till 2 a.m. and working hard. I'm happy and keep on going in this manner, my dear. Once this exam is done, Then we have got lots to do in life as well, but no repetition for the exam we can afford, okay? So further information about the patient, Dr. Bindu was absolutely right. So it's going to be seen together in a dedicated recurrent miscarriage clinic, dealing in a sensitive and an empathetic manner. History regarding the age, the past gynecological history, the medical history, drug history. As I told Dua, so this was a point which I improved there, and Dr. Bindu picked it up doing the history in the template-wise manner, and that was very, very good. And height and weight and features of endocrine dysfunction. Investigations you would like to send, just add on, because initial assessment, as I told Dua as well, history, examination, and investigation. So investigations which I would like to send would be antiphospholipid antibodies being a cause of recurrent pregnancy loss, cytogenetic analysis of product of conceptions, paternal karyotyping, the pelvic ultrasonography, hysteroscopy, laparoscopy, 3D ultrasound, as beautifully Dr. Bindu said, thrombophilia screening. This was a very difficult case scenario, and students were silent. Believe me, they were silent in the questions. This classification of congenital uterine abnormalities is only mentioned in one of the scientific impact paper, which I posted in your group. Also, it is mentioned in the ESHA guideline. So U0 is the normal uterus. U1 is the dysmorphic uterus, which is T-shaped, infantilis, and others. U2 is the septate uterus, partial and complete. U3 is the bicorporeal uterus, which is partial, complete, and bicorporeal septate. U4 is the hemiuterus with rudimentary cavity, without rudimentary cavity. U5 is aplastic with rudimentary cavity, without rudimentary cavity. U6 is the unclassified malformation. Now, this is not something which we don't know and we can make up in exam, you know. This is a question, sort of a question, friends. Either we know that or we don't know that. I mean, if we don't know the classification, this is not something which we can make up with our words. So you have to learn this, because if it's going to be some sort of a station in which they ask about the classification, so you should be learning this. Otherwise, this is not something which we can like have some midway, right, Jyoti? So just cram it up from the ESHA guideline. This is the main classes which you just need to remember, U0 to U6. Now, question number 3. Yes, all women with recurrent pregnancy loss need to have a uterine anatomy assessment, because this is one of the cause. The limitations of 2D ultrasound is that high specificity, but at times it does not pick up all abnormality. And HSG again has high sensitivity, but will not detect the subtypes. So slight risk of injury and the risk of allergy is also there. Okay. Role of sonohysterography and MRI. Sonohysterography is more accurate than HSG in diagnosing the uterine malformations. It can be used to evaluate the uterine morphology when 3D ultrasound is not available, when tubal patency is being investigated. MRI is not recommended as first-line option for the assessment of the uterine malformations in women with recurrent pregnancy loss, but can be used where 3D ultrasound is not available. So the role of sonohysterography, this is the box from which they have brought in the question. 3 questions were made from this box of the ESHA guideline. All women with recurrent pregnancy loss should have an assessment of uterine anatomy. This was one question. The preferred technique to evaluate the uterus is transvaginal 3D ultrasound, beautifully told by Dr. Bindu. Did you people notice that she knew that the preferred technique is 3D and not 2D, which has a high sensitivity?
Ma'am, can I interrupt? We used to do this routinely in our hospital, because we have a beautiful wonderful radiologist who picks up the septate uterus, and so it makes our job easy to rule out recurrent miscarriages.
Very well done. So basically, generally, otherwise people, they don't know that, but this is written in the guideline as well, and you, by your experience, you know that as well. So I really appreciate that. Sonohysterography is more accurate than HSG. Again, this was a question which was brought in the exam. So thoroughly they put the questions, they took the questions from the ESHA guideline. And if a Müllerian uterine malformation is diagnosed, further investigations should be done. MRI is not recommended as first-line option. So this was a spot-on question. It is only done as an additional if 3D ultrasound is not available, or if we cannot confirm the diagnosis with that. Then was a question, friends, that congenital and acquired uterine abnormalities, no evidence to treat the congenital and acquired uterine abnormalities with a woman who has recurrent pregnancy loss. So the investigation of choice, beautifully told by Dr. Bindu with a confident attire, is hysteroscopy. So I was very happy that not even in a single question, she was having lack of information. This was a very tough station. Hysteroscopic septum resection is beneficial. Metroplasty You know, Dr. Bindu said that metroplasty we used to do initially, but it's not recommended now. So again, the applied clinical knowledge was very beautiful that metroplasty is not recommended as per the guideline now. So the evidence says that the treatment does not help for the recurrent pregnancy loss as well. Therefore, the uterine reconstruction again, and even insufficient evidence in favor of metroplasty in women with bicorporeal uterus and the double cervix, it's there. If they ask you about some intrauterine adhesions, there is insufficient evidence of benefit for surgical removal of intrauterine adhesions for pregnancy outcome as well. After the removal of the intrauterine adhesions in women with recurrent pregnancy loss, precautions have to be taken to prevent the recurrence of adhesions as well. So this was the ESHA guideline. Now, if they ask you about the women, it should be done or not, as it was in the previous question, it is taken from this, Jyoti, that all women with recurrent pregnancy loss should have an assessment of uterine anatomy, hysteroscopic of removal of the submucosal fibroids or polyps. We have insufficient evidence for that. And even if they ask about the intramural fibroids, it say it's not recommended. So there can be a question that if there are recommendations for the fibroid removal, in this they didn't ask it, but why did I bring that? Because they can ask other questions as well. So the idea is that it won't be a ditto station, but it tells you that how important the topic is that they can bring questions from this. So there is insufficient evidence to support hysteroscopic removal of submucosal fibroid or the surgical removal of intramural fibroid. That's not recommended in the recurrent pregnancy loss. Wonderfully done. That aspirin, heparin for antiphospholipid antibody, psychological support. No benefit is intravenous immunoglobulin. Unexplained recurrent miscarriage, beautifully said that only reassurance and support is to be done. Dr. Bindu, I was impressed. And again, the referral to the genetic doctor, geneticist, if there's some sort of problem in the genetic makeup for the product of conceptions, you do that, and then pre-implantation genetic diagnosis. So all these points was a perfect pass station, not only pass, but it was a very highly score case of a structured discussion. I'm sure if any other person would be there, wouldn't have done such beautifully, because it is a difficult station. I was not expecting spot on answers for each question. Very well done, very well done. Any questions? Thank you, Dr. Bindu. I'm really grateful for the participation. Yeah, okay, so next time be ready with the role player, huh? And that's a little tough role player, okay?
I know.
Yeah. Okay, right. So station number 6. Before that, if you have any questions, am I clear, Jyoti? I brought in the answers from the guideline so that you people don't have difficulty in just memorizing that from where they have taken that. Okay, this is the ESHA guideline of recurrent pregnancy loss. Rehma.
Thank you very much, Dr. Sidra.
Thank you, my dear.
I read it till now, didn't get the time to.
I'm sure. I understand your busy routine, so I'm here to make things easy. Thank you. Okay.
Ma'am, do we have to read the entire guideline for RPL?
Harshiba, just do the boxes. Do the boxes at least.
But ma'am, this the classification was asked earlier in the paper, in the exam.
Hmm.
This classification, ma'am, I can't find this classification in the guideline, the ESHA guideline.
It is in the ESHA guideline. I've taken this picture from the ESHA guideline. It is also in the scientific impact paper, RCOG.
Yes, it's in the scientific impact paper also.
Both are there. It is in the ESHA as well. The table is there in the ESHA as well, Harshipa. And do remind me, one of the students, she solved this question as well. But that too is a screenshot. So it's there. You have to memorize, because students were blank in that, Harshipa. They didn't know, I mean, from where to start and where to end, because again, I would say it's a mathematical question. It's not something which we can make a little story on. Yeah, generally for the X-ray station, even if you don't know, you can make some diplomatic lines in exam. But if such a question comes, like give the classification or some staging, we cannot make any story. Either we know that. Yeah.
Yeah. Can I say this? Clinical importance is only the other thing. The angle of indentation and what is that depth from the interstitium to the indentation. That is what clinically this is what is very important.
Yeah, like, for the management of the patient, it is important.
Yes. Whether it's a septate uterus or a bicornuate.
Yes. Okay, thank you very much. All right, so done with the station. Let me see the silent members. I hope they're not sleeping.
Abir, I hope things are fine. Dua. Dr. Sujata. Hello, Dr. Sujata. I hope things are clear. If there's any question, please feel free. Nadra.
Yes, Dr. Clear, but for the congenital malformation in the Green Top guideline, they said there is no evidence that resection of the uterine septum, it has an effect to prevent further miscarriage. And this is against now the ESHA guideline. Because now you said for the removal of the uterine septum, it has an effect. But in the Green Top guideline for recurrent miscarriage, it said no. For the uterine septum resection.
ESHA guideline didn't say about this recurrent pregnancy loss as well. It only said that initial conception.
Okay, so for as regard the uterine septum, for the management of recurrent pregnancy loss,
yes,
no evidence to remove.
No evidence for any surgery, yes. No evidence.
Okay, but only the evidence to remove it for the initial pregnancy.
Yes, for initial pregnancy. So no recurrent pregnancy loss, there's no effect on this, on any of the surgery. All the surgeries, they say insufficient evidence. So not recommended in all the types of surgery, no matter it's metroplasty, no matter it's removal of the fibroid, no matter it's...
Yes. Dr. Sudra, can we just state that the ESHRE says this?
Yeah, we can state that because they're asking the question from the ESHRE.
Yeah, so we can say, I mean, the
always,
question of
in a
GPG not mentioning would not come if we
in
just
the
mention
structured
the
discussion, you can always say that. And the congenital, if they ask about the classification, you could always say, according to the scientific impact paper, the classification says, and go with that. My way was always telling about this references. So it always gives a very confident attire that you're talking about the reference to the examiner. Okay? Right. All right. Okay. So yes, Sarvat, both my Sarvats and Shaheen, I hope things are clear. Clear, my dear? Okay, thank you, Nadra. Thank you very much. Okay.
Dr. Sudra, I just missed a portion of it. Did you say that none of the
surgery is effective?
Surgery is recommended.
Yes, the ESHA says none of the surgery is effective for the treatment of the early pregnancy.
Early pregnancy loss or recurrent?
The recurrent pregnancy loss, yes.
Okay, and what about septoplasty?
You mean to ask for what scenario? Thank you, sir.
Yeah, for recurrent pregnancy loss, because I've seen septoplasty being done, but not exactly sure in whether that is what is written in the guideline.
Yeah, so see the septoplasty, if you have to go with the recommendation as the Dua is going to, Dua, please share that line for everyone so that nobody forgets from the Green Top guideline. The last line which says about the septate and the arcuate as well in the GTG. Right?
Okay, okay.
Dua? So do that. So in the end of the Green Top guideline, Jyoti, it says that this septate or the arcuate uterus, they're no helpful in doing the surgery. So in the end of the recurrent miscarriage guideline, it's there. That's a simple small paragraph. Dua would be sharing the screenshot so that you people understand and you know what the Green Top guideline recommendation is. Okay? Right?
Thank you.
Okay, thank you very much. Thank you. All right, so let's move to the second last station for the day. And who is in the sequence? We've got Dr. Rehma. Hello, Rehma.
Hello. Yes.
How are you? Good evening.
Fine. I'm fine.
Thank you very much. Thank you. So let's do a station with Dr. Rehma, and then we are going to go with the last station of the day. Okay. So let's start with station number 6. Dr. Rehma, can you please check your mic? Speak a little more so that we can understand, we can listen to you.
Yes, you can hear me, Dr.
Yes, we can hear you. Thank you very much, my dear. Thank you. So we are starting your 2 minutes now. Okay, so let's begin. Good luck.
Yes, doctor. Yes, Dr. Please move. Yes, doctor. Okay.
Yes, please.
Hello. Hello, I'm Dr. Ahmad, doctor on duty. May I confirm your name and age, please?
Yes, doctor. I'm Jazz Phillips. I'm 26 years, doctor.
Jazz, I can understand from this that you've been having bleeding since morning. May I know more about your bleeding, Jazz?
Yeah, I'm having lots of bleeding. It's just heavy. I'm passing, I don't know, some bubble-like structures as well, doctor, and it's lots of clots. Severe vomiting it is, doctor. I cannot hold anything inside. I'm vomiting, doctor.
Oh, I'm really sorry, Jazz. Jazz, I'll ask my nurse to start a IV line for you to give you some fluids. And once you are settled, I will explain more about your condition, Jazz. Before that, I need to examine.
Yeah, can you give some medicine so that this vomiting
Yeah,
stops
yeah,
and I can talk to
yeah.
you?
We'll do that. We'll do that, Jazz. We'll do that.
Okay. Thank you, doctor. I'm better.
Okay. Okay, you don't mind me examining you, Jazz, from your tummy and down below?
Okay.
Yes, Jazz. Jazz, are you alone today?
Yes, I am.
Okay. Just before I start discussing the management options, I want to ask you a few questions. You don't mind me asking questions? Are you okay now, Jazz?
Yes, I'm better, doctor. Please go ahead.
Can you tell me more about this pregnancy, Jazz?
Yeah, it's been 7 weeks now. I don't know, since morning I was having heavy bleeding and there was so much, and the vomiting. I had sickness for the last 2-3 days, but since morning all my tongue is all dry, doctor, and I'm vomiting heavily. I don't know what's happening.
I'm really sorry. Jazz, was it a planned pregnancy?
Yeah, it is. I'm happy for the pregnancy.
What about your menstrual history, Jazz? Where your cycles are regular?
Always, yeah.
Jazz, are you allergic to any medications?
No.
Are you following with GP for any medical illness?
No, I'm otherwise fine, doctor.
Did you have any surgery in your tummy or down below?
No surgery prior.
Jazz, how about your cervical smears, Jazz?
How about what, doctor?
Jazz, your cervical smears are up to date?
Yeah, I had one, that's fine.
Yes, Jazz. Pardon me to ask, do you smoke?
No, I'm not smoking, doctor.
You drink alcohol?
No alcohol, doctor.
Are you taking any illicit drugs?
No, doctor.
Are you aware of your blood group, Jazz?
Yeah, that's A negative.
Okay. Do you have any concern for blood transfusion?
No, doctor.
Yes, Jazz. Are you okay now, Jazz? How do you
Yeah,
feel
I'm
now?
fine, yeah.
Yes, Jazz. Let me confirm your name and NHS number, and then I'll discuss with you the reports, and we need to manage you right now as you are bleeding heavily. Also, I'll inform the anesthetist and the consultant of my team. Okay, Jazz?
Okay.
Jazz, I'm really sorry. I don't have a good news for you. From the ultrasound, what I can see, it's a molar pregnancy.
Molar pregnancy? What is that, doctor?
Yes. Just in the normal pregnancy, what happens is a sperm from your partner fertilizes the ovum. Okay, Jazz. But in the molar pregnancy, there is an imbalance in the number of chromosomes where the sperm from the partner fertilizes the empty egg. Jazz. Sadly, this pregnancy does not, there is no baby present in these pregnancies and cannot survive and cannot lead to the birth of the baby. Yes.
What do you mean? We're going to end up this pregnancy?
Yes, I can understand you are psychologically very upset. Do you want your partner with you now or any support?
No, he cannot come. He's very busy. Please tell me that what are you going to do now?
Yes, just because you are bleeding heavily, we need to perform an operation. Are you with me? Yes.
Okay, so what to be done?
Yes, we need to do a surgery under general anesthesia where we make you to sleep, and the products of in the womb are removed by the suction cannula. And these products will be sent for further examination, Jazz. Once you're okay from the anesthesia, you will be given some things to drink, but you are not allowed to drive or take any important decisions for 24 hours.
Okay.
Yes, Jazz. And then you will be registered, but you can be discharged after 24 hours, and then you can slowly come back to your routines, Jazz.
Okay.
But this molar pregnancy, because this is a molar pregnancy, we need to book you in the molar pregnancy registration centers, which are present in Sheffield, Dundee, and London, who will follow you up with the blood test and urine test to know the level of pregnancy hormones, Jazz.
Okay.
Yes, the pregnancy hormones become normal within 56 days of your operation. You will be followed for a total of 6 months, Jazz.
Okay, I'll have to wait for 6 months.
Yes, Jazz. Before you plan your next pregnancy, you have to wait, Jazz.
I understand that. So I hope my next pregnancy would be okay. Or do I have a chance that every pregnancy would be like this, doctor?
No, Jazz. I can reassure you, a molar pregnancy will not affect you or your chance of having another baby, Jazz. But there are chances of it. This molar pregnancy happening is 1 in 80, Jazz.
All right. And what about my vomiting?
Just I will give you some medications to stop your vomiting now. And are you sure you are not allergic to any medication, Jazz?
No, I'm not.
Yes. Once the operation is done, I can assure you that you will be fine, Jazz. And after the operation, we need to give you anti-D injection as your blood group is negative.
Okay.
Yes, Jazz. This helps to prevent the formation of antibodies, which will affect your next pregnancy.
I get that, doctor. And
I'm really sorry, Jazz.
I know, doctor, but what about the contraception? I mean, for 6 months you said that I don't have to be pregnant, so I can use anything?
Yes, Jazz. Until your pregnancy hormones in the blood becomes normal, you need to use condoms. After that, you can go for pills or intrauterine devices, Jazz.
I understand that, doctor. So for now, can I go home and discuss with my partner, because he would be very upset. I need to tell him that this is the plan, so then I'll get admitted.
No, Jazz. We need to. I can understand you are emotionally very upset, but you are bleeding heavily. I can arrange a phone with your partner so that he can come to you before we make arrangements for the operation, Jazz.
Okay, that's okay. If you can ring him up to call him here, I really need to talk to him.
Yes, sure. We will help you for that, Jazz.
That's okay. Thank you very much, doctor. Thank you.
Just in the next pregnancy, after any pregnancy event, you need to follow up with the GP after 6 to 8 weeks, Jazz.
All right.
I hope I addressed your concern, Jazz.
I get that, doctor. Thank you. I'm clear about it.
Thank you.
Mhm. Give me some leaflet.
Yes, yes. I'll provide you with the patient information leaflet, which you can go through, Jazz.
Okay, and I'll ring your partner so that he can come here to support you. And then my consultant is on the way to have a look at you, and then we'll plan the management from this point onwards. Would that be okay, Jess? Right? Okay, so give a very good ending to the station. Because remember, the last few words, they really mean a lot because examiner is just making the right mark. So no matter how good the station had been, the last ending of the station has to be super. So never be shaky in the end. Okay, thank you very much, Dr. Rehma. How did the station go?
Dr.
It was
Sidra?
not okay because it was an emergency. So I think I was not okay in the start.
Okay, right. So tell me the okay points first. Not okay points, we'll discuss later. Yeah. So what were the okay points, Dr. Rehma? The ones which you did good. Come on. Yes, Shaheen, tell me the good points. Sarvat, tell me the good points. Dr. Sabina, you wanted to tell some good points, please, yeah?
Yeah, I'm just saying that today nobody is giving leaflet. Only patient is asking at the end.
Exactly. And today patient is after the leaflet and everybody's doing the same. Was it Harshipa? Was it you? And then Dr. Emma? I'm asking leaflets from everybody. Yeah?
Yeah. Regarding Rema, her tone is very empathetic and her good tones. She was, very empathetic with the patient.
Okay. Yes. Yes. Very good. Okay. So, yes, thank you, Abir. Right. So the points which we can improve. Yes, Dr. Rahma. Yeah, the best part was she didn't forget the entity. Believe me, Sarvat, my students, they forget entity in the end. Because, in the management, in the flow, they forget that, oh, she was RH negative. So that was very good. Yes, Dr. Bindu, she has an empathetic tone. Okay. Okay. So tell me the points which we have to improve. Yes.
I need to act in an emergency first.
Yes.
I should ask her, are you okay? Are you okay?
So you also have a little tendency towards going slow in the station, like Dr. Sabiha. So a little tendency.
Yes, that's what I told you. You should join me also with Dr. Ramya.
Yeah. So now, Abir, you have joined them up. So Abir, make them quick, please. So go give some energy and speed to be a little quicker, also to Dr. Rehma and also to Dr. Sabiha. Okay, Abir, so next week I'll be seeing that they are a little quicker. Of course, not quicker as a bullet train, but at least that quicker so that we can manage the station. Okay, right? All right. So a few points more. In an emergency situation, you have to be a little quick. And yeah, so please take some speed, borrow some speed from Ramya. So we can take some speed and we can give some rest and pauses to Ramya. So let's exchange that. Okay. Okay, so let's begin with the introduction. You have to practice, Dr. Rahma, the emergency situation, early few lines, and send me a voice note. Okay, so whenever patient is vomiting, don't fumble. When the patient is in emergency, don't fumble. I can see that you're having vomiting. I've just called the nurse to give you the medicines to stop vomiting. Or are you having any known allergy? That's it. So you gave me IV line, but I wanted an anti-sickness medicine or something to prevent vomiting in these turns. Okay. So this was one thing in the start which I want to improve. So before that, let's go with the positive points. Introduction was good. Calling nurse was good. You started the information gathering starting from I'm sorry that we are meeting in such a difficult situation or something. You said like to acknowledge her condition. You asked about the periods, the allergy, the smear, smoking, and you asked about the blood group. That was very good. A patient safety. You did a little BBN and told about the molar. And then you said that I can understand that you are in distress, and we will start with the suction evacuation as you explained. That was all right. 6 months follow-up you told. The recurrence chance you told.
Then in the end, you settled me with the vomiting again, asking about the allergy. You gave me NTD. I prompted you to give me contraception plan. You did that. That was very good. So these were the good points. And also offering me admission. Yes, starting IV fluids were good, but IV line is a jargon. Okay, you said that we are going to give you fluids through your arm, right? Through your arm, we are going to give you fluids. So this is what you speak for the IV line. All right. Now, to start with, yes. Okay, to start with, the starting, yes, thank you, Dr. Rehma. To start with, starting was that she is dehydration. So basically, we have to rule out that this is a combination of hyperemesis gravidarum and the molar pregnancy. As I told to Harshiba, that there were two things we had to address. That was an X-ray and that was a threatened miscarriage. Therefore, here we had to take two things side by side. Stabilizing her first and treat her hyperemesis gravidarum. And along with that, we have to settle her molar pregnancy management. So stabilizing her first and then going through that. See, the hematocrit is 45%. That's way too higher and she's dehydrated. Okay. About the information gathering, you have to be a little in the sequence, Dr. Rehma. One after the other, the question should be coming spontaneously. I know it would come with practice. Because we have started practice now, so it comes little with the practice, that one after the other. Because the gynae history, it was earlier, then medical history was not there, the family history was not there. And before information gathering, immediately, you started examining the patient. Now this happens in emergency in the clinic, and I respect that. Whenever patient is having bleeding, you take history side by side and you immediately examine the patient. You do that. I appreciate that. But in exam, we have to ensure that we are in exam. So go in a sequence like we do. Because I was a little, it was for me as a role player, it was a difficult thing that you do the introduction agenda and you say that, can I examine you? Examination comes where, Dr. Rehma, in the sequence of hours? After history. Yes, after history. So you take the information gathering and then you can say that I'm going to examine you. So that examination part, you have to put a little down, okay? And then you explain the molar pregnancy. Fertilization is a jargon. You say that the sperms and the eggs, they meet up to form a baby. So meet up is fertilization. NTD was fine. You can simply say that we are going to give you an injection after we treat this condition, and that is to have your safe future pregnancies. Safe future pregnancies, rather than the NTD or RH thing, patient gets confused. So this is for your future safe pregnancies. We give this injection to all the women who have the blood group negative. That's it. So your job is done. Okay, thank you very much, Dr. Rehma. So after history, we'll do the examination. History has to be in a sequence, and NTD, a little fumbling was there in explanation. You can speak that up. Follow-up was fine. Now, I had a smile when I said, the doctor, is it okay? I go back home and I discuss with my partner and I'll get back to you. So you said, no, Jazz. And then you said, I can understand your concern, but it is wise to get admitted. So I had a smile at that part, that immediately you said no, and then you understood that no, we don't have to say no to the concern. First, we have to appreciate or acknowledge that or understand that, and then we have to come to the point of clarification. So that was very good. I enjoyed that part, that you understood that immediately, that I don't have to say no directly to Jazz for going home, but at the same time, I cannot let her go home as well. Very good. So starting with this communication with the patient, be a little more confident and a little more speedy at times. So pauses, multiple pauses gives a little shaky appearance, which I will definitely work upon. I'm sure this is the first station, and every passing station would be better. Greeting was fine. Emergency management, we can improve a little. It was a calm, appropriate volume and an empathetic sound. And breaking bad news was done in a good manner. Information gathering was fine regarding the bleeding. This part was a little up and down, the obstetric history until lower down, but still we can improve it. Just be in a sequence for this. So one after the other, the question comes in your mind. I understand that a lot of busy routine is going, but with practice, 1.5 hours, we would be fine in the sequence.
Patient safety, assessing the concerns, telling about the patient is upset, and stabilizing. Urgent review by consultant is very important in molar pregnancy, remember, right? So deciding for the removal of the pregnancy under the effect of the medicines to make you fall asleep. So this is general anesthesia. And telling about the molar, informing the recurrence, that was very good. Now comes the part where we missed it. So remember, we cannot do a suction evacuation in a patient who is dehydrated. So you say that we are going to deal with your vomiting first to stabilize the condition, to give you the fluid immediately in your arm, avoiding the glucose as it can precipitate the condition. We'll give you the vomiting medicines and see how is the result, and we'll give you the vitamins as well. Once you're stabilized, we'll plan to start with the procedure for removal of the pregnancy tissues, right? We'll talk to you about the procedure, and we'll take the consent. Anesthesia doctor will also talk to you about that. We might give you some medicines to soften the neck of the womb prior, and it is going to be a surgery by the consultant, and the pregnancy tissues would be labeled and sent for the laboratory study. After the pregnancy tissues are removed, we will give you some injections as you are having a negative blood group to have safe future pregnancies. And for 6 months, we generally suggest that you continue with your contraception. It is advisable to take the barrier methods, that is condoms. And when the pregnancy hormone, once it comes back to normal, you can use the combined pills as well, or the copper coil as well. Now we are going to follow you up for at least 6 months if the pregnancy hormone gets back to normal in 56 days time. If it doesn't get back to normal in 56 days time, we are going to follow you for 6 months after it gets normalized. So am I clear about the management, Jazz? So now you can tell her about the 1 in 80 thing for the future pregnancy. You beautifully told about the 6 to 8 weeks, having the pregnancy test later as well. About the follow-up, I've told already that how you have to deal with that. About the pregnancy, molar pregnancy, you can simply say, do the Breaking Bad news, and you say that Jazz, generally the sperm from the dad and the egg from the mom, they meet up and they make a healthy pregnancy, having a baby and the afterbirth. Unfortunately, in this condition, the sperm from the dad meets up a hollow egg, and that leads to the development of the afterbirth only. And unfortunately, we do not have any baby in this condition. That is the reason that only the afterbirth is growing and leads to that heavy bleeding. I'm afraid this pregnancy cannot move forward, and we have to end up this pregnancy. Okay, so this is how you explain in a better way. Your explanation was fine as well. No problem, Devya. Oops, no problem. Yeah, no problem. Thank you. That's absolutely understandable, Divya. Just one station left.
Dr. Sidra. I think today I have a special task, so I'll listen to it tomorrow morning and
no problem. I'll just post that after the session, and the recording would be there. You can listen to the recording with the last station. Okay?
Thank you very
much.
Thank you so much.
Thank you.
Bye.
Okay.
Bye.
Bye. Counseling and support then you can provide. So introduction, agenda, quick focused information gathering, do a Breaking Bad news, and offer support and manage both hyperemesis gravidarum, right, and the molar pregnancy. So this is how you deal with the molar pregnancy outline. A little polishing and speeding up. I'm sure with passage of time, Dr. Rehma, we'll work on that. You can say that there's an imbalance of the material, but for genetic material, then you have to explain the chromosome as well, Dr. Bindu. Yes, you can say that, but then you have to say that the cells, they are actually the millions of cells in the body, and each cell, it contains the pair of chromosomes, which are thread-like structures, which contain the information. So that information has to be balanced in the cells. This material, chromosomes, which carries the information, if imbalance occurs because of meeting of a sperm from the dad to a hollow egg, that leads to this condition in which afterbirth is only growing, and we call it as molar pregnancy. So if you're saying something about the genetic material, then do mention the thread-like structures inside the cell which carry the information, the imbalance of that information that leads to this condition, right, Dr. Bindu? Okay, yeah, so then make one line of the chromosomes as well, and then come to the genetic material.
Thank you.
Okay, thank you very much. All right, any questions from this?
Thank you very much, Dr. Rehma. Just work on the information gathering being a little speed up and one after the other, and work on this different sections of the outline of the station. So one after the other, go with the sequence, and I'm sure we will be improving together. Okay? Thank you very much. Thank you, Dr. Rehma, for a participation and doing it wonderfully. Every next station has to be a better station, and we are going to improve together. Thank you.
A question, Dr. Sidra.
Yes, sir, please.
I want to ask, in this case, yeah, the scenario is like she came to emergency with bleeding, but if the molar pregnancy came with a scan report to discuss without any symptom that time, and she says that she want to go home and come back, so can we send her home?
Molar pregnancy, no dear. Molar pregnancy and ectopic pregnancy diagnosed, molar and ectopic never sent back home.
So we have to offer admission
anytime. Yes, molar pregnancy diagnosed and ectopic pregnancy diagnosed can lead to torrential hemorrhage anytime. So it's a gas patient safety to send them back home. Always admit them. You address their concerns. If they want to ring their partner, you help in that. And you say that we are going to ring your partner, and tell her that I understand your concern. However, it can be risky because anytime you can have serious or torrential bleed that can put your life into danger.
And
so
what we need to tell her about the chances of getting gestational trophoblastic neoplasia?
Don't tell about that. You simply say that if after this removal of the pregnancy tissues, still if the pregnancy hormone doesn't fall down, we will talk to you about the details or the requirement of some certain important medications to be given at that time, but it's way too early to discuss at the moment. We'll follow you with the pregnancy hormone and discuss further if requirement of other medications are there after the removal of the pregnancy tissue.
Like that. And if the patient says, why I need the follow-up of hormone for 6 months,
why?
So even that,
you just have to say, I again say, I respect your concern. This pregnancy hormone should fall down and get back to normal. If it doesn't get back to normal, there's a requirement of other medications to treat the condition. Okay. So for that reason,
so if she asks the question relevant to that, then only we will speak about it.
Yes, only then. Yes. Okay. Otherwise, go into the smooth flow. Okay.
Thank you.
All right. Thank you, Sarbat. Any other question, please?
Yeah, Dr. Sidra, I just wanted to know whether she has come with heavy bleeding and she is in the emergency. So do we need to really give her a patient information leaflet?
If she's stabilized, give her, because suction evacuation, a little time you're taking, right? So till then she can read about this. So if she is not stable, because at the moment I said that I've been given the medicine and I was fine, right? So you can give that. And if she says that if she's really unwell and she's like some sort of till the end, she's in some quick lines you're getting, in some quick response you're getting that she's in emergency, then avoid that. That's fine. So you're going to take emergency decision of section evacuation. Okay. Right. So Girija has a question. Avoiding dextrose solution. We are going to give you fluid and not containing glucose, because it can precipitate and worsen your condition. So basically we say we are going to provide you with the salt water in the arm, salt solution in the arm. Okay. Right. And again, another question. Liana, sweetheart. Firstly, I've not forgotten you. I know you're part of Batch D and you're a very important part of Batch D, sweetheart. Just saw a pop-up of a message. So another thing is, Liana, the important thing is that we don't go for expectant in molar pregnancy ever. In molar pregnancy, there is no expectant, there's no medical management. It's only suction evacuation, sweetheart. Okay? Yes. After stabilizing. So give fluid. Stabilizing would be earlier, Dr. Bindu, like immediately you stabilize, give her antiemetic, give her fluid, because if you're doing with a hematocrit of 45% and dehydrated patient, what we are doing in suction evacuation is that we are actually inviting the complication to occur, because she's going to bleed a little, of course, and that bleeding can be more as well. So at least to have a good hemodynamic status of the patient prior to starting suction evacuation. Okay. And Liana, about the expectant management in ectopic, yes, you can send her back home with a very little pain and no pain. And of course, the fetal heart is not there. The criteria is meeting. That's all right. But generally, it doesn't come as this. Okay. Right. Yes. Any other question? Yes, group D, I'm getting all the pop-up of your messages, huh? Right. Okay. So any other question? Is it done? Okay, so let's do the last station of the day before you people get tired. And who is left? So this is Fozia. Hello, Fozia. Hello, Fawzia. 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 Check in the participants, friends. Fawzia is here. Yeah, Fawzia is here. Fawzia, unmute yourself. Your station time. Hello. Fawzia, we can't hear you. I know doing a 7th station is a difficult task because you people get tired. I'll try to keep and organize the sequence in a manner that the end ones always don't remain on the end. So it's a little mix up, keeping in the middle and then in the start, my dear. Fawzia. Okay. Knock, knock. Girija, message on a WhatsApp. Yeah, call her. Then maybe she's online. She's in the group, but she's not coming for the station. Voicemail? It's off? Didn't tell me.
Hello.
Hi, Fawzia. How are you?
I'm so sorry, Dr. Sidra. Yeah, I'm fine. I'm so sorry.
No,
Yeah,
no
I had to
problem.
disconnect. There was some problem. And
No
then
problem.
reconnect. Yeah.
No,
Yeah.
your voice is audible clearly, my dear. How are you doing?
Okay. Yeah, I'm fine. Thank you.
How is the group going?
Yeah, going fine. Yeah.
Thank you very much. Okay, so let's begin with the last station. And next time you have to remind me whenever it's your turn, you should be somewhere in the middle or in the first few, okay? So that, you know, there is some alteration in everybody. So the last station, I know it's a difficult station because people get tired, okay? Thank you very much. But you have to remind yourself because at times I mix up with all the presentations, all right? Okay, so let's start with the station number 7. I'm sure you'll do great. Just be yourself and follow the template, okay? Good luck, sweetheart. Go ahead.
Okay. Next slide.
Sure.
The first one. Yeah. Hello. Hello.
You start, please. Yeah.
Yeah. Hello. I'm Dr. Fawzia, one of the doctors in the early pregnancy assessment unit today. Is this Christina James?
Yes, doctor.
How are you, Christina? I can see you're in pain.
No pain is okay. Nurse has given me the painkiller, doctor, but it's again an ectopic, doctor. It's my 3rd ectopic, doctor.
Yeah, I know. It must be very difficult. I can see you're very tearful for that.
Why again and again? I mean, first ectopic, then second ectopic, and again an ectopic. I mean, why am I having this? No, I just want a healthy baby.
Nurse just told me that it's again an ectopic. I mean,
I know, Christina, it must be a devastating news. Are you alone or you have somebody with you today?
no, I just came with driver. Actually, I didn't know I was having a little tummy discomfort, doctor. So I just rushed to here so that I can see that this time I was hoping for a healthy baby.
Yeah. I know. Like, do you want some water or tissue? Anything?
Thank you. Thank you.
This must have been very difficult. I can see. If you want, I can call the nurse to be with you. Or do you want me to go on with it?
Yeah, thank you, doctor. Please, doctor, you can carry on. I'll be better. I just have to face this. I know I have to be strong.
Yes, you have to. You have to, Christina, definitely.
Okay. Yes, doctor, please.
Okay. So, Christina, how about the pain right now? Is it tolerable? Have you taken anything for that?
Yeah, nurse has just given me the painkiller. Thank you, doctor.
Okay, fine. Now, Christina, can you tell me more about yourself and the pain that you're having? Since when?
Yeah, the pain started early in the morning. I'm into 6 weeks, doctor, and it's my 3rd pregnancy. When the pain started, I just got scared because this was similar in the last 2 pregnancies as well. So it was just ringing in my mind that it's not an ectopic again, but it is tolerable. I mean, it's not to the extent that I was thinking that it's something like a crampy pain, but it's localized here on the left side.
Mm-hmm.
And nurse just did the ultrasound and she said that she can see the pregnancy on the left side.
Yes, this is very unfortunate. I can see that. And how about this pain? Do you have any shoulder tip pain? Any
No,
pain
no,
radiation?
No, doctor.
Okay, and any time have you felt fainting at
No, doctor.
any time?
No.
Okay, right. How about the bleeding, Christina? Is it a lot, or is it just a mild bleeding only?
No. The bleeding was just like a spotting, doctor. I'm not bleeding heavily at all.
Mm-hmm. And how about your this pregnancies? You said you've had 3 of.
Yeah.
Can you tell me more about it?
Yeah, doctor. My first pregnancy was ectopic. It was on the right side. It was diagnosed around 6 or 7 weeks of pregnancy. And the pregnancy hormone, they said, was very, very little in amount. And there was no, they said that we can go with the medical treatment. They gave me injections and it was over. But just after 4 months, I had my 2nd pregnancy. And again, it was in the right tube. And then they decided for the keyhole surgery and they removed my right tube. And this time, again, I conceived, and all these, my pregnancies, they were like spontaneous. It's been 5 months from the 2nd ectopic, and now I conceived, but this time now they say it's on the left side.
Yeah, okay. Mm-hmm. And can you tell me more about your periods? They have been regular?
Yeah, periods, I don't have any problem, doctor. They're always regular.
Any pain during your periods?
No, doctor.
Okay. I'm sorry, can I ask you certain personal questions, Christina?
Okay.
Do you have any history of any vaginal discharge or sexually shared infections?
Oh, doctor, I had a low tummy infection, but that was way too early. I was around 19 at that time. I was given antibiotics and then it went fine.
Mm-hmm. Okay. And how about any other, do you have any other medical condition that you're following your GP with?
No, doctor, I'm fine otherwise.
Okay. And any surgeries in the past?
That's it, the ectopic surgery I told you, doctor, in the 2nd pregnancy, yeah.
Yeah, other than nothing, yeah.
No.
Do you take any medications?
No, I'm not taking any medication. I started on folic acid on my own when I came to non-pregnancy, but yeah.
Any allergies that you're aware of, Christina?
No, doctor.
Okay. Anything in the family that is of concern?
No, doctor.
Okay, Christina. Do you smoke?
I used to do that, but when GP told me that it can be related to ectopics, I stopped that 2 years back.
Yeah, that's good. And how about alcohol?
No, doctor.
Okay. And do you have what about what do you do for a living?
Yeah, I work as an accountant in bank.
And how about the support at home?
Yeah, that's fine. Yeah,
And how about your partner?
he's okay.
And how long have you been together?
It's been 5 years.
Okay, so surely you must be looking forward for a pregnancy. I can fully understand that. Are you aware of your blood group?
Yeah, that's O positive.
Okay, and any reservations to blood?
No, it's okay.
Okay, and how about your weight to height ratio? Are you aware of that?
Yeah, that's 22.
Okay. Thank you, Christina. Thank you so much for sharing all this information. I would just like to examine you, okay, just to see the feel of your tummy, okay, how severe your pain is, and then I will just, examine you from down below also. Okay. And I will just see, see whether there is any pain while examining. Though I have the report with me, and I know the nurse has informed you this, okay, Christina. I will confirm your name once more and tell you the report. Yes, it does show that we did the blood report. That is fine for you. Even the pregnancy hormone was done, and that is there. Yes, the ultrasound shows that you have pregnancy on the left side. And as you're well aware, what is an ectopic pregnancy?
Yes.
So yeah, that is true. Unfortunately, again, there is, but it's on the left side. And but this time, Christina, what we see is that the pregnancy can show the cardiac activity, and that there is some fluid there's also some fluid around the womb. Okay.
Cardiac activity, sorry, doctor.
The heart of the pregnancy the baby can be seen. Okay. What it essentially means is that definitely you're aware that this is an ectopic pregnancy and we cannot leave it in the tube. Okay, yeah. Christina? Yeah. And more importantly is that since it is, we can see the cardiac activity, it means that the pregnancy has a chance of growing, which essentially means that the tube can rupture if we leave it like that. I know it must be difficult. What I mean is that we because we have to take you for a surgery. Okay.
So what would be done? I mean, I've got one tube only, doctor.
Yeah, definitely, Christina. It is a difficult time. What we will do is that we will try to salvage this tube. What we will do is we will scoop out the pregnancy tissue and leave the tube over there. Okay. This is an operation which we call a salpingotomy. Okay. Do you understand that procedure? Let me draw it for you. Here's the tube. Essentially what we did before was we cut the tube and we removed it. Now what we will do, since you have just one healthy tube, we will try to leave it so that you have your chance of pregnancy. Okay. But with this, leaving the tube and removing the pregnancy tissue is that there is a chance in next pregnancy, unfortunately, having a repeat ectopic will be there. Okay. Yeah, I'm so sorry to tell you, but then this is the thing. And more importantly, after the surgery, we would need you to have a very close follow-up for the pregnancy hormone to come down. This will be a weekly follow-up, okay? Okay, Christina?
I get that, doctor.
Okay, yeah, I know. And also, Christina, it is also very important that sometimes even after the operation and follow-up, we might need to if the hormone of your pregnancy, if the pregnancy hormone doesn't go down, we might need to repeat give you another form of treatment, either in the form of an injection, or we might need to repeat the surgery to remove the tube.
But if my both tubes won't be there, I mean, can I get pregnant? I mean, any way out for me?
Yes, Christina, your concerns are very valid. Yes, there are other ways also, Christina. What we can do is, have you ever heard of test tube baby?
No.
Okay.
This is like an artificial thing, I think, yeah?
Yeah, what we can do is we can take the egg from you and sperm from your partner, and we can let them meet in a laboratory. And once they meet, we can put the embryo, the fertilized egg inside you, and then you can carry the baby easily. Okay.
Okay, I understand that, doctor, because I'm really stressed up with these repeated ectopics.
Yes, Christina. So there is an open option. I know it must have been very difficult for you. I would really suggest you that we will, since we can see that there is quite an amount of bleeding, we would prepare you for an operation. Okay, we will try to salvage the tube. If not possible, we might need to remove it. And then definitely there are other options, which I will try to connect you to my fertility specialist who will speak to you in that manner. Okay.
Thank you very much, doctor. I feel better. Thank you.
Okay, my dear. Thank you very much.
Oh yeah, how was it? It was a difficult station for me. I mean,
yes, it was difficult for you.
It was a difficult station for me as a role player. Thank you very much.
Yeah, but you acted so well. Yeah.
Very well handled, Fawzia. Initially, you were not expecting me because it was a difficult ectopic pregnancy because she knows it earlier. So the breaking bad news things is not there. But I had to give you tough time in the beginning, you know, so that, and I was successful in that, a little silent you had, I mean, you were not able to cope with and you were getting paused. So I had to tell you, doctor, please go ahead. I mean, take history, please. Your time is getting wasted. I'll give you life.
I didn't know what to tell her because I mean, this is
I-
real. What is she going through? So I didn't know what to say. So I was like, so better to be quiet.
I know. So you were quiet in that. And, you know, again and again, I was changing the slide. Please see the glass of water here. Please see the glass.
Oh, okay. I think I needed one.
Yeah, I know. So probably I would have said, doctor, please, I have a glass of water. Fawzia, please, you can take glass of water.
Okay,
Yeah.
I'm so sorry.
Okay, lovely
Noted,
memories.
yeah.
You know, Fawzia, when you'll pass this exam, we are going to cherish these stations and we're going to cherish these times, inshallah. Okay. Okay. So initial part has to be a little improved one. You were taken aback by my being very sorrowful. So you were quiet at that. A little improvement should be there on that part of me being upset. But later part of the station was very good. From the explanation till the management and till the end, beautiful applied clinical knowledge about even telling me the substitute of IVF and all. A wonderfully done applied clinical knowledge. I'll give you 2 by 2 on that. Wonderfully said that, you know, self-injectomy has a chance of even going to self-injectomy and then IVF is an option. So I was very happy on that. Even information gathering was very good. You picked up the PID thing, that was very good. 2 by 2 in information gathering as well. Patient safety went superb. Very good patient safety, not sending her back home, making her prepared of that. So that was beautifully done, Fawzia. Communication with the patient, I'll give you around 1.5 in that. Just because in the initial time, you were a little taken aback. I mean, you were...
I was scared also of you also, Dr. Sidra. I didn't know how to present. I was like very scared and timid.
Don't worry at all. Beautifully done. Believe me, you've got all the... And you know, I've written, I always make a box of strength in the end and I have to update in my notebook for you guys. So I've written that you have a very composed voice, Fawzia. You have a very solid voice that each word you speak clearly. And this thing, Ramya, you have to learn. Fawzia speaks each and every word clearly, one word, then going to the next and then moving to the next. So this is a very good composed voice. So this is your strength. We have to polish this strength to use it in our communication, Fawzia. And I'm very happy the way you presented the management plan and going with an empathy sidewise, that was very good. I'm sure polishing is there. I'm sure the things we have to improve together. But as a first station, it's a beautiful station, Fawzia. Job well done, okay? Despite only one domain, that too because it was a difficult, I was giving you a difficult time. I told you guys at the very starting that early pregnancy is an easy station. So if they put something in that to make it a little twisting, so we should be able to handle that. Okay. Yes, Dr. Sabiha, she has a very composed voice, having a control over herself and what she's speaking. So that is something wonderful. Okay. Now, to begin with, when I gave you a tough time and I was not explaining, you were taken aback on this, that good points, many are there about the introduction. Yeah, you asked about the fainting, you asked about the PID thing, the medical history, and I'm sorry about you've been passing through a lot. Smoking, alcohol, support, partner, the pregnancy undertaking, blood group, reservations, all these were perfect points, Fawzia. Examination, and then what impression you have, a beautiful description of self-injotomy, a beautiful description of weekly doing pregnancy hormone to follow up, to remove that. And my concerns are valid when I said that, how would I get pregnant? So beautiful acknowledgement, Fawzia. These are all things I teach. And when you absorb these things, I'm very happy that you are putting it into your presentation as well. Now, just about few jargons you have to avoid, like cardiac activity. You say that we can see that in the left side of the tube we have a pregnancy, and also the heart, the baby's heartbeat is beating. Yeah, its heartbeat can also be seen. So you say the heart is beating, or you say that we can see or appreciate the baby heart as well. So cardiac activity, cardiac is a jargon. You say the baby has the beating heart that can be seen on the ultrasound. All right, so this is one thing. This can be, yes, Jyoti. No, this is not ruptured because she's having mild discomfort. But she's hemodynamically stable at the moment. She can talk to you. Salpingotomy can be an option because the other tube is not there.
But
Other
then,
tube
there's a significant fluid in the pouch of Douglas. Doesn't that indicate that it's a rupture?
It can be a ruptured thing, but at this moment, she's stable. At time, the leakage of fluid can also be there. Hemodynamically stability can also tell you about this. So option of removal and saving the tube, both can be given. So either we are going to save that, if not possible. So what the line which Fawzia said, I totally agree with that. If not possible, we would be removing. So consent of both would be taken and surgeon is going to decide at that time that what are we going to do. So if possible, we are going to try our best to save the tube. If not possible, we will have to remove the tube. So this is a safe line when the patient is hemodynamically stable. Yes, if she's not stable, of course, the sure shot diagnosis is there that it's a ruptured ectopic. So then you can say that I'm afraid we won't be able to save the tube. So this is how you can take a diplomatic way of that, right? Now,
yeah, Dr. Sidra, actually we did this station in our practice group also.
Okay.
And we had this discussion whether we can offer salpingotomy or not. So then we had reached an agreement that because it has already ruptured, so it won't be possible to do a salpingotomy.
If Girija, it is a ruptured and it's a sure shot case from the scenario that it's ruptured, you say that that I'm afraid we won't be able to save the tube. So removal of the tube would be the option and then connecting her to the fertility center in the IVF thing. But if you think that in this case, there's a little ambiguity about the diagnosis and the blood pressure and the heart rate is absolutely normal and she's talking to you without any such sort of features which is given to you.
Yeah,
You
she's
say,
stable. The only point which goes towards rupture is the significant fluid.
yes, that's the only point. So you have to say at that point that the surgeons are going to try for best to save the tube at that point in time. However, if it's not possible, then I'm afraid that tube would have to be removed, and for that we'll connect you to the further fertility plans later for the test tube baby. So both the things mentioned in one go, because you're not performing that, you say the surgeons are going to decide best at the time of the surgery after looking at the state of the tube. It's not only Girija, Jyoti, because of this ruptured tube, only at times because she has a previous history of PID, the tube might not be healthy. So healthy tube should be saved and preserved. However, if during surgery they find that the tube is unhealthy, even then it is suggested to do salpingectomy because then you're putting a trigger of the future ectopic there.
It will be a future ectopic.
Yeah,
exactly. So the line which I would speak is that, Christina, since you've got only one tube, so the surgeons would try to save that tube and scoop out the pregnancy only. However, it depends on the state of the tube. If they find it being unhealthy, or if it's a ruptured ectopic, I'm afraid they'll have to remove the tube because then the chances of future ectopic are more in that tube. And then we are going to refer you to the fertility clinic for further plans of having a pregnancy. Would that be okay? So this is the safest line, Girija, Jyoti, to speak.
Yeah, okay. Thank you.
Can we tell her like this that because I can see there's a significant amount of fluid in your tummy, so
the chances are that the tube has been ruptured.
It's ruptured, and in that case we won't be able to save it.
If that is the case which is found during the surgery, I'm afraid then it won't be possible to save the tube, and the removal of the tube would be the best option for you. However, at this point in time, both the options are there, so the surgeons would decide the best at that time during the surgery. Right?
Dr. I have a doubt here. Yes. This lady has repeated ectopic now, so has it a bearing on the type of treatment? Like, because she said she had repeated ectopics now, so that means salpingotomy will be an option.
I would tell her that because there is a repeated history of ectopic and because it looks like that your tubes might have ruptured, the safest option for you would be to take out the tube and go for IVF.
If at all we find out that the tube is healthy, it's just continue with the same. If we find out that the tube is healthy or during the surgery, there's any chance of saving the tube, definitely it would be given priority, Christina. So that's it.
Yeah.
So this is your patient safety, that's it. Okay.
A big thing. And also I wanted to ask you was I forgot. Yeah, why would you say the surgeons would decide? Because it will be you who will be doing the surgery. Most
No,
probably.
it's not actually necessary that I would be doing the surgery. Maybe I'm looking her at emergency and the operation team is separate.
But it's not like that. When you are gynae on call, then if you have
So it depends actually. She is in the emergency. Maybe in the early pregnancy assessment she is, right? Okay.
Yes, it's called the gynae on call team.
Yeah. So maybe basically at the moment I'm just running with this clinic, you know. So I'll just admit and the other team would do that. So basically whosoever would be operating. Okay.
So actually, I mean, I'm not trying to argue. Actually, whenever there is an ectopic pregnancy, only the gynae on call team will see her.
That's fine. I'm not saying the general surgeon. I'm saying whosoever would be performing the surgery would be deciding at that time. Yeah. Gynecologist is going to do that. So the one who is performing the surgery, by surgeon I mean that, not only the general surgeon. I don't mean. Yeah.
Yeah, understood that.
Okay.
We call surgeons, but
yes.
But it will be only the gynae on call team who will be seeing the ectopic and operating on the ectopic.
Yes, absolutely agree. So what we are going to say to her is that at the time of the surgery, doctor would decide how the things are, and they're going to decide best for you at that moment. Okay. So this is the safest thing which we can say. All right.
Dr.
Yes, Dr.
Sidra, sorry,
Yes,
I am asking again.
Yes,
Here she had a repeated ectopic, now, so
Yes.
still can give her the option of salpingotomy because it's her wish, or like
It's on the right side, basically on the left side, it is the first time. On right side, she had twice.
Okay.
First
So-
was medical option done, and second was self-injectomy. So on the left side, it is first. So the only tube available is of the left side. That's it.
So we should give both options.
Both options. Yes.
Okay. Thank you.
Okay. Now,
so Dr. Sidra, I'm sorry,
Yes.
I have the same
Yes.
question. Like suppose a patient is stable and have a repeat ectopic. As in this case, this is a third ectopic. So shouldn't we talk to the patient that we have an option and we will try to salvage the tube. But even if you salvage the tube, there is risk that you might have another ectopic
Yes.
with the same tube.
Yes.
So is
This
there
is what
any of your
this is what
preference?
Dr. Fawzia. This is what Dr. Fawzia told me, that there are chances. So for that we have to check for even after doing this procedure. Even then there are chances that we have to take the decision of removal of the tube even later, because at times there's a persistent pregnancy tissue there for which we are going to do that weekly pregnancy hormone, right? So that was a correct thing which she said, that it's my choice to choose that either it is going to be removal of the tube or it's going to be saving the tube. Okay, so we should give her this risk that it's going to be a future ectopic, but at the same time, as per the guideline, saving is always, if it is healthy, it is always better, right? And then going to the IVF if removal is there. So give both the options if the patient is stable, and if it's a ruptured ectopic, of course, self-injectomy is the choice. Or if it's a diseased tube or it's an unhealthy tube, so you are talking in the clinic at the moment, right? Then basically she should be knowing about both the things, that both options would be there. So doctors would be decide at the time of the surgery how the tube looks like. Is there any chance to save the tube? So only scoop out the pregnancy. If not, removal would be done, and then we'll connect you to the IVF center. Okay?
Okay, fine.
All right. Thank you very much. Okay. So about the initial part, when she was weeping, you simply say, I can understand, Christina, that you've been through a difficult time. Do you want me to give you a little time? I can get back to you and then we can talk about this. So this is the right way of making her stop weeping, Fawzia, because she knows it's an exam. Indirectly, you're telling her that please don't waste my much time. I have to move forward. I've got only 10 minutes. So give her a little thing like, you know, a feeling. I can understand that you're upset. Would you like some support from my side? I can call nurse to be with you. I can talk to you in a while. Would that be okay? Do you need a little time, Christina?
She won't be offended, Dr. Sidra, that I'm leaving her, like, you know.
No. You're not
maybe
leaving
she wants
her
me to
for this,
comfort
that
her.
consultation.
Okay.
You're going to give her support. You're not leaving her. You're going to provide her support. So about the consultation, you say, we can carry on the consultation in a while. Okay. So you say that we'll carry out the consultation in a while. Immediately she'll wipe off the tears because you're giving her a clue that please, this is an exam. She would say, no, doctor, I'm better. Please ask questions.
Okay, clear.
So this is indirect way of dealing with the role player. Okay. And along with that, the initial part, when you asked about the name and I started crying. So you forgot the age. So patient safety is when she gets better. So you have to come back to that. So Christina, may I confirm you're 25 years? So go through the recording. You'll understand that in that, fix of me crying and you settling that, you forgot the age thing, and it's fine.
I remembered, but I thought she would say, what do you want to do with my age? I was so scared to ask her. I left it. I thought, okay.
Okay.
Yeah.
So
Okay.
before we
I
move
will ask
forward,
next
Christina,
time.
yeah, how are you going to say that? Because it's patient safety, right? So Christina, before we move forward, just to confirm, you're 25 years. All right. So just ask in a very empathetic way. Okay. All right. So then one more thing which I've written is that when I said that it's okay, doctor, so you immediately started asking, can I ask more about the pregnancy? So then you can simply say, so do you feel better, Christina? Can I proceed with a consultation? So again, when you say one sentence, it is seeking permission to talk to such a patient. If she says yes, so she's giving you permission herself. Okay, so these are 2-3 things which I've written. So practice a little above first 2-3 parts of a weeping patient. And I think Ramya can really act well with the weeping patient. Ramya, am I right? You were being appreciated by, yeah, so do that with the Fawzia. And Fawzia, first 2-3 lines I need again on a voice note.
Yes, doctor.
Okay, right? So first 2-3 lines do again for me so that I can see that you're now coming with the flow. So no need to be fearful. The same tone which you had in the later part of the station should be at the top as well. All right. So speaking these lines which I've told you, and send me a 2-3 minutes voice note only, just for the top part when you have to settle her weeping and move to the consultation. Okay. All right. Thank you. So other than that, do you have any questions? Let's see with the communication with the patient and relative. I was very happy with your communication and a solid composed voice, and a few jargons we have to avoid, like cardiac. We have to avoid embryo. You say that the sperm and the egg, they meet up and they form the baby, which gets attached inside the womb. So because she had a very good understanding of ectopic, so very well done. You didn't explain the ectopic to waste your time, so it was fine because she knows what ectopic is. Communication with the patient and the relatives went fine. You were not giving me any false reassurance. Clearly, you were telling me about future risk of ectopic pregnancy. That was very good. Information gathering was good. I passed you in information gathering, Fawzia, a wonderfully done information gathering. And the patient safety was good as well. I was happy with the plan about salpingotomy or versus salpingectomy because you gave me an IVF option. So I had another horizon to think about rather than saying, okay, so it's going to end up my life. You say that we have 3 options in this case, which is expectant, medical, and surgical. Now, see, the surgical option is the desired option, but you have to speak up for your applied clinical knowledge. Like Christina, generally in the ectopic, we have 3 options. One is when the nature takes its course. Then we have giving medicines option, and then we have the surgery. As we can see the baby heartbeat on the ultrasound, therefore the first 2 options are not suitable in your condition. Therefore, we are left with the surgical option. And then the surgical option, you will write in explanation. Am I clear? Yeah. So naming expectant and medical is your applied clinical knowledge, Fawzia. And note, choosing it is your applied clinical knowledge, my dear. So don't only give the the desired treatment plan for the patient. Give her the all options and say that why doesn't the other suit her? So mentioning expectant medical is important. And then about surgical, telling it that because we can see the baby heartbeat, therefore the surgery suits you best. And now we have 2 options in the surgery. Right? Okay. So this is how you're going to go with your applied clinical knowledge. Ectopic pregnancy is there. Tell her about the nature takes its course or the medical management with the injection. However, in your condition, as the baby heartbeat can be seen, therefore it suits you best. And we can save the tube if it is healthy, or if the doctor at the time of the surgery think that it is better for you. However, with this, the weekly pregnancy hormone would be done, and there are chances that there's some persistent pregnancy tissue found in the tube. For that, in future, we might have to remove the tube, and again, we have to give some injection as well. The other option is that if at that time the tube is not healthy, or if we find that it's already ruptured and the bleeding is there, at that point, the doctors might take a decision of removal of the tube. And for that, we will connect you to the fertility clinic, the options of the test tube baby or having the hiring of a womb and surrogacy or adoption is also there. So whatever you will decide for yourself, we'll give you support for that and refer to the fertility center. Okay, so this is going to be the future option for her. If we just divide it: introduction, agenda, quick focused information gathering, counseling regarding options, offering support, management of the ectopic pregnancy, her future plan. If she's fine now, you can give her reading material. If you think that's an emergency situation and she's really unwell, it's fine even if you skip that. So actually judge the condition of the patient and then speak up about the information leaflet. Very well done, Fauzia. Patient safety, absolutely pass. Applied clinical knowledge, pass. Information gathering is pass. Communication with the patient, just improve a little. Emergency or a patient who is a little loud and very sorrowful. So that part, just improve that. Your communication with the patient otherwise is very good. So just work on this so that this one station goes confidently past station. Very well done, my dear. Very well done. Okay, so any question regarding this station? Yes. Done. Okay, it can be both, Abir. If she's hemodynamically stable, you say that your blood pressure, Abir, you say that your blood pressure is fine and the heart rate, blood pressure, the heart rate is normal. We can go through the keyhole surgery as well. However, if we find out that the blood pressure is falling and the heart rate is rising, we will plan for the open surgery for you. Okay, Abir? All right, so that depends upon the hemodynamic status. Stable patient can go with the keyhole surgery, sweetheart. And if you say that the blood pressure is falling or the heart rate is rising, we would decide for the open surgery for you. So this is going to be the line, the safe line for exam. Okay, well done. Well done. Right. So let's do with the antenatal care basic template. So before that, please tell me, Harshiba was saying the other day, or you all were writing that antenatal care, you want a little time to prepare. Next plan was Friday. So if you people a little time to prepare this module, let me know that how much time do you require so that we can post that.
Yes, ma'am, we can do it in 10 to 12 days if everybody is okay with it.
Okay, okay. So 10 days? 10 days.
That's fine.
So then it won't be Friday, Saturday. It's fine. Any working day?
Please, Dr. Sidra, if you can do the session of Friday, because almost of the days in next week we are involved in duties, if you can.
So Abir, how about then skipping this Friday, the next Friday? Would that be okay with all of you?
Is this okay?
That would be more better.
So you people want to have your sleeping nights, huh? That you people are going to get 14 days. And would I see that the mini groups are silent? Yeah? That you people are getting 14 days to prepare. So that's going to be, if I calculate from today is 18th, right? So it's going to be 31st.
Dr. Sidra, then in that way, we cannot finish all the modules on time. Is that so?
No, maternal medicine and antenatal care, they wanted to take 2 weeks time to prepare because they wanted to prepare, I think, all topics rather than the 7 topics which I give. So it's up to you guys.
So you are giving ANC and maternal medicine both together for 2 weeks, then it's okay.
Are you people going to take all or only antenatal care? Both?
No, ma'am, only one at a time. But if it is a problem, then if everybody is not on board with it, then it's okay. We can we'll manage it in 1 week, I guess. But I just felt that we would need to do a lot more different varieties of cases, so more time to prepare would be better. But if duties are a problem, then yeah, it's fine. We can do it in a week as well. It's okay.
Okay. So there's 2 things, either doing on next Friday, or if you people want, it can be next Saturday as well. So then it can be, if you want Monday, Tuesday, Wednesdays, I don't have any problem with anything. So you settle that in the main group, then I will decide that, okay? So come to a conclusion that...
Yes, I have one suggestion, Dr. Sidra.
Yes, please.
Actually, I think I don't know, maybe maybe others' opinion will differ. If we have 2 sessions for ANC and maternal medicine, both, then I think we can cover all the stations. I don't know why, am I right or not?
I didn't get you, Dr. Sabia.
I mean, like if we have 2 sessions for ANC during 1 week.
Yes, ANC is 1 week and maternal medicine is next week.
No,
After 1
sessions.
week,
Your
yes.
sessions. Two of your sessions.
Yes, yes. One was expected to be this Friday and next was next Saturday.
Dr.
No, you
Sidra,
did not get
can we meet like next week for 4 stations and the next week later for another 3 or 4 stations? Will that be okay? So that we get 2 weeks to prepare the module, but it will be in parts, if that is possible for you.
Okay, I don't have any issue. Even if we do, do 8 stations in the one go after 2 weeks, if you people want to take time, I don't have any problem, because at the time you people feel the date is not announced as well. That's what you people want, that antenatal care gets prepared. Okay, so what we can do is that I'll just post in the study group, whatever you decide, the maximum people decide, we'll go accordingly, right? Okay, so give me your plan, that what date you people decide, and I'll give 1 or 2 options there. So according to that, you people can decide, finalize, and then we can do the antenatal care module. The antenatal care.
Sorry.
Yes, you wanted to say something, please. Yeah.
Yeah, also all the working days are not suitable because many of us are working. So like
that's why in the beginning, when we had introduction, do you people remember that we decided for the Fridays and the Saturdays, so half Friday and half Saturday. So Fridays are off for half of you and Saturdays are off for half of you, right?
Yeah, that's fair. But like if it is every Friday, then I would be missing most of the classes.
No. That's why I'm saying one is Friday and one is Saturday, Jyoti.
Yeah,
right? Because Fridays are off for half and Saturdays off for half. So that's why Friday and Saturday is better. So what we can do is that we can do the Friday, next Friday, antenatal care. I'll give you 8 topics to prepare. These 8 topics you can prepare. And once we'll come to the books, we'll come back to the antenatal care again. So concentrate on the 8 topics, which are the exam-based topics. I'll also post the important topics, but the syllabus topic of mine, which I've given, you can go to the antenatal care again in revision of the books. So come back to antenatal care. Okay, so come back to antenatal care and maternal medicine, take those topics in the syllabus which is done, and once you come back with the books on the antenatal care, then do the rest over, because at least your basic idea of the antenatal care would be done. All right? Okay.
Yeah,
so
that sounds good, Dr. Sidra.
Okay, fine. So because we cannot complete in one go and giving 2 weeks, you can do half, at least your knowledge of the antenatal care would be done. So then after Friday, next Saturday, we'll have the maternal medicine. Again, do the exam stations and get back when the books would be done, come back to all the book station again for a second go of maternal medicine. So this would be a wise idea to do that. All right?
I have one request, Dr. Sidra, I have one request.
Please.
Because next Friday, if it can be next Saturday, it will be okay, good for me. Otherwise, can it be little late?
For me too. And we get more full 1 week then. Otherwise, we get only 6 days.
I don't have any problem, Dr. Sabia. I'll just confirm me, please. Dr. Atiya is presenting on Friday or not? Confirm from the list, please.
Yes, inshallah.
Dr. Atiya, did you confirm? A1 is there?
Ji, bilkul. Yes, I am Atiya.
No. Dr. Atiya, in the list, are you there for the next week? This is what I'm saying to confirm from the list.
Oh, acha.
Okay, so let's do with the antenatal care based template. Dr. Sabiha, till then, please confirm me that she's there in the next. If she is on Friday, then actually she requested for being on Friday because she's a presenter. Otherwise, we can shift on Saturday as well.
Okay, I will talk to her and I will let you
yeah,
know.
let me know, then I'll post that. I knew this, Pallavi, first as well, that when we'll do one Friday and one Saturday, my dear, for once you'll get 5 days and for the other you'll get 7 days. So this would happen. I knew that earlier. So I'm flexible. It's actually you guys who are going to decide. So if Dr. Atiya, you can manage one station any other day as well, like today you listen to the session as well. If you can manage on Saturday doing one station as per your ease, starting from the beginning or in the end, anywhere you're available during your...
This time I could be the last, then on Saturday, the last presenter. Because it's 11 in my country, na? So my duty offs by 9:30.
So I can keep you, if it is Saturday, I can keep you the last, huh?
The last one, yeah.
I understand, Dr. Atiya. Thank you very much for the cooperation. So we can keep on Saturday, guys. It's okay, right? Done? So we'll keep on Saturday. Whenever Dr. Atiya is there, she has a problem in presenting. But okay, Abir is also there. Abir, what about the Saturday? Abir, you're also presenting in the next station.
It's okay, doctor. I try, inshallah. I try to manage.
Thank you, sweetheart. Abhi, tell me the sequence wheresoever you want in 1, 2, 3, 4, 5, 6, 7, 8. I'll put you there, whatever time suits you. Either the first one if you want to do that, or the last one, second last one before Dr. Athiya. Okay? Just let me know.
Inshallah, inshallah.
Thank you very much. Thank you. So let's see what antenatal care we have to do for this 1 week, friends. So introduction, agenda, and the history of presenting illness we have to go with. Do ask, is it the first pregnancy? Is it a planned pregnancy? Do congratulate. But if you think that it's something like which requires the termination of pregnancy, go with something like not congratulating. Don't make a mistake in this case, okay? How is the pregnancy going so far? Are you taking folic acid? What is your blood group? It's a patient safety in pregnant patient. Please don't miss that. Have you been booked to the midwife and your dating scan, the labs, the down screening done? And do you know the results? Tell me about your previous pregnancy, how were they born, and how is your recovery? Smear history, you can skip up in pregnancy. Only in high-risk patients like HIV positive or a renal transplant, go with that. Now, this medical condition, in antenatal care, all the questions regarding the medical problems will go here in the HOPI if she's having a medical problem. So first would be regarding the history, and second would be regarding the medical problem. And then you go to the obstetric history. If it's no medical problem, then fine. You just ask one question. May I know that you see your GP regularly for something? That's it. Okay, that's it. Then you go with your family history, surgical, drugs, personal history, the social, mental, and the management plan. Now this management plan, friends, has to be, like I was telling Ramya, the antepartum, interpartum, and postpartum. Please don't speak these words. You're going to say that, Christina, I'm going to take you through your pregnancy journey and start going with that. Please start with a team of doctors care from the very beginning of antenatal care. Please note down these points because these are hot winning points for the examiner. Then during the labor, don't say intrapartum, during the labor, and then you have to say a signpost that after the birth. So take out from your dictionary, friends, intra, anti, post, anything like that, you have to take out from your dictionary. Try to say that in a very easy language which can be absorbed better by the patient. So during your pregnancy journey, during your labor, after the birth, so just speak in this manner, take like a story, but students make a mistake. They end up on breastfeeding and the canceling regarding the contraception, and the station ends. If she's at 7 weeks, please come back to 7 weeks. And if you see my templates, one-to-one templates, if you see that, you'll always find in the end. So coming back to today. So this was my pet way of handling a patient in an exam. Coming back to today. So for today, you have to do this, 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 right? So always come back to today. This is a beautiful explanation and ending of a station. So don't end up a 7-weeker or a 23-weeker or some 28-weeker into breastfeeding and contraception plan. You say, for today, we have to do this, 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 and next appointment. Am I clear about the ending of antenatal care, please? Am I clear that how you're going to take the station forward and come back to today before ending? Why am I emphasizing? Because I want that in the end, I see the difference in your presentation, right? And you address the patient's concern, if at all they're left, and you give a closure, give information leaflet, and ask her for the follow-up as well, right? Okay, thank you very much. Now this time, the group performance went well. So my last 1 week words, they did matter. About the group A, Dr. Athiya is back here. This week, first 2 days were a little less participation, but I've skipped up the day for the homework. I've not taken that day for the repetition of this, the revision of this session, right? I've done that afterwards. I've started the grading. So probably there was some sort of commitment going on. I understand, but I would respect that even if you're not presenting, please try and be active and improve the things, because see, none of your week should go wasted. All right. So first few days, but in the end, from 14, 15, 16, and 17, believe me, till 4 a.m. There was one day when Dr. Rahma and Dr. Sabiha and Dr. Sarwar, it was like, I think it was around midnight GMT that they were practicing. And I messaged Dr. Sabiha that you're not about to sleep today. And I knew that this week Dr. Sabiha is having a station So she's on toes like anything, gathering everyone, originating the Zoom meetings, and please, everyone, please come into discussion. So that was very good. The last 2-3 days, and even today in the morning, they had a practice, and I was smiling on this that, you know, till the evening, I know they're going to be on throttle. Very well done. Group B, there was a little disturbance between people coming in and coming out because of some domestic commitments, but I'm very happy, Dalia. Very well done. You're taking the lead, and I'm very happy with Nadra. Nadra, I listened to your voice for the as a role player, and let me tell you that you've got all the chances to pass this exam. You've got a very composed and a very beautiful, empathetic voice, a very controlled voice, Nadra. So I'm very happy. Keep on going in this manner, my dear. Lead, take the lead. And Midhat, thank you very much for joining in. And now, yes, I'm really happy with that, and I'm sure you're going to do great. The way you ask the questions and you go in the deep question, minute points. And similarly, Dua, as she presented today, Dua, you are going to pass this exam. Just go in this direction. And Midhat has left, or he's still here. And Shaheen, I would just make a tiny suggestion, my dear. Just follow the group meetings and try to make your templates. So give tasks to Shaheen as well, Nadra and Dalia, so that she can also contribute and she starts speaking in the mini group meetings. All right. She's going to be active participant for the next group, but she requested to start earlier because she didn't want to waste this time. So I'm going to take, she would be going to the active participation in the next batch of mine, but at the moment she just wanted to join in as a listener to give a little start to her practice. So then I'll shift her to the next batch for the active participation, okay? So keep going, my dear. Thank you, Shaheen. Yes, the group C, lots of Skype going on and lots of recording going on. I talked to Khanda the other day as well. She was a little busy. I can understand she goes with the recording, but otherwise she is, you all are really practicing well, Girija, and Jyoti, you, even Dr. Sujata, you people are trying to take each other together, and improvement is definitely there, right? And very well done. All days were perfect. From day one, you start practicing and it goes perfectly all right. But still, I have to say that batch D is going ideal. They don't leave a minute point to discuss, like you saw in Dr. Bindu's discussion, like you saw whenever Harshiba presents. They discuss each and every aspect. They open up all the PILs and they open up all the references in front of them, and they beautifully discuss between themselves, and I can see that they have this energy and they have this enthusiasm that we have to make this happen. They see me working hard, and in return, they give definitely a lots of hard work. What I'm going to say is that we all have to keep going. We would definitely make it happen, my dear. The only request is, see, there are lots of things going on. I can understand lots of domestic commitments, lots of hospital routine, being busy. But at the end of the day, if we just make this exam happen in this go, it's only we are going to step forward. We can take care of our kids. We can take care of our household chores. We can take care of our other routines. But unfortunately, when one exam that gets stuck up, your confidence gets lowered down. I just want that we make it happen in this go. I am going to give my 100%, but in return, I require you to 100%. See, I can give you lines, but you have to speak it. I can give you coaching of minute things. Like, ask about myself. I do not solve stations anywhere. None of the mentors solves each and every station on slide. But when I take time, I spend 2 to 3 hours for each station to solve them for you guys. Why do I do that? Because I want to give everything in platter, but in return, it's going to be you practicing again and again, right? It's going to be your flow again and again. I would make everything easy for you guys, but at the same time, would require that you people do everything in this manner as well, because we have to move forward in life. We've got many things to do as well, right? So do you people agree? Yes, do you people agree?
Yes, we agree, Dr. Sidra.
Thank you very much. So I would like to see a change every day, that we move forward and we improve from other students. We have lots of competition amongst yourself. You can see the competition. So think about the entire MRCOT 3 students are pairing. So we have to be at a level that we compete with them and we are better than all. All right. Thank you very much, all of you. So take very good care of yourself. So we have come to the mutual agreement that it's going to be Saturday. Am I right? Yeah? So the final decision is Saturday, Dr. Sabia, yeah? Girija, Bindu? Okay, fine. So I'm going to post the topics for Saturday. Thank you very much, Harshipa. That's very important. This energy which I inculcate is very important because see, I've been through these times and I know that with kids, with the domestic issues, with your families, it is very difficult. So we have to give our 100% and just pass it in these months' time so that we don't have to just pick up the books again and again. Okay, so we move forward and do all other important things that you have to do in life. All right, thank you very much. Sidra ma'am loves you all. Take very good care. Stay in touch with me and keep telling me about the progress. Send me voice notes whenever you think that you people are stuck up. All right, lots of love from my side. Please take very good care of yourself. Thank you very much, Liana. I still remember the part 2 journey. I will definitely give the continuous support and you'll find me till your examination hall. In fact, even later in life, even the people who have done MRCOG, they still message me for certain things. And I always reply to them with the same love and with the same care because you people are like my family and very close to my heart. Thank you very much. Take very good care of yourself, please. Have a good dinner and sleep tight. A good night from my side. See you all on Saturday, inshallah. Thank you. Bye-bye from my side. Bye-bye. Thank you.